workforce, standardize the type of training that people who function in a CNA capacity will receive, and this will benefit many areas of rural Connecticut. The second part that we would like to change and expand in terms of this particular statute is that one of the programs we are looking to do is an incentive program to have practitioners stay and practice in rural areas of Connecticut for 5 years. They will each receive an incentive at the beginning of each 5-year period, so of each year of the 5-year period. However, currently, we would have no other way of holding that particular practitioner accountable should they leave the rural area before the 5 years has terminated. And so we are looking for expanded authority to take potentially an action on the license of a physician who may choose to leave before their time period of commitment has completed. The third part of this program that we would like to amend is specifically an opportunity to contract with our tribal nations in Connecticut. We have several programs, one that includes mobile health vans that will be going throughout the state. And we have a specific carve out to provide specific services to our tribal nations and for them to be able to contract to be able to work in this capacity. So the third part is to be able to allow us specifically to engage with the tribal nations in this regard. The last part is the EMS compact. What this particular provision allows for is that only if a neighboring state enters the EMS compact, at that point, Connecticut will evaluate and will look into joining the EMS compact as well. Currently, the only states around us that are involved in the EMS compact are Delaware and Pennsylvania. This allows us also additional time to identify ways that we would be able to partner with neighboring states should we even end up in a situation where neighboring states end up entering the EMS compact, because each of us have different types of EMS providers, and we would need to closely look at scope of practice should we be in a situation where we enter this compact. So with that summary, I will conclude and I'm happy to take questions. Thank you.
Thank you very much, Commissioner. And Commissioner, we will be mindful of your time and the fact that we can certainly have follow-up conversations and will be having follow-up conversations with you, and that we have others here from DPH. Senator Anwar.
Thank you so much, Commissioner Jotani, for your testimony. Commissioner Jotani, this rural health support that and the program that we are working on, this is a 5-year plus program, and this is going to hopefully change opportunities in healthcare in our rural part of our states. The question is, I think it would be worthy to have a broader conversation with the Public Health Committee and spend more time, because the time that we have today will not do justice to what I think the Public Health Committee members and perhaps the people in our state would want to hear. So we would love to hear the vision, love to hear what can be done, and perhaps there's an opportunity to put the collective wisdom in the picture as well for many of our members and the people at large. So would you be open to that option after your travels?
Absolutely. Happy to have further discussions on this. As I mentioned, I also want to just highlight, I believe that there was an overview session about the entire grant. DPH only has about 30 million of the 154 million in year one, and I'm sure the full administration would be happy with the 12 agencies to provide a broader view. And I know that this has been done already, but we are more than happy to do that. And certainly on the DPH component, we're happy to have that conversation.
Thank you so much. And I also know that we will seek your insight because of the time limitations. We won't be able to have a conversation or a robust conversation on the various other bills at this time. I know your office and you have weighed in on some of them. Is there any bill that you would like to speak of that you've not been able to touch on right now?
I think we have submitted written testimony on the other bills for which we have comment, and would defer to those written comments unless you have a specific question that you'd like to ask me.
No, I've seen some of your comments, so I do not have any specific question right now. But I think we'll need to have more conversations in depth, and I know your time is limited. You have to catch a flight, and before the flight, you have to be in New York, which is more painful than any flight. So, safe travels. Thank you.
Thank you, Senator Anwar. Representative Dauphiné.
Thank you, Madam Chair, and thank you for being here today. I have a couple of questions on some of the things you said. You talked about the Nurses Aid Program and the idea of expanding it, and I thought that was a great idea. I wondered, do you think that this is going to change the wages that they're paid? I mean, right now, I'm not sure what the current rate is, but do you anticipate?
Rep. Dauphiné. Rep. Dauphiné.
Yes?
Can you turn your microphone off for a minute? I think we're having some microphone issues, and then it's not just you, and not sure what happened. So we are just going to take a moment to recess the hearing. Commissioner, we're very sorry we're having some technical issues. Can folks hear me okay on the microphone at this point?
I can hear you at this point, and I heard half of her question.
No. We are having some technical issues, so we are going to recess and determine if we can fix those technical issues. So bear with us today.
Check, check, check.
Just testing. There we go. Commissioner Jutani, can you speak to see if we can hear you?
I can hear you.
Wonderful. I want to thank all of the technical wizards who were able to fix this so quickly. So in just a few seconds, we will reconvene our public hearing. So we are reconvening our public hearing. Commissioner, thank you for your patience. Members of the public, thank you for your patience. We're back. Representative Dauphiné, you have the floor.
Thank you, Madam Chair, and thank you, Commissioner, for being here today. I was referring to the nurses' aid training that you were talking about and the expansion of that, and I wondered if you anticipated a change in wages with regard to that, with the change in their maybe capacity or training and what they can do. If you could, provide that information, that would be great.
Thank you. So I would not be able to fully comment specifically on salary and wages. What I can say, though, is that currently there are many people who undergo what would be considered CNA training, but then may work in areas where they have not taken practicum training in those specific areas. As I mentioned, assisted living, home hospice, other type facilities. So I do think we will have a more qualified workforce to work in a broader area of facilities than just the training that nursing home training provides.
Thank you for that answer. I know in my own nursing experience, a lot of places, in particular with the shortage, will provide training. Has that been your experience? They will actually provide on-the-job training?
Yes, I believe that that is what many facilities would say, is that they would like people to come in with the nursing home training, but then they would provide additional training on site. One of the advantages of this is that people would come in immediately on the job with the type of experience and training that might be able to be cross-sectional and work in multiple different areas. And it also would then give us the ability as a department, if somebody is not practicing within what they really should be, that we have some disciplinary authority. Right now, if something happens to a patient in assisted living, in hospice, we have no authority to do anything in that sort of situation. And this now would give us expanded authority as well.
Thank you. So would you anticipate that be part of the training right now? I can't, I think their training is about, correct me if I'm wrong, 3 months. Are you seeing that as part of that training, that scope of practice training?
At this point, I do believe that it would be within what the current training is, but that would still need to be further developed out. And so I think we need to look at closely, if we expand it, would there need to be any changes in terms of duration of training or not?
Thank you. Thank you for that answer. And my next question would be, if I might, I just want to be sure I'm okay to ask a few questions. Is that okay, Madam Chair?
Yes, if you
Okay.
could just keep them brief.
Okay, I'll
so
try
we
to keep
can
them
see
as
if
brief as I
others
can.
have
Regarding the
questions.
Native American mobile health, I was just curious, do they not have any access to health care right now? Could you speak?
Each of the tribes has healthcare access, but part of the grant proposal that was put forward was specifically to be able to provide tribal access. And that was part of what was asked for as well from the federal government, is specific areas that we would be working with various different groups. So this was responsive and part of the proposal that was put forward and then approved by HHS.
Thank you. I appreciate that answer. And I think lastly would be the participating EMS compact, which I'm kind of unfamiliar with. You said Delaware and Pennsylvania only participate right now. Can you just describe what that compact does or doesn't do right now in the states that you're advocating to join in?
So at this point, there are more than just Delaware and Pennsylvania. I believe that there are approximately 25 states that participate in the EMS compact. And we currently participate in the physician, nurse, and psychologist compact, which the Rural Health Transformation Program saw as an advantage to the state of Connecticut. And they were also offering additional funding in terms of rural health dollars should we join the EMS compact. We chose to only put forward in this bill that we would only choose to join if surrounding states participated, because like these compacts in the other ones that we currently participate in allow, is that if you have a compact license, you have the ability to work in other states that also have a compact license. For EMS providers, this would really only be most useful for contiguous states where you are potentially crossing state lines every day. For other types of providers, for example, providing behavioral health types of consultation or other physicians that might provide telehealth, you could potentially be in states that are far removed from us, but that is not practical from an EMS standpoint. And that is part of the reason why this is in the bill, is that if we do want to consider getting additional funding from the federal government, this would be an opportunity. And it would also require, though, that our other states around us have that capability so that we are really collaborating with sister states in the region.
Thank you so much for that answer. So this is specific to licensure. Is that correct?
Correct. That's correct.
Thank you so much. I hope you have a great trip.
Thank you so much.
Thank you very much, Senator Gordon.
Thank you, Madam Chair, and I'll keep my remarks brief, and Commissioner, and follow up with you at a later point in time, being mindful that you're trying to catch a plane, so I wish you a safe travel. I have two quick questions about Senate Bill 93 relative to Department of Public Health. I appreciate wanting to find incentive programs to get healthcare professionals into rural parts of the state. I practiced for many years in a rural part of the state and represent a rural part of the state. So, and it's something that I have been advocating for, so I appreciate that very much. My question is, one thing to try to get people to come and work in a rural part of the state, is there any effort being looked into as far as also trying to get those areas, for example, primary care, behavioral mental health, additionally, which can be tough in and of itself to get people sometimes to come to Connecticut, especially into a rural part? Or is it just more in general trying to get people, healthcare professionals, to practice in rural parts of the state?
The particular program that we've outlined in this bill is specifically to get providers to work in rural health areas and specifically give us the stick component of holding people to that commitment. However, in addition to that, a program that we do not have in this bill because we already have the authority, we have the ability to contract for such work, is the mobile health vans that would be providing physical care, dental care in rural areas of the state. So I do believe that we are looking to also expand providing care in these areas, not only providers, but both should accomplish that goal.
No, I appreciate that, and I'm more than happy to talk with you further. I know your time is limited today, and I welcome that opportunity very much, looking at the rural part of the state. And I'm glad Connecticut applied and got from the federal government its application approved. I think it's a good step forward. And one quick follow-up, is this being looked at in any way relative to the rural health funding to see what we can do to restore services that some of the big hospitals have cut, such as inpatient labor and delivery, which, if we're looking to help rural parts of the state, that's an extremely important part. I can tell you in Northeast Connecticut, there's only one hospital that has it. Otherwise, you cross the border and go to some other places, such as Worcester. So I don't know if that's being considered as well, or is that something to be determined?
I do believe that the programs that we have put forward certainly could address part of that. I can't speak more broadly. As I mentioned, that there are 11 different agencies that are putting forward different programs, both from a policy standpoint and operationally in different areas of the state. So there may be other programs that some of my fellow commissioners may be able to comment on specifically to that question. But I do think the two programs I mentioned, at least here today, should hopefully address some of those areas that you highlighted.
Thank you, and again, I'll follow up offline with that. And one last question, maybe I missed it trying to scroll through lots of testimony and read through it. Does the department have any testimony it's provided today in writing on Senate Bill 195, or is it planning not to submit any testimony?
And 195, I'm just refreshing my memory. No, we have not submitted any testimony. I would say that there are no changes to federal laws at this time. I defer to my colleagues at Demas and DESPE in terms of the actual operational execution of those types of programs. And what I would say is that our position has not changed at this time.
Thank you, and thank you, Madam Chair.
Thank you very much, Senator Gordon. Senator Elmore for the second time.
Thank you so much. Madam Commissioner, just wanted to ask you about Senate Bill 193, which is establishing a licensure for long-term acute care hospitals.
Yes.
We've had this conversation in the past. This is having a major impact on an important hospital, actually two hospitals in our state. We have two LTACs that are federally classified as LTACs. Gaylord is providing acute care. And because of our licensure restriction in the state of Connecticut, it's having sustainability concerns and issues. What can be done to go beyond these technicalities to be able to address this so that we are able to have the hospitals be federally licensed, just like the federal licensure is, but also the state would be at the same place? And I know your testimony suggested it's going to be technically difficult. I'm trying to see what can be done to address this, because this is a second session of this conversation.
Yes, I understand. And I think I want to just be clear where our concerns lie. So the LTACs have the ability to have the designation of an LTAC, which they currently do for billing purposes from CMS. At the state level, by creating a new licensure category, it can be done, but I do believe that the statute that would specifically allow for fingerprinting and the safety measures that we have for other types of patients that are in long-term care, where we have providers undergoing that standard of fingerprinting because they have long-term access and care with a given patient. By creating another category that doesn't currently fall under that, we would be removing that protection from patients. And that is one of the concerns. We would need to create a new licensure category that is certainly going to require some effort and time on the part of the department. And at this point, for us, we do not see what the benefit to patients is by creating this category, especially with the risk of losing the potential oversight that fingerprinting currently provides. But we are happy to continue this conversation and see where our discussions can lead.
I think other states have not had as much of a difficulty doing this. So I'm going to be interested to see why other states can do this and why the state of Connecticut is having so many challenges. Is it because of your budgetary restrictions, your personnel issues?
I believe this is slightly larger than that. So when I say it needs to be a new licensure category, that certainly would be part of it. It would need to be a whole new regulatory framework that needs to be set up for a different type of class. Currently, they are in a specific class of type of chronic hospital, chronic disease hospital. A different type of category would need to be set up. We need to change the statutes that currently allow us for fingerprinting in the current type of classification. So these are things that could be done, but I believe that we need to think critically about just creating a category of LTAC without making sure that LTAC patients get the same kind of protections that other types of patients who are in long-term care types of settings receive.
Okay, so I'm sure we'll have more conversation on this. My last question is on 195. I know while you have not testified and you have opined on this, I would invite you to, by today, and then perhaps your team can actually read every single testimony, but also listen to the testimonies of the people who come here, and also see the legalities from other professors and experts on this, and also see how other states have been able to achieve success. So perhaps that would be another thing we can learn from other states who have been able to achieve some success on this.
I understand. Thank you.
Thank you. Thank you. Back to you, Madam Chair.
Thank you, Senator Anwar. Seeing no other questions, I think we have hit it on the nose for you, Commissioner. And
Thank you very much. I do have my colleagues there if there are additional questions that you would like to ask of them. Otherwise, I'm happy to meet with you offline to have continued conversations. Thank you for the opportunity.
Commissioner. And I was going to say, I know that we will be spending time together in conversation about these bills and many others. So we appreciate your work and we appreciate your colleagues, Deputy Commissioner, Ms. Miller, for being here with us today as well. Thank you.
Thank you.
Next we have online, I believe, Calvin Bonner. I hope I said your last name right. Welcome. Please proceed.
You did. That was perfect. Thank you. Hello, co-chairs, Senator Anwar, Representative McCarthy-Vahey, distinguished members of the Public Health Committee. My name is Calvin Bonner. Thank you for the opportunity to testify today in support of Senate Bill 195. I'm a third-year medical student at the Netter School of Medicine at Quinnipiac University, currently doing my capstone research in opioid use disorder and its management in hospitals. I'm sure that there will be many powerful testimonies today about individual stories, but what I would like to speak about is the pattern of inadequate care and missed opportunities that too frequently end in overdose and death. As part of our research, our team has gone through well over 1,000 individual patient encounters, and I can't express how common the following narrative is. You have someone with opioid use disorder, OUD, comes to the ED for a wound check or illness, or just simply because they want to stop using. For whatever reasons that's bringing them in, they're here, they're looking for help, It's a busy day in the ED. They have to wait a few hours in a crowded hall before they can talk to someone. They may have already been experiencing some early withdrawal symptoms when they came in, but now their pain and anxiety is getting worse. Maybe after a few hours, someone comes in and tells them something along the lines of, just stop using. You know this isn't good for you. And at this point, many patients would just leave. But let's say, despite all this, they stay and are able to see a physician. But this provider isn't really familiar with methadone or buprenorphine. So they just start the patient on clonidine because that's what they've done for years. And that's what worked with patients who used heroin. Unfortunately, clonidine is no longer the standard of care, and given the severity of fentanyl withdrawal, is not sufficient to manage their withdrawal symptoms on its own. Maybe this patient gets lucky and a physician is able to start them on buprenorphine. However, for this patient, it causes precipitated withdrawal. That's a complication that's more common in patients who use fentanyl than heroin. It causes rapid onset, severe withdrawal symptoms. So after all this patient can't take it anymore. They leave, having come to the hospital vulnerable, looking for help, only to be belittled and left feeling so much worse than when they came in. And the chance that they'll choose to come back to the hospital for help plummets. And what our research team saw time and time again was these patients would leave and return, sometimes even within the week, having suffered an overdose and died. I want to be clear, I don't want to discredit the hard work and excellent care that is provided by so many working in hospitals and EDs across Connecticut, but as it stands, they are the exception, not the rule. You can pick any number of reasons why our overburdened and understaffed healthcare system fails these patients, but the truth is the system we have now is not designed to provide adequate care at the scale that this problem necessitates, and it's costing lives. What we're doing isn't working, and I think that this bill presents the opportunity to meet patients where they are, building trust within communities, taking some of the burden off of emergency departments and hospitals to provide another point of contact for patients with opioid use disorder, and ultimately saving lives. Thank you again for your time.
Thank you very much, Mr. Bonner. Senator Elmore.
Thank you, Mr. Bonner. Have you published your research yet, or?
We were able to present it at a national conference on addiction medicine, but it's currently still getting edited for publication.
With the entire committee, if because this is Connecticut specific data, right?
Yes, correct. Hartford Hospital.
Would you be able to share that with our committee, please?
Yes, we can.
Okay, that would really help us out, and I would love to engage with you more because I completely agree with what you have said, that we are not able to take care of our citizens, and that's leading to very bad outcomes. Things haven't changed. We have waited and seen, and here we are. So thank you for your testimony. Back to you, Madam Chair.
Thank you very much. Thank you, Mr. Bonner. Next on our list, we have Michelle Farella, who's here with us in person, followed by Kim Rada. Welcome. If you can just press the button in front of you, that would be great.
Thank you. How's that?
Perfect.
Great. Okay.
Please proceed.
Committee chairs and committee members, thank you for the opportunity to testify today in support of Senate Bill 190. My name is Michelle Farella. I am a licensed veterinarian practicing here in the state, and I am the immediate past president of the Connecticut Veterinary Medical Association. The CVMA does support the intent and spirit of this bill. The expansion of access to veterinary services in the state is critical to protect animal, human, and public health. The CVMA is happy to have collaborators on this issue. We recommend some minor clarifications, and the CVMA is more than willing to work with the department on final language. The following inconsistencies should be addressed. In line 43 to 44, the phrase working toward should be better defined. And in lines 41 to 43, the phrase from a program acceptable to the American Veterinary Medical Association is ambiguous. Schools of veterinary medicine are not acceptable or unacceptable to the AVMA, but are accredited or unaccredited. Now, I did see in some of the submitted testimony a separate issue was brought up, that of telemedicine, and if I may, I'd like to address that with a few words on the subject. So first, I'd like to make the committee aware that veterinary telemedicine does in fact exist in Connecticut. It is described in Chapter 384, Section 20-197. Now, some have proposed eliminating the requirement for a veterinarian client-patient relationship established through an in-person examination of the animal before using telemedicine. On this proposal, I would encourage committee members to consider two questions. The first is that of many tools available, is telemedicine the correct tool to address the shortage of veterinary care in our state? It's notable to me that the AAVMC workforce shortage report cited in the testimony does not include telemedicine in their list of recommended actions. Second, have the risks or shortcomings of lowering the guardrails on telemedicine been considered? And are the advantages of lowering such guardrails outweighing these risks? While telemedicine is a great tool and it has its place, using it indiscriminately risks misdiagnosis, delayed treatment, increased costs to animal caretakers, and in some cases, animal suffering. So I welcome any questions now, and the CVMA is available. I'm very happy to help with any future discussion about access to veterinary care, certification of foreign educated veterinarians, or telemedicine.
Thank you for that, Ms. Farella, or Dr. Farella, I should say. And my follow-up question is, just to put a finer point on it, is essentially what I'm hearing specific to the telemedicine piece is that you are saying to please exercise caution, and you're kind of raising the red flag for us. Is that a correct interpretation with those questions that you're raising?
Yes, I would say that is correct. We use telemedicine here in Connecticut, and having an in-person examination of the patient before being able to use telemedicine is really important for animal safety and health. And there certainly is a issue of access to veterinary care, and putting all our eggs in the basket of looking at telemedicine is going to ignore some of the other things that can actually be done to help that issue.
Thank you very much, Senator Elmore.
Thank you so much for your testimony, and thank you for really being helpful in making some specific suggestions on language change. On the telemedicine component, if there is no, the issue it's being asked is that if there is no patient relationship, can the first interaction be on telehealth? And I think that's where the rub is, if you will. And if it is for a short acute issue, would that be an option, and then work towards establishing that relationship?
Yeah, that's a great question. So to answer your question, telehealth involves different components, right? There's tele-advice, tele-triage, telemedicine. And tele-triage and tele-advice totally can be done without having an existing patient relationship. You can give general advice on the care and keeping of that animal, preventative care. You can give advice in emergency situations. You know, we actually have poison control service for animals. So all of those things can be done without an existing relationship. Diagnosing a specific illness and providing specific medication is very challenging. My patients can't talk to me. They can't tell me this is where it hurts. I'm actually itchy, it doesn't hurt. My bladder hurts, it's not because I'm itchy. They can't tell me those things. So being able to put my hands on that patient is really important if we're making a diagnosis and giving them medication.
Thank you. Can I ask you for a huge favor?
Yes.
In your written testimony, you have not addressed this because this was not in the bill. Would you be able to add another written testimony, if you can, and have it in written about this telehealth component from your and organization's perspective?
Oh, yeah.
That
yes.
would really help us out.
Sure. Is that in response to this bill, or there's a separate bill?
No, this bill, but because that question has been raised in some of the conversations, I think it's worthy to have that documented from your perspective, and we may reach out to you to clarify some things too later.
Absolutely, would be happy to.
Thank you so much. Thank you, Madam Co-Chair.
Thank you, Senator Elmore. Senator Gordon.
Thank you, Madam Chair, and Doctor, thank you for testifying. I don't take care of animals. I take care of adults as a doctor, and I understand the pros and cons of telehealth. And I've always cautioned that telehealth, telemedicine at times is being overused as a way for some systems to say you can be more efficient. That doesn't mean you're more productive or you're doing actually good care. I've seen some patients who I take care of who haven't seen their primary care doctor literally in years, just only by a screen. I don't do telehealth because as a cancer doctor, I have to see and examine people to make decisions, but I just want to say your point's well taken that telehealth, telemedicine has a role. And you know better than me about veterinary medicine, but I can extrapolate from my world, but also the pitfalls and cautions, and would love for us to learn more about that as we navigate the systems, but understanding there's only so much the state can regulate about how individual doctors and others use telehealth and telemedicine. And I think that comes down to a lot of what the professional organizations and even hospital systems say and don't say about that. But the points you raise are very valid and very good, and would love to hear, that's not on the spot, but would certainly love to hear more about that, as a legislature has to understand these issues and figure out where we stand with that, because I think we'll see as this becomes more and more quote-unquote norm, some of the pitfalls, and there'll have to be some action to be dealt with that. So I welcome learning more about that in veterinary medicine. Thank you.
Thank you.
Thank you. Senator Gordon Rippetoe.
Hi, thank you for your testimony today. I was just looking at the bill. So are you saying that you want added in that veterinarians don't do telemedicine, just so I can understand?
No, we're not asking to add that in. As written, this bill does not include telemedicine.
Yeah.
There was separate testimony bringing up the issue of telemedicine. I am asserting that we already do have statute that allows veterinarians to perform telemedicine, and we do not believe that the rule within statute that requires an initial in-person examination of the animal, we don't believe that that rule should be removed.
Oh, I see. So you'd want to make sure that all the animals are seen initially, and then later can maybe have a follow-up with telemedicine. And you want that to become law, or do you want that to become discretionary from veterinarian to veterinarian?
That's already law right now.
Okay.
We want to maintain that and ensure that it doesn't change to allow a client veterinarian patient relationship to be obtained through telemedicine alone.
Okay, because you talked about not being able to ascertain like their pain, for example, and that sort of thing, which I would agree. However, in a routine annual exam, which is legal, correct? They would bring the animal in, and then after that, discretionary to the veterinarian whether they wanted to see them or not via telemedicine. Okay.
Yes.
You're asking that be kind of clarified, or?
We don't believe that any changes need to be made to statute as it's
Okay.
written right now. All of that is already in statute, and it's acceptable for the veterinarian to make a judgment as to whether telemedicine can be used for their patient if they already have a working relationship with that patient. That's already set up.
Okay, so there would be some kind of analysis as to whether they already had a working relationship by whom? The state, or?
On a case-by-case basis, it generally is the veterinarian themselves would determine, there's not a prescribed amount of time that constitutes a valid patient relationship. So, for example, if I have a request to do a telehealth call with a patient who I saw 6 years ago, I might say, I really need to see you in person to know what's happening. If I saw them 6 months ago, then I would say, yeah, sure, let's hop on a call and see what's going on.
This is really interesting to me because I didn't even know they had telemedicine for the pets. I mean, I have pets and I've never even thought to call. I wish bring them in, but interesting. But thank you for coming in today for your testimony.
Thank you.
Thank you very much, Rep. Dauphiné. Thank you, Dr. Farella, for being here and for your helpful testimony. Next on the list, we have Kim Rada, who's here in person, to be followed by Wendy Burnett, also here in person. Kim, welcome. And Kim, if I just could ask you to turn that microphone button off and try the other one. We're having some feedback, so we'll see if that one works a little bit better. Thank you.
Is this working well? Okay, thank you. Thank you, distinguished chairs and committee members, for the opportunity to speak today on SB 195. My name is Kim Rada. I'm a registered nurse. I'm one of 2 community outreach nurses at the Connecticut Harm Reduction Alliance. I currently work as part of a team on our mobile RV unit, providing wound and other health care, harm reduction education, and assisting participants to not access shelter, housing resources, drug treatment services, and I also work as part of our evening outreach team to connect with unhoused individuals in the greater Hartford region. I'm here today calling upon many years of experience in harm reduction and work among vulnerable people struggling with substance use and other comorbidities to speak in favor of the establishment of overdose prevention centers here in Connecticut. On a daily basis, I see, I hear, I assist participants in our programs who struggle with substance use disorder, quite often along with other physical, psychological, and emotional stressors, including, and not the least, poverty and homelessness, and sometimes very long-term homelessness. In my role, I not only address visible wounds, however. As a team, we learn to recognize the wounds that are not easily seen. For a moment in time, we may be a safe space for listening, for conversation, and for respite for many of our folks. We're a trusted resource. We develop networks and work to help to make connections to additional needed services that we may not be able to or immediately be able to provide. And currently, those needs are not easily or swiftly met. The establishment of OPCs with the proposed services that are outlined in this bill and staffed by competent and caring providers will provide a critically needed and logical resource. This will be a life-saving addition to our toolbox. At CTHRA, we meet people where they're at, without judgment and with the dignity and respect that is needed. We build relationships that create bridges and connections. We often work in difficult and seemingly despairing situations. A good day all around is an overdose reversed. Someone connected to treatment or to shelter. Learning that the person with the extensive arm wound and possible infection actually did access the medical referral and is now doing well. We also carry with us those who have disappeared off our radar for a whole variety of reasons, including those who have passed, perhaps from an overdose, quite often alone, and unattended. One death, one loss, is one too many.
Excuse me, Ms. Serrata, but you've reached your 3 minutes. Thank you.
Thank you so much. I want to say that's a very powerful way to actually end, and it's very true. And I also want to say thank you so much for your work. It's very appreciated.
Thank you very much.
Senator Anwar, followed by Rep. Subkis.
Thank you so much for your testimony. Can you, in the last many months, it's very clear that the unsheltered people, overwhelming majority, are impacted by substance use that we are seeing, and the unsheltered ones. Mm-hmm. And in order to get them help, it's almost impossible to get a detox facility and a treatment facility because they don't have an address. And they're sort of caught in a catch-22. You guys are the only ones, at least in this region, who are providing some hope in some path. Mm-hmm. Could you speak a little bit about how these two things are connected and we cannot fix one without the other?
I can speak from my experience and the experience of members of the teams that I work with, that we make an incredible effort to make the connections and create the networks with providers, with substance use treatment centers, and have developed the trusting relationships that are really necessary for folks to come to us and for us to have these conversations. We may talk to someone 25 times discussing treatment, discussing hopes and wishes that they have but are not ready at that moment in time to make the next step, whatever that may be. But the 26th time we talk to them, that may be the time. They'll come with their bag, they're ready to go. So, and we know, we've had the experience of calling and calling and calling various facilities and beds not being available. We do what we can. We pull out all of the tools and the tricks of our trades to be able to make this happen. When that does not occur, we try as best we can and as often as we can in as many ways as possible to maintain that connection with the individual until that time that there is an opening and that person can be provided with the services they need. These OPCs really, for me, open up a door to a real holistic and a comprehensive opportunity for care for folks.
Thank you so much. Thank you, Madam Chair.
Thank you for that answer. Representative Zupkis.
Thank you, Madam Chair. Thank you for coming and the work that you do. It's,
Thank you.
I'm not sure I could do it, but we're grateful for people like you that do it, because people are in need. And, but I have a couple of questions. And you talked about what you do in caring for folks and offering them services, and I think that is wonderful. When this bill came up last year, these safe injection sites were not going to help to get people off drugs, as I remember. So I'd like your thoughts on that.
I think in reading through the bill myself, it really is pretty comprehensive, and there are so many points along that continuum of care that I see within this bill where these conversations can be had, can be initiated and continued. And this is where I see the connection between the struggle with substance use disorder, the overdose prevention sites, and the access to care when and if people are ready. I mean, we do not, it's not our job, and we are very clear that we do not try to pressure people into making any kind of decisions. We will walk beside you, excuse me, and provide those services. And again, I see OPCs as a real comprehensive way and maybe many doors to access services that people need. Not only overdose prevention, not only access to treatment, but to many other resources that they may or may not be able to access or easily access.
Because one thing I struggled a lot with last year, well, two things. The first thing is, I think, and we all have someone in our lives close to us that have these addictions. And you know, the responsibility of guiding and encouraging and helping to get off drugs, I think, is extremely important. And then the second piece with these sites is these are illegal drugs. And so having people come and do illegal drugs, I struggle with that because they're illegal. And so, you know, why do we let that happen when someone breaks into your home and they're held accountable? So the illegal part of it and letting people come and do illegal things, I struggle with that a little bit. So what are your thoughts on that part of it?
I understand that struggle, and this is not the first time that I've and others of us that work in this field have heard these struggles that people have. I have worked in the field of harm reduction for many years, and when I speak of harm reduction, it's meeting people, as I said before, where they're at without judgment, and accepting who that person is and what their choices are. It is not for me to impose my wishes or my beliefs on someone else. It is for me to stand alongside them and provide the services for them to remain safe, as healthy as possible, and to be able to access the services that they need or are requesting, with the understanding that at some point in the future, there may be an entry into drug treatment. People may we make decisions all the time on how we change our lives and the courses that our lives are taking. It is being accepting and understanding that folks who are struggling with addiction, with substance use disorder, are going to be using drugs often in a very unsafe, unsanitary, sometimes very frightening situation. And I feel that if my place as a nurse, as a human being, excuse me, is to provide the safety, the security, and the education, which is a huge component of everything we do, so that people can make decisions that will keep them safe and keep them alive till the next day.
Thank you, and I completely understand empathy. That's what you just described. And everyone is God's child, no matter where we are in our lives or any of those things. And everyone deserves respect, and I agree with you 100% on that, and meeting people where they are. I think it's a responsibility, though, to help people, to try to get them off of drugs. And again, the illegal component of that, you know, again, you let someone come in and do something illegal, but if someone breaks in your house or does something else illegal, they're held accountable. So I didn't get quite that piece there with you. I do understand, though, the empathy and treating everyone with respect, but I do think society should try to encourage and get people off it. Some people are never going to get off drugs. There's always going to be drugs in our society. But to help people get off and to be healthier, I think is very important, in the whole criminal aspect of it as well.
Okay.
Thank you.
I do understand your point of view. I will respectfully disagree, but what we've just seen is a space where we can come together and have that conversation, and I thank you for that.
Thank you, Representative Zupkis. Just to follow up on the conversation you were having with the good representative, in my experience, I'm a social worker, not a clinical social worker. I've not practiced as an addiction specialist in any way, so I will put those disclaimers out there. But back in the day, the strategy was to do interventions where you would bring people together and say, this is what needs to happen. And, you know, coming from the place of concern that family members or others would have. But over time, my understanding is that we've learned through research from people like Prochaska and DiClemente, who talk about the stages of change, who use motivational interviewing to now use that evidence, that social science research and evidence, to look at a different strategy, which is essentially empathy, but with social science behind it, to meet people where they are in terms of that stage that they're in, whether they're in pre-contemplation to make change, they're contemplating change, they're taking action, and that intervention is designed to meet them along that continuum based in evidence. And I guess my question to you is, have you seen that evidence change over time? Because I think, you know, we all share, as Rep. Zupkis said, we all share the desire to see people living their fullest, healthiest, happiest lives, but how we get there, right, is part of what we debate around this circle. So if you can kind of speak to that just from a more of a scientific and evidence-based standard, and if you can't, that's fine. There are others here today, so I'm partly asking the question so that others in the room may be able to answer that later. And please feel free to say that's not something that you want to answer, that's fine.
I can only answer it in part. I do understand what you're saying and the stages of change. And yes, what I have seen over long periods of time, people make those decisions and take those steps to make the changes that they feel are important in their life. Some people, and that those goals are very different from, as you well know, from one person to another. Some people function extremely well with continuing substance use. Others, and many of the folks that we see, are struggling just to get through an hour or to get through a day. So it probably doesn't answer your question. I hope others may have some clinical data to back this up, but I have personally seen change over time, and it's not without those continuing conversations. And I feel as though we have created a space or spaces where folks feel comfortable coming to us and talking to us about their thoughts and maybe a long-term or future desire, without the understanding that we're gonna grapple with this right now, and we're gonna make a call and we're gonna get you into treatment. It's really following the lead of the individual who we're speaking with.
Thank you for your answers. Representative Reddington Hughes, to be followed by Senator Gordon.
First, I'd like to say thank you for the work that you do. It's very hard, and it's very caring. I wanted to ask a couple questions on the overdose prevention centers. Do they show a better success rate than traditional treatment centers? And do you see this as a better alternative than an inpatient program for rehabilitation?
I really don't feel qualified to give you an answer on that, because I have not done extensive research on making those comparisons. What I can say is that as I understand and as I've seen in other states and other countries, the comprehensive nature of an overdose prevention center provides an opportunity for, as I said before, people to take different paths and doors. It's the not one size fits all approach, and I feel that they have been successful. I think that what we are doing and what we have available is inadequate at the moment, and opening up the opportunities for this type of a resource, I feel can only do good.
Yeah. So I would say, in summation, then the goal is to prevent the deaths of the people there, but not necessarily to rehabilitate them from addiction.
I struggle with that term, rehabilitation. That is a word that I would never use. I think there are several goals that I see when I read the House bill. Overdose prevention, obviously, because it's called an overdose prevention center, but overdose prevention can take many forms. It can be testing your drugs to see what's in them. It can be the administration of naloxone. It can be the conversations with counselors and other providers to maybe even initiate thoughts in individuals, and the understanding that there may be options that I haven't thought about, or that have been unknown to me up to this point.
But so in conclusion, then, it is not necessarily the cessation of the use of the drugs. It is being able to use them in a safe manner.
Absolutely, absolutely. And this is something that we do every day.
Thank you.
Thank you, Representative Reddington Hughes. Senator Gordon.
Thank you, Madam Chair, and thank you for being here today. This is not the first time we've heard testimony and had to wrestle through this topic. And throughout all the public hearings and all the testimony that I read, and I do read through all the testimony provided, it is, I'm always thankful for the caring work and longitudinal work you and others are doing. And I understand certainly about being accepting, understanding, being where people are, and I'm not challenging any of that. We heard the Department of Public Health Commissioner when I asked her on this topic, and she said that she's not aware that federal law has changed relative to how overdose prevention centers are used or may want to be used. And I won't go into details of that law and the history behind it, but I assume that one of the things that people who are trying to help and take care of those who do have the addiction problem with regards to substance abuse and substance uses would also want to make certain that these prevention centers and the work being done follows state and federal laws. Is that correct?
I would say absolutely, and if we're looking at state law, we have the opportunity now to make that change.
And a corollary
Or
to that,
or to create a law and create legislation.
and a corollary to that is separate from creating or changing state law would also be wanting to follow applicable federal laws. Is that correct?
I would take that one step further and say that I am very interested in not only changing state legislation, but federal legislation.
And I appreciate that, and our jurisdiction is just on state law here. So if we still have the federal laws in place, we do have to be mindful of that. But I appreciate very much your testimony and the discussion you've been having with us, and I do appreciate it. Thank you. Thank you, Madam Chair.
Thank you very much, Senator Gordon. Thank you for being here with us today and testifying.
Thank you for having me.
Next up, we have Wendy Burnett, followed by Cameron Breen, both of whom I believe are here in the room. Yes. Hello, Wendy. Welcome.
Good afternoon. Dear Senator Anwar and distinguished members of the Public Health Committee, my name is Wendy Burnett, and I am here today in strong support of the Overdose Prevention Center bill. I speak not only as a professional who has spent years supporting individuals and families through crisis, recovery, and loss, but also as someone with lived experience who understands the realities of substance use, stigma, and survival from the inside. There was a time in my life when I needed compassion more than judgment, safety more than shame. I know what it feels like to be caught in a moment of crisis and do not have a safe place to land. I know what it means to be given a second chance and how many people never get that chance at all. My recovery, my stability, and my ability to stand here today are the direct result of people who believed my life was worth saving, even when I didn't always believe in myself. That is what overdose prevention centers offer: a chance, a pause, a moment where a life can be saved instead of lost. In my professional work, I have sat with parents who lost their children to preventable overdoses. I have supported individuals who have used only because they were too ashamed or too afraid to seek help. I have watched people cycle through emergency rooms, jails, and shelters, not because they didn't want to live differently, but because they didn't have access to the kind of consistent, non-judgmental support that OPCs provide. Overdose prevention centers are not about encouraging drug use. They are about preventing death. They are about creating a bridge from isolation to connection, from crisis to care, from surviving to actually having the chance to recover. We know from existing centers that they reduce fatal overdoses, reduce public drug use and syringe litter, increase engagement in treatment. But beyond the data, there is human truth. People cannot recover if they do not survive. When someone walks into an OPC, they are met with dignity. They are met with people who see their humanity, not their addiction. And for many, that is the first step toward believing they deserve help. I am living proof that when people are met with compassion instead of condemnation, they can rebuild their lives. I am here today because someone created space for me to stay long enough to heal. I want the same opportunity for every person in our state who is struggling. Passing this bill will save lives. It will keep families whole. It will give people the chance to write a different ending to their story. I urge you to support this legislation and to stand on the side of evidence, compassion, and hope. Thank you for your time.
Ms. Burnett, I'm going to ask, I know it's very difficult to not clap, but I'm going to ask that you do so in your heart, if you would, or to do this exactly. Thank you for that. We are very glad that you are here and very grateful that you are using your experience and your voice to advocate for others who can't be here with us, maybe because they have died or because they can't be here because they are currently struggling. So we thank you very much for being with us today. Senator Anwar.
Wendy, thank you so much for your testimony, and thank you. Would it be fair to say that one has to live to have rehab?
I'm sorry, say that again?
Would it be fair to say that one has to live to have rehabilitation?
Well, yeah,
Of-
absolutely.
Okay, I just need to make that because people sometimes don't even recognize that. Were you able to, through your journey in the past, have episode of an overdose that somebody saved you?
Yes,
And that path sooner or later led you for rehabilitation and then be where you are?
it did.
Okay,
It definitely did.
okay.
But I also got a lot of support along the way.
Yes. So you think that that connection and support and survival allows a person to overcome this situation?
Sure it does.
Okay. Because I know my colleagues are struggling with some of those concepts at times, but this is important because when you bring your personal experience, which truly is heroic that you do this, it helps us move in the right direction with respect to understanding from somebody's lived experience. So your coming here was very helpful. So thank you for your courage and your leadership and your work that you're doing. Thank you.
Thank you.
Back to you, Ann.
Thank you, Senator Anwar. Ms. Burnett, thank you so much for being with us. Next up, we have Cameron Breen, who is here with us in the room, to be followed by Fiona Farine, who is, I believe, online. Welcome.
Good afternoon. Thank you for having me. Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. I'm here today to support SB 195 in support of overdose prevention centers. My name is Cameron Breen. I have been here before. I work as a street outreach case manager and a drug checking technician for Liberation programs. My question to the legislature is very simple. It is, do you believe that people who use drugs deserve to live? That all people in our state have the right to life, liberty, and the pursuit of happiness? If so, I urge you again to support overdose prevention centers. Since Connecticut's legislative body voted no and or did not choose to proceed with OPCs in June of last year, approximately 519 people have died in our state. And this number is only increasing every day. I am curious how many people have to die for this to be seen as a viable solution for the powers that be to accept a pragmatic response over a punitive one. We continue to talk about this subject and what it would mean for the people of Connecticut, and people continue to die. You continue to debate what is acceptable versus not acceptable, when the reality is these spaces are clean, welcoming areas for people to be connected to help. The reverse of that is what we currently have going on now. People injecting in public bathrooms, in their cars, in parking lots, in front of businesses, and people dying in those spaces. It is true we've watched overdose deaths start to decline, and contrary to popular belief, it is not due to a decrease in access to the drug supply. It is not due to a punitive response. It is due to expanded access to naloxone, medication for opioid use disorder, harm reduction services, and more. I worry that we will pat ourselves on the back saying that we are doing enough. We could be doing so much more to help people with an overdose prevention center as they manage the effects of a volatile and unpredictable drug supply. More than 2 people have died a day since we did not proceed with OPCs last time. Is that something we are going to accept? Is that something we are going to socially condone? Is that doing enough? Last year we were told to wait and see. How long do we have to wait and see? While our friends die, while our community members die. If our legislators cannot get behind the ideal of keeping people who use drugs alive, then what about saving money? What about helping an overburdened healthcare system? What about helping first responder burnout? And even our businesses that continue to find overdose members of the public in their bathrooms, sometimes dead. Can you get behind the idea of moving drug use indoors so that there is less public nuisance calls when it comes to opioids and drug use in the public?
Excuse me, Mr. Breen, but you've reached your 3 minutes. Thank
Knew
you.
that would happen.
If you can summarize in a sentence or two, that'd be great.
It is easy to look at this issue as problematic because since we have been children, since we've grown up, we look at the idea of drug use as moral versus immoral. It is value neutral. We just want to have a space for people to be able to survive and get connected to the care they need.
Thank you, Cameron, for your testimony here today and for your presence here on a regular basis. We appreciate it.
And I'm happy to answer any questions if there are any.
Senator Anwar.
Hi, Cameron. You try and help people every single day, but you're here because somebody helped you. Can you just tell us about that?
Absolutely. I forgot to mention I was an IV drug user for many years. I was saved multiple times by naloxone and people who cared enough to show up and give me those spaces. And for me, recovery didn't happen in a vacuum. You know, I needed people, and I needed space in order to access the different care. And socially, we don't really have those spaces in the way that we should, and this is one of those spaces.
Thank you for that. And if there are wraparound services, caring individuals, respecting individuals, accepting individuals, is that going to help the person move towards rehab?
Absolutely. I hear a lot, and I mean, we've done this multiple times. We always seem to come back to the idea that this is not going to push a person into rehabilitation, that they're not going to get well, because that is not the focus of an overdose prevention center. On the surface, that is always what is attached. You know, that's what we attach to. We attach to that moral of we need people to be abstinent in order to say that we have achieved anything, right? But when there are wraparound services, when a person knows that they can go somewhere for a shower, to do laundry, to go to a space that's not going to condemn them for using substances, that's where things start to happen. That's where conversations start to happen. That's where people look at themselves long enough in the mirror to say, I don't really love what's going on right now, but this is the only way that I know how to survive. With those wraparound services, with case management, with helping people get access to housing, with access to medications for opioid use disorder, people get well, right? But when they're pushed into a hospital, when they're pushed into a treatment system in a space that only focuses on abstinence being the only attainable measurement of success, we don't reach that. We don't get to that space. And so the end of my testimony was talking about this is an opportunity for us as a state to shift the narrative towards treating people with dignity and respect regardless of what's going on, and shift the narrative away from abstinence being the only measurement of success and looking at the small incremental changes that happen in people's lives where they actually start to turn things around. Because for me, that is what happened. It did not happen overnight, and it did not happen in a vacuum.
Thank you. And is recovery linear?
Absolutely not. Recovery is not linear. Recovery is defined by each individual. I define, as many other harm reductionists define, recovery as any positive change, right? A lot of people in the normal spaces, they see recovery as abstinence, that they are completely abstinent from any mind and mood altering drugs. For me, that is what worked, but that is not what works for every single person. And any positive change is all the things that Kim talked about. It's the things that people will talk to you here about today. It's connecting with a case manager. It's taking a shower when they haven't taken a shower in 3 weeks, right? There's so many small things that move a person incrementally to a space where maybe abstinence does take place. And ideally, working in these spaces, we're not here to say that drug use does not cause pain, that drug use does not cause harm, right? We know it, we see it, we work in it every day. We want a space where people feel accepted and where those changes begin to take place. And right now, we are severely lacking in that area in the state of Connecticut.
Thank you. And you made one comment that since the end of May, when this bill a similar bill that was presented in the past that did not get voted on, you named gave a number of how many people have died. Is it your suggestion that if we had OPCs, we did not have any, and then if we had OPCs, all those people would be alive and they would be with their family?
I cannot ever say that it would be every person, right? What I can say is there are individuals that I know that would have accessed these centers and that would still be alive in this past year. 519 people have passed away since June of last year. Overdose prevention centers will not solve the drug overdose crisis. They will not solve the opioid crisis. They will not solve drug use in the state as a whole. What they will do, as I said, is shift the narrative away from abstinence being the only measurement of success, and they will move us into a space where we can save countless more lives while we're already starting to, lower the number of overdose deaths that we've seen, as I've said, that has much to do with harm reduction measures.
Thank you so much, Madam Chair.
Thank you very much. I have a question for you, Cameron, and then Rep. Clara DeStitria to be followed by Rep. Carpino. My question is this: if a person is at an overdose prevention center, or in your experience at Liberation, they're coming to you and they're looking to enter treatment and perhaps to go to an inpatient setting, are you finding that is a difficulty in terms of making that transition in terms of space available or providers available?
Yes, absolutely. A person comes in to access treatment today with Liberation programs, specifically inpatient treatment. The treatment that we all propose is like the most ideal and the thing that's going to get people well, going away for 5 to 30 days, right? That's kind of the idea that we have. If a person comes in for treatment, it takes, on a good day, 3 to 5 hours for us to make the phone calls, get the person accepted to care, find the transportation or get transportation through the access line, and get them there. That's on a good day. Most days you call for, state beds for treatment, and there are none. And the person loses that hope in the system that's there to help them. And so, ideally, spaces like these, for instance, Insight in Vancouver, had a detox unit or a withdrawal management unit on the 2nd floor. And the idea was that when the person is coming in and using drugs on a consistent basis, if they're ready to go, there doesn't need to be those phone calls that we make. The phone call to the provider to see if they're eligible, to the insurance companies, X, Y, and Z. They can literally just take them upstairs instead of transporting them across town. So again, the idea here is truly what the bill speaks of, which is expanded access to treatment. Right now, as I said, we are definitely severely lacking in the ability to quickly transition someone into inpatient treatment.
Thank you for that answer. Rep. Clara DeStitria.
Thank you, Madam Chair. Cameron, thank you for being here today and sharing your story with us. One of my questions, and I apologize if you already answered this, your personal journey to where you are today, did that happen here in Connecticut or at a different recovery center?
No, it happened here in Connecticut. I had struggled for years on and off. My story includes medication for opioid use disorder, Suboxone. My story includes incarceration. My story includes a lot of different pieces that people have had to deal with: probation, inpatient treatment, outpatient treatment, all of that, most of which occurred in Connecticut. There were a few treatment centers that I came to outside of Connecticut, but this time around, I did not go to inpatient treatment. I was able to access medication for opioid use disorder, Suboxone, and a doctor, and start working on those things. Although I very much likely did need inpatient treatment, it was not something that I accessed this time around. And it has been almost 9 years.
Well, congratulations.
Thank you.
I think everybody could see that you worked very hard to get where you are today, and that's commendable. And I think we struggle with, we don't want anybody to be addicted to drugs, and no one chooses that path. Whatever brought you there, the goal is to get you back to where you were before, in a better space. We do have wraparound services in Connecticut. I think a lot of us struggle with the fact that a lot of this still is illegal on the federal level. We know, we've seen from other OPCs that it does decrease deaths, which is wonderful because we don't want anybody to die under any circumstances. It does decrease emergency department visits. But the goal is to get you through all that and then be clean and not have to deal with the struggles of being addicted to drugs anymore. So we'll continue to hear everybody's testimony here today and hear your stories, but I appreciate, again, you coming here and sharing that because I know it's not easy. So again, thank you very much. Thank you, Madam Chair.
Is there a couple of things I can say to that, or yeah?
Go ahead.
So there's a lot of discussion on the federal legality of it and the connection to the quote-unquote crack house statute, which we've had Scott Burris discuss here before, and even bringing up the President Trump's ending crime and disorder on the American streets. The idea here is we are writing into state law, right? No other overdose prevention center has been, sanctioned, so to speak, for engaging in the services that it offers. And so without kind of like looking too far outwards to what the federal landscape looks like, we have an opportunity here in the state of Connecticut. And I would hate to see us wait for another administration to move to another administration and say, well, we're just going to wait and see, when we had an opportunity for people to not lose their lives, when many other states are doing this, and we have plenty of data to show you guys from the OPC in Rhode Island, and I'm sure they would love to have you. We have AJ speaking later today, so I don't mean to drone on, but
No, thank you very much. And we're very heavily data-driven here at the Capitol, so any data that you can get to us, it would be greatly appreciated. Thank you again.
Thank you, Representative, and thank you very much, Cameron, for your ongoing advocacy and your witness. We appreciate you. Next, I'm sorry, I forgot Representative Mara. So thank you, and Representative Mara.
Thank you so much, Madam Chair. Thank you for coming and speaking to us. I'm a big supporter of what you do at Liberation Program, and it's great to hear from you. So as I know you're aware, we have harm reduction already codified, right? I'm curious as to your thoughts on where you see the difference in kind of lives saved. We know, obviously, if you're going from no wraparound, no support help to something fully like what we're proposing today, might see a drastic difference. But when you're looking at safe injection site versus kind of the harm reduction unit, are you like 50% there? Are you 90% there with the harm reduction units? Where do you think that the comparison would lie with someone that already has a harm reduction unit that wants to put in safe injection site versus, am I out again?
I can hear you.
I'm sorry, what did I say?
You.
Hello, can it? I
Were
am.
you speaking in regards to like the harm reduction centers specifically?
Correct, yes.
What the difference is between?
Yeah, I mean, you got, I
I'm-
mean, I think it's amazing.
No worries.
Just testing, no.
Hello, hello, hello. Works. Seems like it works. Oh, it's a little fuzzy.
All right. If anyone can hear me online, I don't know if this is working or not.
We can.
We can hear you. We can hear you.
Not available right now.
Okay. No, I think we're obviously having some microphone issues here, but
I can
this
hear you
seems
fine.
to be working now.
Yeah.
Rep. Mara, I'm going to go back to you and see if your microphone will work at its proper level of volume.
Thank you, Madam Chair.
And we're back.
So yes, we have a lot that's there that is helping this community, and I'm curious as to where you think what we have now versus adding in the safe injection site. Like, I feel like this is one of the best things, having that wraparound care for people to come in and maybe have access to testing strips or to clean needles and to have health care and advisors there, or a shower, or just a place to rest, versus adding in the safe injection site. I know you're going to think it's a little bit better or a lot better, or that's what I kind of want to hear.
I think that the services that we offer through harm reduction centers in Connecticut is ideal, and those services came directly off of the bill that was originally proposed as a safe injection site, right? The 3 harm reduction centers that we have in Connecticut, and the soon to be more, came directly from that bill. The supervised consumption was just struck from it. So the difference being is that when it comes to the safe consumption piece, it becomes one of the most.
So,
Somebody's unmuted.
is there a place where
Senator
all the
Kushner,
bills?
Senator Kushner, you are not muted. If you
Sorry.
mute yourself, that'd be great. Go ahead, Cameron.
When it comes to the safe consumption piece, it becomes, as I said, we have amazing services that are available in Connecticut, but what is offered with the safe consumption part of this bill is we are working with some of the most marginalized communities across Connecticut, people who are experiencing homelessness, people who do not traditionally access hospitals and other services, people who live under bridges, in doorways, etc., right? That is a target population here that is not, it has nowhere else to go to use but outside, alone, in bathrooms, right? And the goal is obviously to expand that to a much larger swath of people that use drugs. But ideally, those are some of the folks that are targeted and use the service the most. And that is where you save lives, right? Because what we're offering right now is wonderful and amazing, but under the current guidelines, those folks are told that they need to leave, and that there cannot be drugs brought into the facilities or used in the facilities, and so they turn away and they go somewhere else and they use alone. And last year we had, the Department of Mental Health and Addiction Services citing SafeSpot as an idea for, call the overdose hotline. But again, we're working with the most marginalized communities, people who do not have cell phones, right? People who don't have access to those services. Those are the folks' lives that we're really trying to save amongst a huge swath of other people. Hopefully that answers your question.
And just a quick follow-up, if we don't get across the line for safe injection sites, is there something else that can be done with the harm reduction that could be done without the safe injection site?
Ideally, safe injection sites, or specifically overdose prevention centers, are what we want to see here, but what can be done is continued access to sedentary funding for harm reduction centers for continuation and improvement of the care that we're able to offer.
Okay, thank you so much.
Thank you.
Thank you very much. Cameron, if you can quickly answer this, just tell us what SafeSpot is.
Sorry, SafeSpot is the overdose prevention hotline, which is currently being expanded into Connecticut. It used to be the Massachusetts Overdose Prevention Hotline. I apologize. And are we? Oh, we're there. We're there. Okay. It is the hotline that people can call 24/7, 365 days a year to get connected to a spotter. Spotter listens to them. They say they're going to use drugs. They use the drugs while on the phone with the individual. No shame, no judgment, no stigma. And then they make sure that they're alive by the time that the call ends. If not, they call emergency services.
Thank you, and funded through our opioid settlement funds at this point. Thank you for answering that question. Important, I think, for people to know about that. Thank you for being here with us today.
Thank you for having me.
Again, take two. Okay. Next, we have online, we have Fiona Farine, and followed by Tracy Eberg, who is here in the room. Fiona, welcome. Please proceed.
Good afternoon. Can you hear me?
Yes, we can.
All right. Good afternoon, co-chairs Senator Anwar and Representative McCarthy Vahey, and all ranking members and members of the Public Health Committee. I am the president of For Cameron, a nonprofit raising awareness about the dangers of fentanyl and fake pills, and most importantly, confronting the stigma surrounding addiction. And I'm here in support of SB 195. This is my 8th year of knocking on doors in Hartford. 8 years since we lost Cameron to a death that was completely preventable. 8 years of asking for bold, compassionate steps in a crisis where human lives hang in the balance. There have been some small wins, but there have been far too many shrugs and no's. I'm watching newly bereaved families come in with hope and leave disheartened, feeling unheard. The inability to be listened to, where our experience is lived and not theoretical, deepens our grief and proves that stigma is still very much alive. Today, I'm asking each of you to put bias aside. Put aside the language, the politics, and the assumptions that have changed this conversation for too long, and please listen with empathy. Listen with empathy to each of those who will lend their testimony after mine today. Because when our pain is met with eye rolls or hurtful terms such as injection sites, it re-traumatizes us and it reinforces why stigma continues to win. I'm asking you to consider overdose prevention centers. I'm not a policy expert. I'm just a mom who believes that every life is worth saving. But fear is holding Connecticut back. Fear that these centers will make communities worse or enable addiction. But fear is already costing us lives. Public drug use is happening in every community, affluent and urban alike. And our children are watching. Our children are becoming desensitized to addiction because we've normalized seeing this awful suffering in the open. Connecticut has done remarkable work with Narcan education and Narcan distribution, and it's saving lives. But it's also adding to collective trauma as we witness these moments again and again. Overdose prevention centers are one more needed step, a step that offers dignity, safety, and a doorway to recovery. No one will go there who wasn't already going to use. But there they can be safe. They can be treated as people with a medical condition, not a moral failing, and maybe in being treated with compassion, they can begin to feel their own worth again. I leave you with this reminder. They are overdose prevention centers. They exist to prevent deaths, and that alone should be reason enough. Thank you. It's always an honor to be able to testify in front of each of you.
Thank you, Ms. Farine. Thank you so much for bearing witness. And even though you're not here in the room with us, I can feel the pain even through the screen, and I can only imagine what you've gone through. So thank you for taking the time and the persistence. Senator Anwar, I know, is going to want to say a word.
I just wanted to say thank you again. I know we have conversations, and you've been very generous, and you share multiple times. We'll keep hoping and praying this is the last time you'll have to come and testify, because we will do the right thing as a state. I'm so sorry for all the people who have to relive their pain every year. But I also thank you for doing that, because you're trying to use the pain that you have experienced every single day of your life to save somebody else from having the same pain. And that's what heroism is. So thank you, Fiona.
Thank you, Senator.
Thanks for being here with us. Next on our list, we have Tracy Eberg, who's here in person, followed by Evan Serio, also here in person. Welcome, Ms. Eberg.
Good afternoon, Madam Chair, Senator Anwar.
Can I ask you a favor? Will you turn the one button off? That's wonderful.
Gotcha.
Thank you. Microphone adventures today. Go ahead.
Everything's a learning experience, right? My name is Tracy Eberg. I come to you as a widow, as an angel mom, and as a person in long-term recovery. I am in support of SB 195. I believe that it is a form of treatment. It allows people to come in to be seen, to be heard, to be cared for, right? To develop some form of a trust, connection. For me, the opposite of addiction is connection, and it allows them to get that, right? They cannot get a message if they are not alive to hear it. A little family statistic: out of 5 of us, 3 of us suffered from substance use disorder. Out of the 3 of us who suffered from substance use disorder, I am the only survivor. That is my family, right? Substance use disorder is a family disease, and it has a ripple effect. And it doesn't just affect the family, it affects the friends, the family of the friends, so on and so forth. So I mean, I don't have any degrees, I just have my life experience. That is all I have. And I watched one overdose destroy my family. And then the second one came. It didn't just destroy mine, it destroyed a community. The thing that I found when I went into treatment was I had a connection. And, you know, I go back and forth. You know, some days are really, really good, and I'm headstrong with it. And because I have a connection, when those days are not so great, I know who to fall on, right? But everybody's recovery is their own, whether it's MAT, whether it's cutting back. You know, it can go into so many different directions. But it can't go into any direction if they are not above ground. If they are dead, it is done. It's done. My son will never know what recovery is. He will never know what it is like to make a simple step forward into a better life for himself. He will never know. I don't have much more to say other than that. I mean, we talk about stigma. We can talk about it all we want. As a person who had a substance use disorder, you can talk about it. If you don't show me you're not stigmatizing me, it doesn't mean anything.
Excuse me, Ms. Seberg, but you've reached your 3 minutes. Thank you.
Thank you very much. Oh, hang on one second. I actually am using the very word that I picked up on in your testimony. And you said you're just a mom and you just have your experience. That's everything. And we are very grateful that you have come here to share and to bear witness today, and very sorry for all that you've been through, and just thankful for your willingness to be here and present with us today.
Thank you.
Representative Kitt.
Thank you, Madam Chair. I just want to say thank you for sharing the story. I know how much painful that must be for you. I picked up on something you said, which I'm surprised that Representative McCarthy Vahey didn't, was that you mentioned the importance of connections in your recovery. In your view, do you believe these OPCs, outpatient, these overdose prevention centers can provide that first connection as a first step to recovery?
Absolutely. Absolutely. People are going to walk in, people are going to see them. They're going to talk to them like they're people. They're not going to look down at them. They're not going to have that better than thou attitude to make them feel embarrassed, ashamed, or less than.
Thank you for that. I really appreciate you bringing up that notion of connections. Thank you.
Thank you very much, and yes, I do too, Representative Kitt. Thank you for being here with us
Thank you
today.
for having me.
Next on our list is Evan Serio, and to be followed by Gabrielle Bogut. I think I probably mispronounced that. Evan, welcome.
Good afternoon. Thank you very much for your time this afternoon, and I apologize if I'm a little shaky. My name is Evan Serio. I'm a resident of New Haven. I am a social worker. I am the director of a low barrier drop-in and resource center and a syringe service program. I am someone who lives with chronic pain and is myself in recovery. And I come to you also as a grieving brother, friend, service provider, and loved one. I think that it's made very clear in the many hearings that we've had over this and other issues around substance use that feelings are deep and that we are deeply affected by this. We will hear all kinds of data and reasons to care. And I think that I just want to leave folks with a perspective of the service providers that are here. I'll keep it brief. We've dispatched so many tools in the prevention, diversion, intervention, and response towards opioid, overdose deaths. And I think that we would be remiss to leave any tool on the table at our disposal, and then to think that we can dismantle other tools to try to fix what we have a good option for. Implementing overdose prevention centers would stand as the first major decision to center those most affected when they are at their most vulnerable in a facility specifically made for that purpose. And while these are unprecedented in Connecticut, they have been proven on the international stage to be a critical and evidence-based life-saving strategy with undeniable results. They save money, they have no major influence on local crime or public nuisance, they reduce public consumption of drugs and stop the spread of blood-borne viruses, they provide direct pathways to treatment, and more, but most importantly, they save lives every day without fail. When we talk about pushing the stigma and prejudice and bias and policy, pushing folks to the margins, overdose prevention centers flip that narrative and bring those folks to the center of care. It is my solemn belief that had such a service been available to someone like my brother, that in January of 2016, he and all of the others that we did not have a chance to say goodbye to would have been surrounded by the caring, trained individuals who staff these facilities, and instead of dying alone in the shadows, would have been surrounded by care. That is my belief, but it is also my experience. For the many dozens of individuals that I and my staff have reversed overdoses for in the nearly 5 years of our program's existence, they return to us, most of them return to us within 48 hours with the adamantine knowledge that their lives are valued and guarded and that they are safe and the staff and programs are trustworthy. We have seen them and cared for them at their most vulnerable, and we will uplift them into the future that they are still alive to experience.
Excuse me, Mr. Serio, but you've reached your 3 minutes. Thank you.
Thank you.
Thank you so much for your powerful testimony, and also very sad to hear about your losses. It is, as you said, you and so many other people who are here with us in this room and who are listening online, who have suffered through terrible loss and tragedy. And I want to thank you for your work as well.
Thank you very much.
Seeing no questions, thank you for
Thank
being
you for the
here today.
opportunity.
Next, we have Gabrielle. Gabrielle, I hope you'll help me with your last name. Bogut, and followed by online Trish Rios. Welcome.
Thank you. Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee, my name is Gabrielle Bogut, and I thank you for the opportunity to testify today on behalf of myself and in memory of my late brother, in full support of Senate Bill 195. For 13 formative years of my life, I had watched my older brother fall victim to his addiction. I watched my parents struggle to find treatment options for my brother, unsure of how to navigate the vast healthcare system and unable to afford basic treatment for something that was not being treated as the illness it truly was. A substance use disorder ultimately took my brother's life, but an overdose prevention center could have saved it. We will continue to hear from a lot of qualified, passionate people today about the logistics and efficacy of overdose prevention centers. So I would just like to reiterate that the overall purpose of an overdose prevention center is to do just that, to prevent an overdose. However, this goal can be accomplished in more than one way. Along with providing life-saving care in the event of an overdose, overdose prevention centers serve as safe, community-oriented places where individuals struggling with addiction can turn to for a vast array of services. These centers provide clean, safe supplies for drug users to prevent and reduce fatal infections such as HIV and HCV that are often contracted through the reuse of needles. They provide referrals to treatment centers and recovery programs, helping those who wish to initiate treatment but don't know where to look or how to begin their journey of recovery. They provide housing and employment services for individuals who are struggling to get back on their feet. They provide drug testing to ensure that individuals are not using supplies that are contaminated with adulterants. But more than anything, these centers place humanity at the forefront of substance use disorders. On the night of May 21st, 2023, my brother passed away, alone at home after using drugs for what would be his last time. If he had had access to an overdose prevention center, I strongly believe that his death could have been prevented in at least 3 ways. For one, he could have spoken with a mental health counselor or a treatment coordinator who could have talked to him and alleviated his inner turmoil, potentially persuading him away from using again after being sober for 3 months. Second, he could have tested his drug supply and found that it was contaminated with a lethal dose of fentanyl, something that he was unaware of and that my family had learned after his death. And finally, he could have used those drugs under the careful supervision of another person, someone who could have ultimately brought him back to life after he overdosed. My brother Patrick is one of thousands of people whose life could have been saved had they had access to an overdose prevention center. We have the power to prevent further lives from being lost to the fateful disease that is addiction, and the establishment of an overdose prevention center is a critical first step in doing so. Thank you very much for your time.
Gabrielle, thank you very much. And as you were speaking, I was thinking about your brother and wondering what his name was, and realizing that I was remiss in not asking others who spoke previously. We'd love to hear their names and to honor them as well. So thank you for sharing part of your story and his story with us so that we can understand why this is so important. We really appreciate you. Senator Anwar.
Gabi, thank you so much for your beautiful testimony, and thank you for sharing your pain with us. It's heroic. Would you be able to speak how this has changed your life and the work you're hoping to be able to do and your plans for your PhD and your entire life, how this has impacted you?
Of course. I'm currently getting my Master of Public Health at the Yale School of Public Health, focusing on the socio-political determinants of substance use disorders, and I plan on pursuing a PhD in neuroscience to understand the neurological basis of addiction and substance use disorders, so that I can hopefully contribute to more evidence-based treatments in the future.
Thank you. And having a space, a safe space where people are going to survive their overdose, would that also help science advance?
Of course, you can, as everyone's been saying today, the first step to recovery, if someone wants to engage in recovery, is to be alive for that. These centers will save thousands of lives and allow us to be able to find more pharmacological or behavioral interventions that can potentially help people through their addiction, and we can only do that on people who have lived through addiction themselves.
And there's another aspect about identifying what substances are in the market. Would they help us identify what's in the market and then have information to the public in advance about different things that are there that can be more harmful and prevention strategies around that? Have you looked into that at all?
Yeah, I mean, the best way to find out what's currently in the market is to test current supplies, and that's something that overdose prevention centers offer, is drug testing. And that's how we can find out how things like xylazine, which is currently in the Connecticut drug supply, is impacting people who use drugs and how it's contributing to more overdoses.
Good. Have you, in your work in the last, I know you've been working on this for quite some time, have you come across any family that has lost a loved one who said to you that this is not a good idea?
No, not a single person has said that to me.
Okay, thank you so much. Thank you, Madam Co-Chair.
Thank you very much, Senator Anwar. Thank you so much for being here with us today.
Thank you.
And for your ongoing work, dedicating your life to this.
Thank you.
It's a gift. Next, we have Trish Rios online and Carson Ferrara, who is here with us in person. Welcome.
Thank you. Good afternoon. Thank you, Senator Anwar and the Public Health Committee. My name is Trish Rios. I'm the Director of New London County Cares at Alliance for Living. I'm also a person with lived experience in long-term recovery. I'm here representing the long-standing collaboration between Alliance for Living, Ledge Lake Health District, and the City of New London. Since 2016, our comprehensive harm reduction program has addressed the overdose epidemic through services that meet people where they are. What began with navigators, mobile treatment, and a syringe service program has grown into a coordinated system that increases access to care, strengthens overdose response, and removes barriers that prevent people from receiving life-saving support. Our services include drug checking, an on-site clinic, one of Connecticut's 4 harm reduction centers, a wellness hub, a harm reduction vending machine, and a Hep C cure program collaboration with Dr. Rick Altiste. These operate alongside HIV care, housing support, food access, mental health, and public health services. We are here in strong support of SB 195. We have lost too many friends and family members. Over the past year, our Harm Reduction Center has served over 300 individuals at risk of overdose. Our syringe service program reached 816 people, and our navigators connected with more than 1,200 individuals. These numbers reflect both the need and trust. The drug supply is increasingly unstable and dangerous. Overdoses are often reversed in the community and go unreported, masking the true scope of the crisis. More people are unhoused and forced to use alone, dramatically increasing the risk of death. Even those who are housed often hide their use because of stigma, again increasing fatal risks. Substances are frequently adulterated with xylazine and metabidine, causing severe wounds, infections, and additional health complications. Despite the clear need, harm reduction is under attack at the federal level, threatening funds not only for the services, but also for critical housing and public health programs. SB 195 is essential to preserving and strengthening evidence-based strategies that reduce overdose deaths, prevent infectious disease, and connect people to care with dignity and respect. In closing, I would like to share the words of one of our Harm Reduction Center participants. I'm a strong advocate for the overdose prevention centers for the following reason. I'm currently struggling in active and chaotic use, and a program like this would keep me from overdosing and dying alone. The safety of the community in which I live and care about is important. Having a center will cut down on people using their drugs outside in public restrooms, parks, and leaving behind used syringes and paraphernalia that could transmit disease or harm to another person. I'm a father, and the thought of a child finding a used needle and experiencing a needle stick is awful. I also know that in addition to a safe place to use with medical attention, a safe use site offers support and resources by staff that are supportive and understanding to people who use drugs. Thank you for your consideration.
Trish, thank you so much for your testimony and for the work that you do as well. I believe Senator Anwar has a question for you.
Thank you, Trish, for your testimony. Trish, I know you're in New London. I was looking at some of the data in the recent past. The number of deaths in I was not allowed to say what I wanted to say. Can you hear me?
Yes.
Can you hear me now?
Yes.
No.
Yes.
Well, checking, check 1, 2. We'll be in recess for a second as we try and check 1, 2, 3. Check. Sorry, that's ease. But nobody heard me anyway, right? Trish, can you hear me?
Yes.
Trish, I'm using the Zoom mic for connecting with you. Oh, she can. I just wanted to know that she's waiting. Trish, we are having some difficulty with the mic system, so just wait for a second. We're going to.
Okay.
Thanks.
Thanks.
Check. Oh, okay, we are back in again. All right, we are back in the situation. Well, this whole exercise was also to make a point that it's not only happening when my Republican colleagues are asking questions, it's happening when the Democrats also ask the questions. So we have established that fact. Trish, back to you. I've looked at the death rates and the challenges in New London. There has been an increase in the last many months. Do you have an understanding why that's happening more in New London right now compared to other parts of our state?
I mean, I would definitely think it's the drug supply, housing, the chaotic use. I really think the drug supply is probably the biggest one.
Okay, this is very helpful. Thank you for your testimony, and I can share with you that Senator Marks, one of our colleagues, is speaking about the challenges that are happening. Oh, as soon as I mention her name, she's raising her hand. But this is something that she's been raising awareness every time we have a conversation. She lives and breathes the concerns of the community there. So, Senator Marks, perfect timing.
Yeah, thank you, Chair. Just want to thank you for your testimony. I was unfortunately on another meeting, but I am here now, and I think I'll be here for a long time. But thank you for all you do. I'm very aware of all you do, and we're here to make your outcomes better and your lives easier.
Thank you.
Thank you. Seeing no other questions or comments, Trish, thank you so much. And we'll ask the next person who's on our list. That is Carson Ferreira. Welcome, Carson. Actually, just turn the mic on. There's your computer, no, the other one. Your laptop is right there. You go. Perfect.
All right. Good afternoon, everyone. It's good to be back here. I would ask for your full attention while I'm testifying, the legislators. I would appreciate it. My name is Carson Ferrara, and I'm the hospital liaison for the CLEAR initiative at Liberation Programs, where I work with people at the highest risk of overdose in Fairfield County. I'm here today in strong support of SB 195. Since this bill didn't pass last year, at least 519 people have died in Connecticut from preventable overdoses, and at least 3,095 people have died since the bill was first introduced in 2023. These are not abstract numbers. These are people who are dying because our current system cannot reach them in time. As you've heard, overdose prevention centers fill that gap. They keep people alive long enough to access medications for opioid use disorder, housing support, medical care, and treatment when they're ready. Just last month, I was here. I presented the state of the science on OPCs with Dr. Brandon Marshall at the Moving Beyond Implications Conference. We reviewed rigorous US data and emergent findings from Rhode Island's first state-authorized OPC. In Providence, Project Weber Renew has supported over 7,900 visits, intervened in 173 life-threatening events, prevented 91 potentially fatal overdoses, and provided more than 2,600 clinical services within the OPC itself, such as getting people on buprenorphine or methadone in under a year. This is what public health success looks like. I also want to directly address a question raised earlier by some representatives that safe injection sites do not help people get off of drugs. That is factually incorrect. Decades of research from Vancouver, New York City, and now Rhode Island show that people who use OPCs are more likely to enter medically managed withdrawal, start MOUD, and engage in treatment. One study found that 42% of people who participate in an OPC, not in treatment at baseline, entered treatment within 2 years. I also want to address the legal question that keeps coming up, with the caveat that I am not a legal scholar, but Scott Burris, one of the nation's leading public health law scholars, testified to this committee last year that the commonly cited barrier, Section 856 of the Controlled Substances Act, was never meant to apply to medical or public health programs, only drug distribution venues. Connecticut has full authority to authorize OPCs under the state's police power, giving this legislature plenary authority to enact this intervention. And Rhode Island has proved that, operating openly for a year with zero federal interference. The legal barrier is not real, in my opinion, but the overdose death toll is. Finally, I want to say this with respect, but also with honesty. Last year, several members of this committee asked for data before moving a bill like this forward. I sent many of you that data, and have included it again in my testimony this year, now with the addition of data from Rhode Island. And despite that, many of you still voted no. And to be honest, that leaves us with two possibilities in my view. Either the information wasn't read, or it was read, and yet stigma and long-held moral beliefs about drug use were still allowed to outweigh the evidence, public health, and the value of human life. We can't afford that anymore. People are dying while we debate whether they deserve safety. The data is here, the need is here, and the opportunity to save lives is here. Supporting SB 195 means choosing evidence over stigma, compassion over fear, and life over avoidable death. OPCs do one thing better than anything we have now. They keep people alive long enough to reach treatment. Thank you for your time, and I'm happy to answer any questions.
Thank you, Carson, for being here today. And I will just say that there are many things that we are doing as we're hosting a hearing. So I appreciate you asking us to pay attention, and I think that you have the attention of the people who are here.
Thank you.
But we have to juggle a lot. So I just want to name that as we're going forward. I appreciate the data that you have shared, and I will also just ask you to repeat again, when you were here earlier this year, Rep. Foster had organized a forum.
Mm-hmm.
You were here with a professor from Brown. Can you just share a little bit about who that professor is, what that work is, in conjunction with the Rhode Island Center, and speak to that a little bit more, please?
Yeah, absolutely. So Dr. Brandon Marshall is an epidemiologist out of the Brown School of Public Health. He and Dr. Magda Serta of NYU are running a federally funded study called the SAFER Study, which is evaluating the overdose prevention centers in New York City and now in Rhode Island. And they are assessing preliminary qualitative and quantitative data on things like crime in the areas surrounding the OPCs, connections to treatment services, which I mentioned, community acceptability, and in the policy brief that I gave to you all, there's also some quotes from participants that were at the various OPCs to get the qualitative perspective. their findings are going to be published very soon, but I can just say from the preliminary stuff that I've seen, it aligns with the decades of research that's happened around the world that OPCs save lives. They increase the likelihood that someone is going to access treatment. They do not increase the likelihood that someone who wasn't using drugs before is going to start using drugs. And they offer people connections to many different services, including housing, primary care, and what we know works for substance use disorder, buprenorphine, methadone, naltrexone, those things.
Thank you for that. I want to highlight one of the things you said, which is that it does, that research is showing that it does increase people's likelihood to access treatment.
Yes, exactly.
Okay, thank you for that. And then your testimony, if you could submit written testimony, that would be wonderful.
Yes, absolutely. I've submitted
Okay.
written testimony.
Thank you. Senator Anwar, to be followed by Senator Gordon.
Thank you so much, Carson, for your testimony. I did not see your testimony yet uploaded, but there's important data. Would you be able to speak to just the Rhode Island data again? You're very fast, and I think it's some things to be highlighted. Now, keep in mind, for the benefit of everybody else, this place is about 1 hour, 40 minutes from where we are right now. 1 hour, 45 minutes, depending on the traffic. So this is next to us, part of our community in this region, and it is legal. The governor has signed that bill, and they are using state funding to be able to save lives. So I think that's a backdrop of people need to understand. Has anybody been imprisoned for, any legislator has been imprisoned, or the people have been put to check by the federal government when this was started, and then it's still functioning?
No, not at all. As a matter of fact, other states have moved forward with legislation to authorize OPCs, including Vermont, who will be opening one in the coming years, and I believe Minnesota. So many states are understanding the legal argument that I paraphrased from Scott Burris, that states have the power to enact life-saving legislation like this. In terms of the data out of Project Weber Renew itself, which is the name of the facility in Providence, they prevented 91 potentially fatal overdoses, intervened in 173 life-threatening events. So that could be with additional oxygen for someone that was using, or other scenarios. And then more than 2,600 clinical services within the building through VICTA, which is the partnership. I know that they have attending physicians from Brown University School of Medicine that are there working with folks who might not even use the safe consumption space in the OPC, but rather are there to use any of the other services. So it really is a comprehensive wrap-around building that myself and my team had the opportunity to visit a few months ago. And I think there's just a misconception among a lot of folks about just how successful these facilities are in helping folks.
And can you speak about the legal arguments again, and even if you paraphrase from the previous testimony, but if you can speak to that a little bit more.
Yeah, so my understanding, based on Scott Burris's testimony, is that the state's police power gives you all plenary authority to enact public health interventions like OPCs to protect the health and welfare of residents here, as Rhode Island has done and now as Vermont has now done. The statute in question in the Controlled Substances Act, including its history and case law, focuses on profit-driven drug dens and distribution sites. Whereas a state-authorized, clinically staffed harm reduction facility, like an overdose prevention center that prevents death and connects people to care, is not what Section 856 was aimed at. And then also, he has said that the state authorization changes the legal analysis dramatically, and that under this Controlled Substance Act's savings clause, federal law and state health law must be read compatibly unless there is a positive conflict, so the two cannot consistently stand together. And a state-authorized OPC structured as a health program is not in positive conflict with Section 856. It's a public health use operating under state police powers.
This is very helpful because, and I think if Connecticut was saying that we are afraid of this whole decision because of this concern about the federal law,
yep,
based on the public health aspect and the fact that the states have the right to manage their own public health in their community, which is the smart thing to do, and that's the law, they're able to enact this without having a negative impact from the federal government and coming and shutting that down, because New York has had it for 3+ years now, and now it's more than a year for Rhode Island.
Yes.
Okay, so how would you be able to share that with somebody who's just used the federal card as soon as you have that conversation and say, well, there's a federal law, I'm scared of that? How do you do that when people are dying at the same time? But as a kind way of educating that person, how would you do that?
Yeah, I mean, I think just sharing the evidence as we're doing here today is the most effective way that we have to sway people's opinions. I also think that some of the holdup is more of a stigma-driven holdup about what it means to effectively treat people who have addictions. And I don't just mean treat medically, I mean as human beings. I think that growing up in the US especially, we're all taught that drug use is bad, abstaining is good, and it's not me condoning drug use at all, but it just doesn't meet the lived experience and the reality of where we live, and where no amount of drug seizures or punitive measures are going to fix this problem when there's an ever-changing drug supply. We saw the opioid crisis move from prescription opioids to heroin to fentanyl, and now there's plenty of other adulterants in the drug supply like medetomidine and xylazine. So these facilities are our best way to save lives, and again, they do increase the likelihood that someone will access treatment.
This is very helpful. Thank you so much for your testimony, and thank you for the work you do every day.
Thank you.
Thank you.
Thank you, Senator Anwar. Senator Gordon.
Thank you, Madam Chair. And I don't so much have a question as I just want to clarify something you said. You had said that folks who voted no on this legislation or the bill previously had one of two reasons. One is didn't read the testimony, or because of stigma or whatever reasons chose to vote no. That's actually not correct. There is also a third valid reason, which is concerns about legality. I think one has to be understanding that the facts are that to what degree you like the federal law, don't like the federal law, there is still federal law. And there may be some uncertainty that some people have concerns about relative to the federal law, but that hasn't been fully adjudicated to say that the federal law doesn't apply. So I just want to clarify for the record that there is more than one legitimate concern. Even if someone's read the testimony and doesn't feel that there's a stigma attached that we don't want to do something more. So I just want to state that for the record, because I don't think it's factual to say that voting no falls into one of those two categories. Thank you.
Yeah, I think it might not be the
Thank
case
you.
for you personally. I think there are some cases of people in this room where I know for a fact that two of the reasons I mentioned are factual.
So,
Thank you.
I just want to
Thank
say
you.
you can't say that across the board, so you just need to be careful about that. Thank
Understood. Thank you.
Thank you, Senator Gordon. We will often say here that it's assuming intent. It can be a dangerous thing. When you've had specific conversations, that's a little different. So
Yeah, exactly.
thank you, Senator Gordon.
Thank you.
Seeing no other comments or questions, thank you, Carson, for being here today and for all of your work on an ongoing basis. Next, we have Diane Santos, who's here with us in person, followed by Dr. Ashka Shah. Ms. Santos, welcome. It's nice to see you.
Co-chairs, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Diane Santos from Norwich, and I thank you for the opportunity to testify on behalf of myself in support of SB 195. On December 30th, 2023, My 26-year-old son, Mark Andrew Collins, died of an overdose from a toxic combination of substances. My young granddaughter and I found him on his bedroom floor, and first responders explained it was too late to administer Narcan. Mark's opioid use had become chaotic, so he asked for help finding medically assisted treatment. His attempts to stop using on his own were unsuccessful due to the excruciating physical, mental, and emotional effects of withdrawal. We couldn't find immediate help, so we visited the emergency room at Bacchus Hospital. Their solution was to have a recovery coach give us a number to call, then convince us to leave. 36 hours later, my son was dead, turned away from a hospital that had buprenorphine on hand. This medication, considered the gold standard in opioid use treatment, was never offered. Our tragedy exposed massive gaps within available systems, with community programs being overwhelmed and hospital emergency rooms refusing to treat substance use disorder. Mark's only options were abstinence or death. Overdose prevention centers fill those gaps. They do not increase drug use and are not the opposite of recovery. They are often the pathway to it. OPCs provide clean supplies to lower risk of disease, improve safety by reducing public use and litter, save costs on emergency services, connect people to health care, drug treatment, and housing, while providing an environment free from stigma and judgment. OPCs also offer space for safe consumption, not only safe injection, but safe consumption, where pre-obtained substances can be tested for dangerous adulterants, and staff is on hand to reverse overdoses if they occur. This does not enable drug use. It enables people to stay alive. There has never been one death at any overdose prevention center. Bills to establish OPCs in our state were brought in 2023, 2025, and now again in 2026, along with a multitude of data proving the efficacy of supervised consumption. Some view drug use as a moral failing or a choice, when the real moral failing here is having the opportunity to provide a life-saving option, but making the choice not to. Rhode Island and New York are operating these facilities, yet Connecticut watches and waits while our residents die preventable deaths. Overdose prevention centers prevent overdoses and will save Connecticut lives. This is my second year being here to testify in the 2 years since I lost my child, and this is a much needed option for people who use substances in our state. Thank you.
Thank you so much, Ms. Santos, for being such a strong advocate and for remaining persistent. We are very grateful. Senator Anwar.
Thank you so much for your testimony, and thank you for working hard to raise awareness every single day. You're and coming and speaking to us. You know, one of the things that you mentioned about going to the emergency room and not having an option of treatment, we have another bill, and this is a Public Health Committee bill. We are going to actually require all the emergency departments to be able to write a prescription and provide the treatment, so that there's no wrong door at that time. So if somebody cannot get into an inpatient or outpatient facility, they can go to the emergency room and be part of that treatment plan. So this has worked. This has improved recovery chances significantly. And California has shown this. We are going to do this in Connecticut as well, if this Public Health Committee votes for this, and the rest of the body in this building and votes for this, and the governor is willing to sign that. So that's another bill we are trying to save. There is, I think, as a state, we owe it to all the people, the innocent people who have died, that we do everything and anything that we can to prevent these deaths. And we actually celebrate on our highways how many deaths we have been able to prevent, and we still recognize how many people have died. And the number of people who are dying because of overdose, preventable deaths, nobody wants to even, that's hidden now because that data is not even shown anymore. But the number of deaths are far more than the motor vehicle accidents. Every death is preventable, it should be prevented, but we cannot pick and choose who we want to save and who we don't.
Exactly.
And every time you come and speak, you highlight that aspect, and it's important for us to recognize that we have to prevent every single death, and put this out there so that we can recognize this now. For us to find out how many people have died from motor vehicles, easy. For the opioids, can't find that out anymore, especially since some of us have started to speak about it. The data is hidden, and as a result, that's a stigma in policy and action. So thank you so much.
Thank you, Senator. If I could just mention,
Yes.
because you mentioned the bill for the emergency rooms, I was invited in December of 2025 to speak at Grand Rounds at Bacchus Hospital by an addiction medicine specialist to share my son's emergency room experience. And on May 19th, I will be the keynote speaker at Hartford Hospital in a similar discussion where addiction medicine providers across the state are attempting to change the climate in emergency rooms. So I'm very interested in the coming bill. Thank you.
Thank you so much. Thank you for your testimony.
Welcome. Thank you very much, Diane. Next, we have Dr. Ashka Shah, to be followed by Robert Loftus. I believe both are here in person with us. Thank you and welcome.
Good afternoon, members of the Public Health Committee. My name is Ashka Shah, and I am a resident physician at Yale and a researcher on private equity in healthcare. I recently presented my findings at the American Public Health Association conference this past winter. I am here to voice my support for Senate Bill 196 to restrict private equity ownership of hospitals and specifically target the undue control of healthcare provider clinical judgment. My key reasons for supporting the bill are as follows. First, my own research as well as national studies have shown the detrimental impacts of private equity acquisition on hospitals, including a 25% increase in hospital-acquired conditions such as falls and central line-associated bloodstream infections, as well as a decrease in staffing ratios in critical staffing-sensitive areas, including the ED and the ICU. Beyond quality of care concerns, private equity-backed companies accounted for 88% of the largest healthcare bankruptcies in 2024. Through a combination of asset stripping, high leverage buyouts, staff layoffs, roll-ups, and sale-leaseback agreements, private equity firms strip their targets of financial capital and inevitably lead them to bankruptcy. Second, most states, including Connecticut, have corporate practice of medicine laws, which require medical practices be controlled by healthcare providers. However, a lack of enforcement, as well as loopholes in legislation, allow private equity firms to continue to control the decision-making of healthcare providers across the country. This is further validated by my own research surveying healthcare providers, where the most common challenges reported were feeling pressure to increase utilization to turn out profits, limited physician and nursing staffing, and meeting productivity quotas, among others. When asked whether they brought up their concerns to management, 80% of respondents stated yes. However, responses from supervisors included dismissing concerns, or worse, reprimanding employees for coming forward and even terminating employment altogether. I have several recommendations for the bill to make it stronger, including to clearly define what controlling interest is and what a joint venture is, as these are exempt from the bill, and to allow for an expanded review process for sale-leaseback agreements. It has been 3 years since the first private equity-related bill was proposed in Connecticut. Since then, 7 states have passed legislation restricting private equity in healthcare, from increased government oversight to strengthened corporate practice of medicine laws and reporting requirements. And private equity isn't stopping. Last year was a record deal amount for private equity in healthcare. $191 billion was invested in healthcare. The time is now for Connecticut to step up and stop private equity, at least in hospitals, as the first step. Thank you for your time. Happy to answer questions.
Thank you so much. Thank you for your research and for your commitment. I know you've been here before, and we're grateful that you've come back. Just wanted to follow up on something that you just said about what multiple states have done related to this issue. Can you give us a few states and a few examples? Of course, you are prepared for that. I knew you would be, even without, we didn't talk beforehand. But
Yeah.
that would be, it would be helpful, especially if there are some neighboring states that you could speak to. That'd be great. Thank you.
Absolutely. So Massachusetts in January of 2025 signed legislation, perhaps the most expansive legislation around private equity, involving review of all private equity associated transactions at the state level. So the Health Policy Commission, which is a special sort of group, kind of almost similar to the OHS, but a little bit different in that they're independent, actually would be reviewing all private equity related transactions. And they were the first state to ban sale leaseback agreements of any hospital property. So those are the two big components of the bill. And it required any sort of merger acquisition to also be under review by the government. And they give 60-day notice after the application has been submitted by a hospital or a firm asking for acquisition, and they promise to tell them within 60 days afterward. Other states that have done work include Oregon and California, who have expanded corporate practice of medicine laws, specifically saying that private equity cannot control the decision-making of healthcare providers. And also expanding whistleblower protection specifically, as is shown in my research, where unfortunately employees are forced to sometimes stop working, get fired because of this. And we have several states this legislative cycle that are also considering legislation along with us. Most of the legislation is around increased government oversight, similar to the governor's bill last year, 6873, I believe, and would be increasing kind of the government's understanding of what's happening on their own turf, what transactions are happening, what mergers and what acquisitions are happening, and allowing for a pre-review process at a lower threshold than is currently set right now under federal standards.
Thank you for that. I appreciate that. And just to follow up, the Massachusetts any merger and acquisition, that's across the board. You may have heard earlier today at our committee meeting, which is in recess, but we have a bill, another bill.
Yes.
But just curious about that comment.
Yeah.
Is it inclusive?
Yes, it is inclusive. They have this separate commission, the Health Policy Commission, that has the bandwidth to do this work. And actually, previous to me being in Connecticut, I spent time going to the Health Policy Commission. They have yearly meetings where they talk about the cost benchmark growth, and they're required to talk about any private equity moves that are happening and how it could affect the cost benchmark growth every year in Massachusetts.
Thank you very much for your testimony. Senator Anwar.
Thank you so much, Madam Co-Chair. Thank you so much, Dr. Shah, for your testimony and the work that you've been doing. Your previous testimony, the last session, was very powerful, very helpful. The data was very clear. Then your op-ed was very helpful as well. And then you've really done a pretty significant deep dive into the situation. If we had limited resources as a state, what are the 3-4 areas that we should control from private equity in healthcare?
Yeah, I think the biggest is hospitals, by far and away. Other sort of upcoming private equity acquisitions that are happening that they're looking into, including hospice facilities. Those are another big move out.
Hospice?
Yeah, hospice facilities. Another big move is home health. They're actually looking very keenly on home health agencies, home hospice agencies, and then of course outpatient practices, right? We talked a lot about MSOs last year, but outside of MSOs, they're still taking over practices entirely, not in an MSO agreement, where they have control and ownership over, the day-to-day activities. And so I worry dental clinics, vet clinics, all of these clinics, vision clinics, ophthalmology practices, they're all being taken up by private equity. So these are the big buckets of, unfortunately, where they're targeting. And so I would focus on that. The other thing I would focus on is the sale-leaseback agreement. We know that's one of their biggest weapons they have in their arsenal, and so we should try our hardest to try to, at the very least, if we could restrict or review these transactions to begin with as a pre-review, but also potentially banning them altogether, like Massachusetts has done, at least for hospitals. Right. Yeah.
So because of how the deep and convoluted the tentacles of private equity is,
Yeah.
there are a number of different ways that we are going to probably look at this. One is the bill that you're testifying on.
Yeah.
There is a bill that the governor's office has, which is on the CON process, and
Yes.
and they're trying to look at it from that angle too.
Yeah.
So that's going to probably highlight this sale leaseback strategy that they may have.
Yeah.
And I think the bill that we are proposing today with on the current meeting that we are still in recess for,
Yeah.
there is an opportunity, but that also leads to saying that even one physician practice to the other, if there's two physician practices joining, that would actually be a trigger, which sounds more inefficient. Rather than looking at the big companies buying big hospitals, why do we want all the state employees to look at small transactions? Can you help me understand what other states have done around that aspect?
Yeah, I would say most of the state legislation is around reviewing transactions specifically with private equity and including MSOs. So Massachusetts includes MSOs in that. Unfortunately, and I agree, but based on the resources that we have in Connecticut, it's not a priority. It shouldn't be a priority. We should be prioritizing hospitals. For sure. We see the biggest impacts in hospitals. We see the quality of care concerns in hospitals. And MSOs, where there's a minority stake, where private equity has no sort of controlling, and managerial ownership over the practice, private equity really functions more like venture capital in those agreements, because they're really just providing a minority stake, a little bit of, upfront capital, but they're not expecting any sort of managerial jurisdiction over the practice. So I agree that the priority should be on hospitals and bigger facilities, rehab facilities, nursing homes, absolutely, over these smaller practices.
And if there was legislatively something we can write on the MSO part of the bill that would have a protection for our state, should that be rather than checking every single MSO and having the Attorney General or the Office of Health Strategies, which may be disbanded or changed.
Right.
So with that limitation, should we have legislative fix on the MSO part so that we can actually have a protection for healthcare on the outpatient setting and also the joint ventures, so that would protect us rather than having to have everything be reviewed?
Yeah, I agree. I think that makes sense, because we have to prioritize the actual transactions that are going to be, unfortunately, the worst for patient care, and the ones that we worry about causing significant damage financially to the hospitals. So having an exemption, for example, for MSOs, I think, again, this is a first step for us in Connecticut. This is the first sort of legislation we'll have around private equity, and I think focusing on hospitals and bigger facilities makes sense, with the exception of MSOs, yeah.
Okay, this is very helpful. Thank you again for your testimony. We get a lot of help from your efforts. Thank you, Madam Co-Chair.
Thank you, Senator Anwar. I'd like to go back to something you said a moment ago, that private equity functions as venture capital. We're public health, so
Yeah.
most of us don't speak that language. Can you just talk about that? We tend
Yeah.
to use the term private equity really broadly and loosely here, and
Yeah.
actually across the board when we talk about this issue. So can you speak to those different funding mechanisms? Because we've heard very clearly from many of our healthcare providers that they rely on private equity investment in many spaces right now in all kinds of healthcare settings.
Yeah.
And that's because we as the government are not funding those, we could talk, we're not the Committee for Medicaid Rates, that's Human Services. But we all hear about that when we meet with our stakeholders who come before us here. So
Yeah.
if you can just dive into that a little bit more, just to help us understand. And I hear what you said in terms of prioritizing with the hospitals, but we know that this is across the board everywhere. So just if you could speak to that, that'd be great.
Absolutely. It's a great question. I think VC and PE are oftentimes conflated, and people kind of think they're the same thing, but they operate in very different models. So starting with venture capital tends to invest in early stage development, right? So R&D, biotech startups, and they are what is called as seed investors, meaning they plant the seed and they allow the company to grow, and they want the company to grow. And they normally have a minority stake in the company, meaning 10%, maybe less, that they're actually giving equity-wise, and they do not control the day-to-day activities of that organization. They're truly just funding, there's truly just a funding mechanism for whatever company or startup or organization that they fund. And again, they're mostly focused on biotech and less so on like actual hospital facilities. Private equity comes in, and this is across all sectors, not just healthcare. They come in late stage. They come in when a facility is nearing bankruptcy, and they say, we can come in and we can try to fix this. But what they really do is they take ownership, and through leverage buyouts and through asset stripping, they strip that entire company and facility, and I can talk more about what that means, completely, and then leave them out to dry, because their priority is not to eventually make this profitable. Their priority is to get as much money back to investors and then leave and exit that investment. Venture capital, their priority is to make the company profitable so that they can then sell their stake to another venture capital company or potentially sell it back to the company once they become profitable. What do I mean by leverage buyouts and asset stripping? So I will use the story of Prospect Medical to kind of center us here. So back in 2010, Leonard Green and Partners, they took a majority stake into Prospect Medical, 68% majority stake at roughly $363 million. So they invested $363 million. But the $363 million was not actually coming out of their own pockets, this Leonard Green and Partners. Private equity firms only normally pay 30 to 40% out of their own pockets. And then they take out loans, high interest loans, they take out massive amounts of debts, bonds, and they put it under the name of the company that they bought out. So this company, as soon as they take over ownership, has already amassed incredible amounts of debt at the very beginning of that relationship. And then they say, how can we bring back money quicker for our investors? We're going to charge professional fees. We're going to say that we are a managerial sort of professional organization that's helping and consulting this company. So now we're going to make the Prospect Medical pay us money for that as well. But we want money faster. We want money faster for our investors. Let's put them in a sale leaseback agreement so we can get $100 million a year off the land that these hospitals are living on. And they do this, and years pass, and unfortunately, as soon as they see that the company is going to go bankrupt, they exit the investment, which is exactly what they did. And Prospect Medical is left with enormous amounts of debt, and this pertains to, like I said, all sectors. Red Lobster, like Toys R Us, Best Buy. They've continued to play the same playbook through all of their investments. And unfortunately now Prospect Medical has fixed costs that they know that they're going to try to fix, so they say, let's try to decrease staffing, which is exactly what they did. We're not going to pay vendors. We're going to not allow infrastructure to happen. Ceilings were crumbling at Rockville General. We're going to actually stop the ED services, and we're going to stop mental health care. So they stopped the ED department and mental health care. Other private equity-owned hospitals have stopped entire departments like L&D, labor and delivery, pediatric services that maybe don't reimburse at the same level. So this is what happens, and it continues to happen with every investment that private equity unfortunately takes over in the healthcare industry and beyond.
Thank you for that. Yeah, I think the reality is, yes, these investments are happening in every space, across every sector, and that will continue to happen, which is why we continue to have the conversation here at this table as to how we either say no or how we review these transactions, because there are three ways to fund healthcare: private dollars, public dollars, or a combination of both. And the less we fund with public dollars, the more pressure on the private setting to provide, or the more opportunity, depending on how you're looking at it. So I really appreciate you going through that. I think that will be helpful to us as we look forward on both the bills here today and perhaps others going forward, and hope to continue the conversation with you in the future as well.
Of course,
Thank you. Other questions or comments? Let me just double check on Zoom. Nope. Thank you so much for being here with us today. Next we have Robert Loftus, followed by Shannon Lane.
Hi, how's it going? Thanks for letting me speak.
Welcome.
I was here last year on Zoom. My name's Rob Loftus. I recently became a recovery coach. I just passed, I just took the CCAR class and did my 50 hours for that. I'm also a person in long-term recovery. I've got over 7.5 years sober from all drugs and alcohol. I'm also a former outreach worker for Oxford House and a former shelter coordinator for Flagstaff Shelter Services out in Arizona. To repeat what was said earlier, I was listening to everyone speak and hearing that 519 people have died since the last time this bill was proposed was, it really incensed me. That's 2.14 people a day. And there have been people that I have known personally that have died in the last couple of years, that if there was anything that I could do to help reverse that, like, I would have. Working at Flagstaff Shelter Services, I personally reversed overdoses a number of times because there were people who were struggling with substance use disorder, living at the shelter. As an outreach worker for Oxford House, I instructed people how to use Narcan, how to perform a overdose reversal, how to administer Narcan. All of that to say, it just makes me so angry that all of those people died when this bill could have been passed previously. And substances may be federally illegal, but that hasn't stopped them from being made or imported into the country. And denying persons who struggle with substance use disorder access to crucial care they need to survive is equivalent to denying a diabetic their insulin or a cancer patient their chemotherapy. It is worrisome that the amount of deaths since this last was discussed have risen, and it concerns me that some elected officials have displayed an attitude that is less than nurturing towards their constituents affected. That's all I have to say. Thank you.
Thank you, Mr. Loftus. Thank you for the work that you've done to help save and support so many people. We appreciate that, and for being here today with us. Senator Anwar.
Rob, thank you for your testimony, and thank you for sharing your journey into rehab and helping others. So, and also being physically here and speaking about this and being an advocate. So we appreciate you. Your words mean a lot to all of us. Thank you.
Thank you. My driver's license is no longer suspended, so I was able to drive here from New York.
Thank you. Excellent. Good.
Wonderful. Thank you so much. And thank you for sharing that. It's a great example of, step by step. Earlier when someone was testifying, I was thinking about Adam Grant. For those of you who don't follow him, I will commend you to check him out. He's an organizational psychologist and someone who talks about how we make changes in our life. So with that, I see Shannon Lane is actually online. Welcome, Shannon, and you will be followed by Anna Jane Yolkin. Welcome. Please proceed.
Thank you so much. Good afternoon, everybody. Thank you, Representative McCarthy-Vahey and Senator Anwar and the rest of the Public Health Committee, particularly my legislator, Representative Zepkis. I appreciate the opportunity to be here. I'd like to talk with you about House Bill 5166, which is an act concerning social work licensure. And a little bit of extra pressure for me, my entire class at the University of Connecticut School of Social Work is watching right now. So say hi to them. I am a social worker, and I am the director of the Nancy A. Humphreys Institute for Political Social Work at the University of Connecticut. But I'm not here today speaking on behalf of UConn. I'm here because I've been a social worker for 25 years, and I've taught at 5 different schools of social work in the last 2 decades. I believe really strongly in the future of social work education to produce qualified social workers like Representative McCarthy-Vahey, who can improve the well-being of individuals, families, communities, and organizations here in Connecticut and across the country. And I wanted to thank this committee for considering the legislation that would eliminate the LMSW exam as a requirement to practice as a licensed social worker in Connecticut. The LMSW exam is an expensive and biased barrier for many social workers to practice in the state. Social workers who get to the point of taking the LMSW exam have already completed an accredited master's degree from a school of social work, a minimum of 2 years of coursework that includes practice skills, theory, research, and policy. Our social workers have also completed 2 years of intensive internships within community agencies under the close supervision of an experienced practitioner. I think it's worth considering whether a multiple choice exam of any kind could assess whether a person is prepared to be a social worker. And I believe that the extensive interaction that our students have with faculty in the classroom and their supervisors in their internship are a much better way to capture their readiness for practice. In addition, the exam that's currently used is administered by the Association of Social Work Boards. And after a long period when they would not share detailed information about their exam, it has now been shown to have significant disparities in pass rates. The test takers most affected are those who are not white, those who are older, and those for whom English is not their first language. The reasons for these disparities are complex and they're challenging to address, but what we do know is as it currently exists, the exam makes it harder for social workers that we need for competent, culturally appropriate services in our communities. And when I wrote my testimony today, I was thinking of a social worker who was an outstanding student during her MSW program. She was providing exceptional services in Spanish for a community that really lacked Spanish language services, both in her internship and in her first job after graduation. She really struggled with the ASWB exam to the point that she ended up paying a significant amount of money out of pocket for a test preparation coach. This was after the cost for her and her family for her to go through and pay for and graduate from an MSW program, the cost to apply for licensure in the first place, the cost of her original test preparation services, and the cost of taking the test multiple times, because every time you take the test, you pay an additional $230, which was a huge amount of money for this student and her family. I hope you will keep this student and the members of her community who deserve quality social work care in your mind as you're considering this legislation. I appreciate the committee's time so much, and I'm happy to answer any questions that you have.
Thank you so much, Shannon, for your testimony, and tell your class hello and that you did an excellent job.
Okay, thank you, I will.
Give you an A+. I want to ask a clarifying question, and you've heard some of the testimony here today. You're the first person to talk to us about this issue, so as often happens, you may get more of the questions, although I know we do have some others testifying a little bit later. But this is not a request to remove the LCSW license. Can you just speak to the difference between the LMSW and the LCSW license?
Absolutely. So the LMSW license is the license that we expect social workers to go for after they complete their MSW. So sort of as they're entering the professional world. And this bill would not get rid of any of the other requirements for that LMSW license, just to be clear, right? It doesn't remove your requirements for your internship and your coursework, being able to fulfill the application in good standing. At the LCSW level, which in Connecticut does also require an exam, the LCSW also requires a substantial amount of independent practice under the supervision of somebody who's appropriate. And the LCSW exam allows people to practice at a more independent level than the LMSW exam in terms of the kinds of work you can do and the kinds of work that you can be reimbursed for from, say, an insurance company.
Thank you. And another follow-up question to that. Someone with an LMSW, what kind of supervision requirements are there for them by other social workers or others?
So a lot of that will depend on what job they have. So some of those requirements would depend on the kind of work they're doing, the agency they're in, and who's funding that work. So for example, for me, I have my LMSW. I'm a professor at UConn. There's no specific requirements in the law for me to do continuing supervision, although I do because that's important to me in my professional development. What is required in the law is that social workers at the LMSW level continue to complete continuing education every year as outlined by the state legislature. Continuing education on things like ethics. We do a certain amount of work on, working with veterans and other specific populations to make sure that we keep our skills continually updated and we're accessing recent research and up-to-date knowledge about the profession.
Thank you, Shannon, and I will leave you be for now because I know there are some others who are coming to testify, and I will ask and save some of those questions for them. Seeing no other questions, I am going to say thank you so much for being with us, and I hope you have a great time with your class.
Thank you.
Next, we have Anna Jane Yolkin, who's with us on Zoom, who will be followed by William Moffitt, who I believe is here in person. Anna Jane, welcome.
Hi, thank you so much, Chair and members of the committee. My name is Anna Jane Yulkin. I'm from Project Weber Renew here in support of Bill 195. Project Weber Renew is the nonprofit organization in your neighboring state of Rhode Island that operates the country's only state-sanctioned and Department of Health regulated overdose prevention center. So I've heard a lot of questions about what actually an overdose prevention center looks like, what our services are. So I'm here. Really, I haven't asked me anything type of policy. If people do have questions, I also really welcome anyone who wants to come take a visit and come to our site here in Providence to see what we do. I pulled some data from the past 13 months of our operations here in Providence. As of about 2:30 p.m. today, we've had 9,300 visits from almost 800 unique individuals. And that's just for the Overdose Prevention Center. That's just for the safe consumption service that is being considered in this bill. We have many, many, many other services in this building. And I think that's a big takeaway when people come and visit is they say, oh, this overdose prevention center is actually just a really small piece of the puzzle. It's a really important piece because it's a piece that shows that we care about people, that we care about people who are currently using substances. It's an important piece because it saves lives, and that's so important. And it's an important piece because it brings people and connects people to other services, but it is only one of many other services. We've had about 3,000 clinical visits through our clinical partner, and that's substance use treatment, that's physical health, that's behavioral health services. We've intervened in 104 different overdoses and only had to call EMS 2 times. So that's over 100 times that law enforcement and first responders didn't have to show up and they could focus on the other really important needs in our community. I think just anecdotally, what we've seen is we've seen people who come in for care at the Overdose Prevention Center. They're getting connected with housing case management services. They're having their wounds being taken care of. They're doing their laundries. They're taking a shower. They're doing these things that really, really support people. And I'm here to show that in Rhode Island, again, a neighboring state, not too different from Connecticut, we are doing it. And we really would love to have the support and camaraderie of our neighbors, such as yourself, in doing that. And we're here to help provide any support. I will say there's been a lot of concerns about legality, right? Like I said, we've been open for the past 13 months and we show that it can be possible. And I think really we are taking a states' rights approach in this and so many other topics in our country, whether it's things like cannabis legalization and whatever the case may be. And we really see that this is a moment where states can take efforts to lead, to save lives and really to lead the way for public health. So with that, that's all I'm going to say now, but I definitely welcome any questions people have, especially around the actual operations of an overdose prevention center in a similar environment to Connecticut.
Anna Jane, thank you so much for being here, for your work. And Rep. Claire DeCitri and I have been talking for quite a while about coming up to see you. Now that session is in full swing, it's unlikely, but we do want to come up to visit for sure. I have a question for you about your experience with the legislative process at all.
Yeah.
And how that happened in Rhode Island.
Absolutely.
Because you are a state supported and you said DPH regulated organization, which is unique. And so if you can speak to that process a bit, that would be
Absolutely. Absolutely. Thank you. Sorry for interrupting. I was one of the volunteer advocates that worked legislatively. I was at the State House almost every day, along with several colleagues, to talk with lawmakers such as yourselves. And what I found in those conversations, and really echoes what I've heard here, is so many people have been personally impacted, whether it's a family member, whether it's a constituent, whether it's a neighbor, by substance use disorder, by overdose, and by, unfortunately, overdose death. And lawmakers really had an appetite to want to take a different approach, and recognizing that the approach we've been taking around incarcerating people, trying to force people into a broken treatment system has not been working, and that really there was a leadership opportunity for lawmakers and for the state of Rhode Island to make that change. I think the fact that Rhode Island is a really small state was definitely beneficial. Rhode Island is very much about relationships, and I think a lot of lawmakers really leaned into those relationships with entities like our State Department of Health, our Executive Office of Health and Human Services, with harm reduction providers, really listening to folks with lived and living experience, listening to people in recovery who really had a uniform voice, again, similar to a lot of what I've heard in this testimony, saying, we need to do everything we can to save lives. So after 3 years of advocacy, and again, a lot of one-on-one conversations with lawmakers, in 2021, the General Assembly and then the governor signed our bill to authorize this. And then we worked very closely with our Department of Health to create a regulatory infrastructure for this so that it could be regulated by our state. And then we also worked with our Opioid Settlement Committee, which is where all the funding for our Overdose Prevention Center comes from, to allocate funding for this. So there's, make it clear there's no taxpayer dollars. And then since then, we've also been working very closely with our city government, whether that's city council or our mayor's office here in Providence, working with EMS, working with police, working with our local city councilor, working with the local businesses to really educate people about what we do and be a resource here for the community.
Thank you for that. I appreciate it, and I look forward to visiting and to meeting you in person. Senator Anwar.
Thank you so much. AJ, good to see you. Thank you for hosting me when I was able to visit you guys and spend the time and part of your day showing me around and the entire process as well. So thank you, and then thank you for testifying today as well. AJ, your testimony is very important to us. The state of Rhode Island, short distance from us, is using opioid settlement fund, state support, and is saving lives every day. And our bill has asked $0 from the taxpayers, $0 in any shape or form, and we are saying, let the nonprofit save lives. And even then, we have not been able to save lives in our state. And there are different things people have misunderstandings about, and I want to talk a little bit about those. Has the federal government been knocking at your door every day or frequently or telling you you should stop this? Is there a way you can help clarify that for us as your lived experience in your state?
We have not heard anything beyond the support that we have from our state. I think that this is an important moment for states to provide that leadership, for states to provide that support. We're seeing that on so many fronts right now in this federal environment. And so I really see that as an opportunity. As for us, we are continuing what we do. We keep our heads down and we work to save lives. Our team works to save lives here every day. That's our main concern.
Thank you. And when you were trying to pass this bill, and you were ahead of the curve, because we have the luxury of now talking to you, you had the luxury of talking to New York at that time.
Yep.
And we have been to, I've been to New York with some of our fellow at least one of our fellow legislators as well, and you'll hear from her shortly. I want to ask you, how were you able to convince your Commissioner of Public Health and the governor to do the right thing at that point? And then what kind of conversations were you able to have? How were you able to convince them?
Absolutely. So we actually passed our bill before On Point in New York opened, because we passed our bill in June of 2021, and I believe On Point opened in November 2021. So when we passed the bill, there was no official overdose prevention center in the United States. We were really looking at models in Canada. I think that we were able to convince people like people at our Department of Health and lawmakers and the governor through an understanding that we needed to make a difference. This was also during COVID, when I think we were taking really drastic action in the name of public health. So this was a moment when we stopped everything to save lives, right? Like we hunkered down, we worked remotely, we changed when we went to the grocery store, whatever the case may be. And I think certain lawmakers, including lawmakers who had really deep connection to this topic through very personal reasons, really showed that in this era of a drug supply with things like fentanyl, things that were drastically killing people, that we could also take a different approach with overdose. And so is through the leadership of lawmakers, very respected lawmakers, through the leadership of many doctors and the medical society here in Rhode Island, and through a legacy of public health interventions. Rhode Island was one of the first states to legalize needle exchange, right? Things like that. One of, on early in creating something like an overdose task force, and a really strong recovery and harm reduction community that really banded together and said people with lived experience and living experience want to save lives. I think it was that echoing of all these different voices and leaning into those personal relationships that ultimately convinced Rhode Island to take this really bold move to save lives. And I'll say, since Rhode Island has passed the law, Vermont and Minnesota and the On Point has been open for many years, like this is very doable, not only in the United States, but especially in the environment in the Northeast, where we have states like Connecticut and Rhode Island and Vermont who historically have taken really public health approaches to many different topics. And that can also be the case for overdose as well.
So I'm going to ask you another question, and I'm truly, it's a question, pleading question.
Yeah.
If 10, 15 mothers who have lost their child, and fathers in there as well who have lost their child, they talk to the governor and his team, and they cannot convince him to move forward with this, what else can we do?
I think that's a really great question, because I think those voices are among, if not the most important voices to be heard. And I think we need to honor those we've lost to save those who are still living.
So we are just allowing people in our state to die, and we are not passing this law for the past few years. And the data science is there. The federal part you've shared. New York has been safe from the federal attacks, if you will, on this issue, and so has Rhode Island. And is there a way to use your connections over there from the governor of Rhode Island to call our governor and then have the conversation on this topic and say, hey, it's not as big a deal, we can save lives?
Yeah, again, like I said, our state has been really, really supportive, and I'm incredibly grateful for that support. And that support goes from the governor's office, the Executive Office of Health and Human Services, the Department of Health, and again, it goes to our city. And so whatever conversations, lawmakers, officials, who administrators, whoever can have with people in the state of Connecticut to show not only does the sky not fall down when you open a site like this, but it's a really amazing and really important asset for a community of people who often are so disconnected from medical care, who are unhoused, who, if they weren't using our services, would be cold and hungry out on the streets, potentially in an unsafe situation. I think whatever we can do to help bridge those conversations, again, from a neighboring state and a state that's similar in many ways, we're happy to do so.
We've also seen in our state that the unsheltered individuals in our state have gone up by 43%. And when we interact with them, most of them have substance use issues who are unable to find a rehab facility. Have you seen a change in after your OPC was started? That have you been able to make a change on the unhoused people with substance use combination complex issue?
Yeah, so most of the people using our services, between 80 and 90%, are people currently experiencing homelessness. It's a really high percentage of the population we serve. We are not a housing provider. We do not directly provide housing. However, we do what we can to try to get people into housing. So I know there's been a lot of questions about how to get people into treatment and other services, and the role of the Overdose Prevention Center as a bridge for that. I think a really showcase thing that we can talk about in terms of our program is our recovery housing program. So recovery houses, often called sober houses, are places, are transitional houses where people can be, often for folks in early recovery. And so we have a program where if someone wants to go to substance use treatment, That's something we always are here for. Our peer staff will transport people and support people through that process. However, if people are unhoused and they're in a program for 3 to 5 days and they're discharged without a place to go, that is not necessarily setting people up for success. So while people are in an a detox or an inpatient program, our staff will get people connected to a recovery house, pay for the first few weeks of that person's stay, because oftentimes people don't have the cash up front needed to pay for that housing. And then in those few weeks, people can work on stabilizing their lives, get a job, get a steady income. And last year, we supported over 550 unique individuals in getting connected to houses like that. So, I don't know how that we are also experiencing a housing crisis. Obviously, that is beyond just the scope of one service or one nonprofit, but our team does what we can, especially at the intersection of homelessness and substance use, to try to connect people to housing because we know that's such an important determiner of someone's overall health and well-being.
AJ, thank you so much for your time today. Thank you for your testimony. Thank you for sharing the work that you are doing in Rhode Island. And thank you for your advocacy in Rhode Island that has shown light to some of the other states. And we are hoping that your light will reflect in our state as well. So thank you.
Thank you very much, Senator Anwar. Representative Mara.
Thank you so much, Madam Chair. Thank you for your testimony today. I just wanted to ask you a couple of questions about kind of implementation, well, actually through the bill process. When you first passed the bill, how many OPCs were allowed in Rhode Island? Did you have a specific number? Did you have a place?
Yes, so our bill did not specifically set a limit on the number of overdose prevention centers. However, what it did say is that any local, city council or town council would need to approve the specific location and hours and operator of an overdose prevention center. So that was to give local control to especially the siting of an overdose prevention center. So we spent actually several years trying to find a specific location for our overdose prevention center. We did not have one in mind when we were working on the bill. In fact, Project Weber Renew officially wasn't involved in the bill. I was there as an advocate before I worked at Weber Renew. And we looked at several different locations. We finally found one. It's right next to a hospital. You can kind of see the hospital in my Zoom background, which I think is really important to integrate the Overdose Prevention Center within the larger healthcare landscape, and of course for coordination of care as well. But finding that location did take time because we did want to be in the city of Providence and we did want to be on a bus line, and so there was just limited property. So that was sort of our biggest hurdle between when the law passed in 2021 and when we opened in January of 2025.
Okay, thank you. And did you have harm reduction centers before you had the OPCs, or did you just go straight to the OPC?
Yeah, so in Rhode Island, we don't have a specific designation for a harm reduction center. That's actually what our bill calls overdose prevention centers. So however, Project Weber Renew as an organization has been providing harm reduction services through a drop-in center, through syringe service programs, through street outreach and case management and peer support for over the past 10 years. So while it's not an official harm reduction center, we were providing a lot of those same services, and those services are not regulated by our state, which it sounds like might be a little different than in Connecticut, whereas the Overdose Prevention Center and also our medical services on site, of course, are regulated by our Department of Health.
Okay, thank you so much.
Thank you. Thank you, Rep. Mara, and thank you, Anna Jane, for the level of detail. It's actually, I think, really helpful for us as we look forward to hopefully being able to take action here in Connecticut. Seeing no other questions, I thank you for your time, for hanging in, and for all of you who are waiting to testify. We appreciate your patience today. Next up is William Moffitt, to be followed by Courtney Dollar, both of whom I believe are here in the room, or may have been. Okay, so William, not here. Is Courtney Dollar here? Yes, welcome, Courtney. Just press that button right there.
That
You
one
got
works?
it.
Cool.
Yes, welcome. Please
Hi.
proceed.
All right. Senators, representatives, and members of this committee, thank you for the opportunity to speak in support of Senate Bill 195. My name is Courtney Dollar. I still do not like public speaking, and yet here I am again for the third time in 3 years because this is very important to me and my community. We listen to parents, siblings, friends, and loved ones of people who have died of drug overdoses. They've tried to appeal to your sense of humanity at these hearings. Experts have testified to the staggering amount of data that exists from overdose prevention centers across the world, including 2 now in the US, and yet here we are again. It is disheartening to note the absence of representatives that misconstrued a very small part of my previous testimonies and use it as ammunition as to why we should continue to let people who use drugs die. Let me be clear, overdose prevention centers are one part of the response to our drug overdose crisis. They complement existing treatment models that include withdrawal management or detox, inpatient and outpatient programs, counseling, and medication-assisted treatment or medication for opioid use disorder. When we merely define recovery as abstinence from substances, we neglect the depth and complexity of why people use drugs. Overdose prevention centers save lives and benefit communities. I've experienced this firsthand. I worked at a community-led overdose prevention center. I've also worked in a low-barrier emergency shelter program for people who use substances and a managed alcohol program back in Canada before I moved to Connecticut in 2018. Overdose prevention centers have existed for decades in Canada and other countries. They provide compassion, dignity, and care to our communities. They offer a range of harm reduction services, including drug checking, access to treatment services, and linkages to important health and social services. More importantly, they're a source of safety and of connection and belonging within the community. OPCs provide a safe, non-stigmatizing environment, allowing for trust building, which increases access to healthcare, substance use and mental health treatment, social services, and basic needs. We have decades of data that show OPCs positively impact communities by decreasing public drug use, drug-related crimes, and syringe litter. Crime data analysis also shows that there's no pronounced increases in many forms of violent crime in neighborhoods with OPCs. We also see a reduction in use of emergency services and emergency department visits. For this to succeed in Connecticut, it's not just about supporting OPCs, it's about ensuring that we are properly devoting funding and resources to support the wraparound services that OPCs provide. It also means looking to other models of harm reduction that are working in other communities, including safe supply programs, managed alcohol, managed opioid programs, and low barrier shelter options for people who use substances. Can I ask a question of the committee? Since the first time when we met in 2023 to discuss the proposal of an overdose prevention center, how many of you have visited an OPC? For those of you that have not, I would like to know why. We can sit here and talk theory all day long, but for you to come and see what these centers actually look like and what someone who is accessing these services is receiving goes a long way. And I think there's a lot of stigma and misconception as to what these centers look like, the impact that they have in the communities, and the lives that they save.
But most people think I'm incompetent.
Thank you, Courtney. Kathleen, perfect timing. She just ended at exactly the right time. So, Ms. Dollar, thank you so much for being here with us today. I'll tell you why I have not been, because I haven't been able to figure out the time and timing, and I would like to go together with Rep. Clarida Cetria, as I mentioned earlier. And I think that's probably true for a lot of people.
I would
here.
really encourage
So
it.
I think that while many of us would really like to go, we are struggling with juggling those things. That's not an excuse, but also we generally don't answer questions. We get to ask them, which is, I know, but hard and difficult. I would like to just circle back to something you said. And I do remember last year when you testified, some of the conversation that we had. And it sounds like you felt like you were misunderstood or misinterpreted. And I wondered, I don't want to, pick an open a wound, but I wondered if we could just talk about that a little bit, if you could share what that was misunderstood, so that we could all make sure that we understand you fully about it.
So I think my comment about my main drive or my main reason in this work is not to stop people from using drugs was meant as then all overdose prevention centers are not going to connect people to treatment services or anything like that. My main goal and the main goal of an overdose prevention center is to keep people alive. And again, recovery means a whole bunch of different things. It doesn't necessarily mean abstinent from substances. We talk a lot about our unsheltered community. Do you know how hard it is to experience unsheltered homelessness while sober? Housing can be a form of treatment for substance use disorder. I've worked with a gentleman who was blackout drunk in shelter every single day, and we moved him into housing, and his alcohol use was never anything that we talked about. But slowly over time, he stopped drinking, and that was never part of his housing plan. That was the fact that he had somewhere safe and stable to stay. And I just think it's a very big disservice that we look at it as, well, they don't want to stop people from using drugs, when this is a public health crisis and this is a public health response.
I think what you are saying, or how I hear it, so let's see if I've got that right, is what I think our first person testifying today, Kim Rada, was talking about, no wrong door in terms of entering. And I think earlier, I don't remember who exactly was speaking to this, but the steps that we take, this is true for all of us with behavioral change of any kind, whether it's starting a workout routine in the new year, that sometimes it's the small steps that we take towards a goal that add up over time. And I think that's what I heard last year, and I am hearing that again this year, is that you're really talking about being able to meet people where they are. And I think that's one of the real struggles, because for most of us here, we have someone in our life who is facing addiction. I would venture to say there are very few people in this room who don't have someone in their life facing a serious addiction. And for those of us who are family members journeying along with those friends, family, loved ones, we have our own desires and hopes for them. And those who are suffering have their own struggles. And how we address that is really difficult. So I think I appreciate you bringing that up and giving us the opportunity to really clarify what it was you were intending last year, and in addition, your comments this year as well. Senator Anwar.
Courtney, thank you so much for your testimony and the work you do. Recently, I came across a couple that I've been following closely. They are unhoused and homeless. People that they actually lost their home because the person sold the apartment and they evicted them because they did not want them to be there, and they were sober, no substance use at all, and they could not find a place. And then they were in the midst of the winter month in Hartford, and it was so cold, and they were unsheltered, and they were a couple, and you cannot find a couple to be a shelter. They prefer to be in cold together rather than any place. And in order to survive, they started to use substances, only to survive. Now they are addicted because they are addictive chemicals, and now we cannot get them through detox, and we cannot get them for treatment, despite a state senator with public health co-chair cannot find a spot, cannot find a place, and we are failing them every day. And then they're moved from one place to the other. They go deeper into the woods, and sometimes they have no food, sometimes they have nothing, and it's just the housing issue, the cost of living issue, and then having no safety net is just, is this what you're seeing in your work and in home, and is that the pattern that we are seeing more across other parts of the state too?
Yeah, 100%. It's what I've been seeing for years. It's also very difficult to access housing. Folks that are unsheltered are in survival mode, right? They're wondering where they're going to sleep safely that night. They're wondering what their next meal is. They don't care about coming to get a birth certificate with me, but these are documents that they need to access housing services. And so we're seeing a really big gap in how people can access adequate shelter or housing options.
And the number of people who are unsheltered have increased 43%, but I think the resources and the entire organized effort, Department of Housing is trying to deal with it, but they are part of the solution, but not the entire solution. And there's so many people and leadership in this disjointed systems that have to come together to address this, and you highlight that. So thank you for that.
Can I say one thing to that?
Please.
I think that that number is actually grossly unrepresented. We do a point in time count on what is pretty much the coldest day of the year, when sometimes family members or friends are willing to take someone in that maybe over the summer months they're not willing to. So we're undercounting those folks. It's also very difficult to reach people that are sleeping in their cars. They don't have a visible encampment that we can go and visit and count them. So I would argue that that 43% is much higher.
I agree with you. Thank you so much, Madam Co-Chair.
Thank you very much, Senator Anwar, and thank you for being here with us today. We really appreciate it.
Thank you.
And for your ongoing work. Next online, we have Melissa Willett, followed by in person, Kim Sandor.
Thank you, Senator Anwar, Representative McCarthy-Vahue, and members of the committee. My name is Melissa Willett, and I'm the New England Regional Liaison at the Defense State Liaison Office within the Department of War. And I'm joining you today in support of SB 93 as it relates to the Emergency Medical Services Personnel Licensure Interstate Compact. We represent the department and establish relationships with state leaders across the country to educate stakeholders on issues impacting our service members and their families. Military spouses bring distinct talents to the workforce. SB 93 could create stronger pathways to employment for military spouses and help address a unique challenge faced by our military families due to the high demands of military service. Due to the demands of military service, a majority of our families relocate to a new duty station every 2 to 3 years. These rapid rates of relocation often hinder the employment and career potential of military spouses, which in turn have long-term consequences for both the spouse and family. According to a 2021 Department of Defense survey of active duty spouses, 48% of respondents stated that finding employment was one of the most critical problems they experienced during PCS moves. Undue stress, whether financial or other, has potential to disrupt the overall readiness of our military units at the local level. Military spouses and family members play critical roles in supporting our service members. The result of that commitment affects their own ability to pursue employment and establish their own careers, which is highlighted by the unemployment rate of this demographic. Military spouses are unemployed at a rate of 21%, a rate that is significantly higher than their civilian counterparts. But like their civilian counterparts, our military families rely on 2 incomes to meet their basic needs. Military spouses are a cross-section of America. A key difference, however, is that a higher percentage of them work in licensed professions than their civilian neighbors. This, combined with the fact that they move far more often, creates a significant challenge, which is transferring their professional licenses from one state to another. To address this, states are now using interstate compacts. These compacts create shared understanding of professional standards, paving the way for true license portability. Simply put, SB 93 offers a framework to support our military families. We thank the committee for considering this important legislation and are especially grateful for the tremendous efforts Connecticut has historically made in supporting our military population. And we look forward to the positive outcomes of this proposed legislation.
Thank you so much for your testimony. As a military spouse or former military spouse, I know exactly what you're talking about and appreciate what you're saying, as do I know so many service members and this committee. We have a history of passing compacts here, and I think we've demonstrated pretty well the value of that work. So we appreciate you coming to emphasize that and highlight the importance of this issue for our military families. And I don't see any questions, so with that, thank you for being here with us today. We look forward to any other further conversations. We know that you're a resource for us as we move forward with compact work.
Thank you for the time.
Thank you. Next, we have Kim Sandor, who's here in person, followed by, I believe, Laura Curran online. We'll check to see on that. But in the meantime, welcome, Kim. It's nice to see you.
Thank you. It's so good to be here. Good afternoon, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claire Dietrich, and the distinguished members of the Public Health Committee. My name is Kimberly Sandor. I'm a registered nurse and a family nurse practitioner, and I'm the Executive Director of the Connecticut Nurses Association, representing nurses across every specialty and practice setting. Thank you for the opportunity today to speak in support with recommendations on HB 5169, an act requiring the establishment of it's a long one, of an alert in the statewide health information exchange regarding patients with a history of violence toward healthcare providers. I just really want to thank you first for always creating a committee atmosphere where people feel safe to share hard things that are happening, and we do ask a lot of you, but I just want to thank you for year after year showing up around workplace violence. It's been an ongoing issue that we've been trying to address in many different ways. This past year, we held 4 town halls, and we had at least 2 members of this committee at every single one, where you directly heard and listened to the workplace violence incidences that are happening across healthcare settings. When you read the testimony today, you'll continue to hear the same stories. What does that tell us? Everything that we're doing still isn't fixing the problem. Workplace violence in healthcare is often described as part of the job. And it really never should be. People don't go into healthcare for that. They go into healthcare because they want to help. So how can we create an environment that supports that help? Too many nurses, violence is not rare, it's routine. Research shows 1 in 4 nurses has experienced an assault. Verbal aggression happens 1 time a week, and physical can happen 1 time every 3 weeks. Higher rates than any other profession. And I think that is staggering when you think of police and corrections and other professions out there that may experience workplace violence. The incidents are not always unpredictable. They've happened before. It's often shared nurse to nurse, from a security guard, from another nurse saying, be careful, someone is violent in there, maybe a note is left on your desk. We have to do better to create a system where we can move information between systems so that there's a way to be able to do that. Otherwise, the cycle repeats itself. Knowing that there's a history of violence, it provides situational awareness. Awareness allows preparation. Preparation allows prevention. Advanced knowledge enables appropriate staffing, security presence, environmental planning, and proactive de-escalation before harm occurs. We must coexist safety with equity. It can't just be a check. It can't just be a checkbox. It's not okay just to have a flag. We need some clear behavioral-based criteria, not a subject first impression. We also think context matters. We know that workplace violence can be triggered from long waits, being hungry, a reaction to a medication, and it can also just be unintentional and intentional. But we need context. Context helps a provider to go into the room, being aware of what's going on, and being able to do their own assessments in treating that patient with care.
Excuse me, Kim, but you've reached your 3 minutes. Thank you.
We love the voice, Kathleen. We've missed you. But Kim, did you want to sum up anything? You're good.
Just thank you for your ongoing support. We do really support this bill with some recommendations in there. And I just wanted to note with Senate Bill 93, we received clarification this morning, that's a Rural Transformation Grant, that the removal of the rest home with nursing supervision relates to a licensure category and doesn't relate to the supervision of a nurse's aide. So I just wanted to share that because I don't know if it's come up in some of the testimony that's up there. It was an issue that we were worried about until we found out a little bit more about really what those words meant.
Thank you for clarifying that. A couple quick questions. One is, did you submit written testimony or could you?
I will. Our president did submit, a number of members had submitted, but I will submit mine.
I think that's great because I think what you said is really valuable and important. I also just want to give a huge shout out of thanks to Representative Martinez, a member of this committee who has championed this bill, and that's why we're here today, because she brought this forward and has really talked with some of the folks about this, and I know we'll continue to do that to work through anything that needs to be in order to be able to make this happen. But thank you, Kim. I should say, Ms. Sandor, thank you very much for all that you do and all the work you've done with us together And I also have one last really important question. Do you watch The Pit?
Can I just tell you, it is pretty exciting. All the nurses get really excited about The Pit. We just had a nurse practitioner who was down in New Orleans, and he was like the grand marshal of the parade, and she had a big sign up, we love you, Noah Wiley, and he came over and gave her a little something. So, yeah, everyone really loves it.
That's wonderful. And I say it jokingly, but I find as I watch that show, I think about you and all the nurses who have been here advocating on behalf of the nurses who are out there doing this work at the bedside, in the hospitals, in people's homes every day. We are so grateful. Thank you.
Thank you.
Oh, Representative Mara. Go ahead, Representative Mara.
Thank you, Madam Chair. Thank you so much for your testimony today, and I'm sure I didn't realize that Rep. Martinez brought this forward, so I probably can have some conversations with her behind the scenes too. This all makes a lot of sense to me. I'm just curious why we have to have a law for this.
Well, I think, I don't know who makes what's in the statewide health information exchange. I don't know who decides what goes in there and what doesn't go in there. Representative Martinez probably has understood that more, but I do know that flagging has been a successful strategy in some institutions that they've used for this, but it only works in that institution. So the statewide health information system is that umbrella, and then every institution has to connect to it. So the information, if it's up there, then it can come down to everyone versus in their own separate silos. So I think that's what we're trying to achieve with this. And I honestly have no idea why out of my league there.
All right, thank you. Thank you so much.
Thank you, Rep. Mara. Senator Anwar.
Thank you so much, Kim. It's always good to see you, and thank you for your testimony. I just wanted to mention something that I know you have said and believed, and I just want to highlight, and I know Representative Martinez as well. The idea is that every patient in the state of Connecticut who needs health care will get health care. This is just for the protection of healthcare workers, so that they can be prepared and then have support system or perhaps mechanisms to be able to protect themselves and their co-workers. So that's the whole idea. So I just wanted to highlight the fact that this is not restricting anybody's care in any shape or form. So I just wanted to make that comment, and I think perhaps you can repeat that too.
Yes, absolutely, 110%. I think that that's where some of our recommendations come in, is trying to be very clear about ensuring that that care doesn't change. It's just a piece of information that can support some of the violence prevention risk assessments and things that are done. Every hospital has a safety committee. The safety committee has a safety plan. The safety plan is supposed to include how to handle certain situations as they come in. This is just another piece of information. I also want to highlight that we know that while 1 in 4 healthcare workers is assaulted, we know it's highly, highly, highly underreported. And that most healthcare workers don't want people to go to jail and go through a lengthy process. I know we have a felony C in our regulations out there, but that's not our business, right? We're there to take care of everybody. So I actually hope that this idea that we can improve communication between systems encourages reporting and encourages that. And then we have a clearer picture of really what types of workplace violence is happening. The Joint Commission that accredits hospitals has different categories. CMS looks at, these safety plans. But if we don't have the information, garbage in, garbage out, right? That's our whole data frame. So, a real kind of intended or unintended consequence of putting this flag, it empowers the providers to have this conversation, understand the definition, be able to do it, be able to address it when it comes in and say, how are we going to handle this? And now we have it reported. We have a number. And if we can give that some context so that we can better understand it, I think we're doing a whole lot of good to move the needle on this.
Thank you, Senator Anwar, and thank you, Kim, for being here.
Thank you so much.
I believe Laura Curran, Dean Curran, is in person. Yes. I was thinking you were online, but you are right here with us. Dean Curran, welcome. It's nice
Thank
to
you
see
so much. Thank you for having me today, and thank you to the co-chairs as well as the members of the committee. So my name is Laura Curran. I'm a social work researcher and educator with over 20 years of experience, and since July 2023, I've served as dean and professor at the University of Connecticut School of Social Work. My testimony reflects my own professional opinion and not that of the university. So I'm here to support HB 5166 and the permanent elimination of the ASWB exam for the licensed master social worker license in Connecticut. The LMSW is the first level license typically obtained at graduation from a Master of Social Work program, allowing supervised practice under a licensed clinician. The exam was suspended in 2022, but just recently reinstated in January of 2026. Major professional organizations, including the National Association of Social Workers, the Council on Social Work Education, and the National Association of Deans and Directors in Social Work, support suspending or eliminating the exam due to clear evidence of significant demographic disparities in pass rates. ASWB data from 2018 to 2021 show first-time pass rates of nearly 86% for white candidates, but only 44% for Black candidates and 63% for Hispanic or Latino candidates. Native English speakers passed it at 75% rate versus 57% rate for those whose primary language is not English. Older candidates also had lower pass rates than younger candidates. These disparities are unusually large for a standardized exam and likely result from a combination of structural inequality, disadvantage, and potential bias in exam design. The effect is straightforward. It limits diversity in Connecticut's social work workforce, reduces the number of bilingual social workers, and shrinks the pipeline of licensed professionals during a behavioral health crisis. Importantly, there's no current evidence that eliminating the exam increases instances of professional misconduct. I and others argue that the exam is not an effective measure of professional readiness. LMSW candidates have completed an accredited master's program with at least 900 hours of supervised practicum. They're evaluated over time in academic and real-world settings by supervisors and faculty on knowledge, ethics, and skills, not by a single timed multiple choice exam. Over the course of my career, I have seen talented graduates at multiple schools with job offers in hand and strong evaluations blocked from practice because they could not pass this exam. From my perspective, it functions less as a measure of competence and more as a barrier to building the robust, diverse workforce that Connecticut urgently needs. So I urge you to support HB 5166 and allow Connecticut to join other states, including recently neighboring Rhode Island, in removing this requirement. Thank you. And I'm happy to answer any questions.
Thank you so much for your testimony, spending time with us today, and your work at the School of Social Work. We very much appreciate that. I appreciate you highlighting in particular that this is having an effect on the pipeline, the workforce, which is something that this committee has been very interested in and aware of, also taken action on, because we recognize that that is such an issue. So I thank you for that, and I don't see any questions. I think, oh, I'm sorry, Rep. Reddington Hughes, I missed your hand. Okay. I will say I expect that we will engage in ongoing conversation with you, as well as Don Brown from NASW, who will be testifying later as well. Rep. Reddington Hughes, my apologies, I didn't see your hand. Please proceed.
Okay. Thank you. My question has to do with other states that still have the exam. Are there any states that you know of, okay, that have modified the exam so that it is not doing the negative impact that we have here?
Yeah, so the exam is national in context. It's developed by the Association for Social Work Boards, so the exam is the same across all states. There has been an ongoing effort between all the national organizations I've named, the National Association of Social Workers, CSWE, that's the accreditation body, and other groups to work with ASWB to reform the exam. But at this time, they have not been able to provide us with any psychometric evidence that they have modified the exam in any particular way. So we don't really know. They haven't been particularly transparent, although they have engaged in communication. They haven't been particularly transparent about it. So we really, they haven't released more data since 2022, so we don't really know what's happening. With that said, I would also just argue that this type of exam for this level of practice is really not necessary. Clinical judgment is complex. It is also modified so much by circumstance that it's very hard to capture what the exam is asking in a standardized format. We typically don't use these types of exams in schools of social work for that reason. So it's just a more complex assessment. And we've, yeah.
Thank you for your opinion. Thanks.
Thank you, Rep. Reddington Hughes. Dean, I would ask, and I may have missed this in your testimony, I think one of the things I've come to understand is that the pass rate is, there's an age difference as well.
Yes.
So for students who are going back to school, maybe someone like myself, if I had gone back to get my MSW now versus getting it in my 20s, that those pass rates are very different. Can you speak to that data?
Yes, so older candidates do pass at a lower rate, which is not intuitive to some extent, right? Because social work and these types of clinical and behavioral health professions, one would think that somebody with a little bit more life experience might have a stronger amount of clinical judgment. And again, I think that does go back to this question of whether these exams are actually capturing what we want them to capture. And that it may not be the appropriate assessment for practice. So I think it speaks to that. And again, anecdotal from my point of view, but I have seen students who are exceptional students who are unable to pass this exam. And, when we do test prep with our students, it's all, you got to think for the test. Don't think what you would really do in practice. Think about what the response should be on this exam. And so that tends to be what's happening here. Which is, from my perspective, problematic. The disparities are problematic, but the fact that we're using this type of exam as well is probably is unnecessary. And remember, as you were asking earlier, folks are, when they're engaged in practice, they are supervised by a licensed CSW clinician. So you can't really work directly with a client with an LMSW without that type of supervision in place. So that's really important to recognize as well.
In specific settings, and the LCSW exam remains in place, the licensed clinical social worker, Representative Mara.
Thank you so much, Madam Chair. Just at the very beginning of your testimony, you said you were speaking on behalf of you, and I'm just curious, is this a consensus among your colleagues at the college, or is it not? Is that, I know you can't maybe say exactly, but I would say
the overwhelming, so let me say that the overwhelming majority of our faculty are in support of the suspension of the exam, as is the profession. I would say, again, just speaking to our major professional organizations, the National Association of Social Workers, but also the Council on Social Work Education, which is the accrediting body for social work. So our accreditators are saying this isn't necessary, and the National Association of Dean and Directors, so that's all the leaders within social work. So the sentiment is quite widespread. I will say that ASWB, while it's important to have an organization like this is, as one might imagine, their exam is, they are heavily financially dependent on this exam. And, that makes sense. Yeah.
Okay, yeah, thank you. That makes a lot of sense. And just to play, can you play devil's advocate?
Sure.
Can you explain why someone would want to keep it?
Well, I think folks would, say that this is, typically licensure is a way to protect the public, right? And so this would be another potential tool for protecting the public. Certainly social workers as a whole want to protect the public. So this kind of evens the field across, folks who, are people well trained enough. But what we're seeing is that the disparity is not based on, did you come from this school or that school? It's really, and I will say Connecticut schools overall, we do well in our pass rates, but we all the schools in Connecticut still see these disparities. So it's not really about the schools as much as it is about, unfortunately, the demographics. That's really what we're seeing.
Okay, thank you
Yeah.
for walking me through that. I
Yeah,
appreciate it.
yeah.
Thank you, Representative Mara. Rep. Reddington Hughes for the second time.
Because I appreciate your candor,
Yeah.
and I just wanted to know, this clearly, may not be the way to measure someone, especially as we're seeing that there are such discrepancies. But is there another metric that you would suggest?
Well, I mean, we are measuring people with their degrees. So remember, they have to pass and graduate from the school. So that's the big one. The second way that students are measured is their time in their practicums. So they do at minimum 900 hours. Many of the schools in Connecticut do a little bit more. We do a little bit more than that. So they're also measured by a practicing clinician, right, to pass. So they're also that. And then finally, historically, some states have Connecticut not, but California historically did a more extensive exam. Those are very costly. California no longer has that type of exam in place because it's just very hard to administer. But it's really, so one has to, we are certifying their readiness to practice. They already are practicing in a supervised setting. So, we believe that the degree on its own is a substantial measure of their readiness to practice. If they weren't readiness to practice, they wouldn't be graduating from their master's degree program. And again, Connecticut has a strong pass rate. But we do see these intense disparities, and this is what we see across the country, unfortunately.
Thank you.
Yeah.
Thank you for that. I think this has been a helpful conversation to help lay out some of the issues that we're seeing. I think this time I got it right. No other questions?
Okay.
Thank you,
Thank
Dean
you.
Curran, for being here with us. And next we have Kim Adamski, who I believe is here in person. Yes, she is. Wonderful. And followed next by perhaps Lauren Pristo. I'm not positive she's online. But meanwhile, welcome. Please proceed.
Hi, thank you for having me. My name's Kim Adamski. I'm a resident of West Hartford and a Connecticut native. I'm also a health educator and community health worker. Based on my experiences in the field and the available scientific evidence, I'm testifying in support of SB 195. Overdose prevention centers have been studied for at least a decade for effects on public health and community safety. A 2017 review from researchers at the University of Alberta found that overdose prevention centers reduced both mortality and 911 calls due to overdoses. Also, a 2022 study out of Boston University showed that these facilities decreased risk of both morbidity and mortality and did not increase the crime or public nuisance in the surrounding communities. Research also shows us that overdose prevention centers produce economic benefits. Studies in various communities have found that every taxpayer dollar invested in such a center saves between $5 and $20 in emergency, medical, and social services expenses. Connecticut's opiate overdose rate per 100,000 is 33.3 as of 2023, which was higher than the national average that year of 29.1. Over 1,300 people died of unintentional overdose in 2023, which has decreased a bit since then. Great. It would be better if it was zero, though. This number also only reflects the deaths that were reported as overdoses. Each of these people who died mattered to someone. When a person loses their life to an overdose, They've lost their chance to improve their situation towards health and stability. Any measure that prevents loss of human life is valuable to our community. Overdose prevention centers are one such measure, and so I strongly encourage the passage of SB 195.
Thank you so much for taking the time to be here with us and for being an advocate for this important issue. We really appreciate your time. Senator Anwar.
Thank you so much for your testimony. Your work as a community health worker, how does that interact with some of your advocacy work?
So I've worked both in drug harm reduction and in sexual health. I used to work on a syringe exchange van, I think it was like 5 years ago now, and I saw the experiences and the conditions under which folks were using drugs. And I mean, they were on the street, and that's really unsafe for everyone. Nobody wants to see people overdosing in the street. Nobody wants people to be overdosing, and having a dedicated facility would really help with reduction in overdose and safety while using.
Thank you. So your testimony is not only not academic, it's actually based on experience and helping individuals as well.
Yeah, both.
This is very helpful. Thank you so much.
Awesome.
Back to you, Madam.
Oops. Thank you, Senator Anwar. Thank you for being here with us today. Next online is Dawn Brown. Ms. Brown, welcome. Oh, I'm sorry about that. My bad. I apologize because we didn't see you online, and they actually reminded me to check to make sure she wasn't. So Ms. Brown, we're going to have you hold on. And Lauren Pristo, who's here in person, which is a nice surprise. Welcome. Please proceed.
Thank you. Good afternoon, chairs and members of the Public Health Committee. Thank you for the opportunity to speak in support of Senate Bill 195. My name is Lauren Pristo. I'm a resident of Connecticut, and I hold a master's in public health from the Yale School of Public Health and serve as Director of Community Engagement at McCaw Behavioral Health Network, which is in the northwest corner of Connecticut. I oversee community-driven responses to the overdose crisis, including harm reduction and law enforcement deflection programs. I have to say, remarkable things happen when we are able to collaborate and appropriately partition what is a public health response and what is a law enforcement response. In my role, I work closely with police, EMS, and community partners. When we align our efforts and recognize substance use disorder as a health condition, we see better outcomes for the individuals, for families, and for public safety. I want to underscore the written testimonies shared by some of our law enforcement colleagues. After decades in the field, they're telling us that clearly that repeated overdose response without long-term intervention is not an effective public safety strategy. That perspective matters. I also want to share a brief example from our work. As part of our Law Enforcement Deflection Academy, officers from participating community described responding to increased public drug use in a local park after encampments were displaced. With no place for individuals to go to access support or use safely, public consumption increased, and officers found themselves repeatedly cycling people through enforcement with no long-term solution. In that discussion, law enforcement partners themselves identified the need for designated, supervised space where individuals could be connected to care rather than ticketed and moved from block to block. That recognition came directly from their experience in the field. Overdose prevention centers do not replace law enforcement, they support them. By reducing repeat overdose calls, decreasing EMS utilization, and connecting individuals to care earlier, OPCs help stabilize situations before they escalate. This approach strengthens public safety by allowing officers to focus on real crime and community protection rather than cycling through preventable medical emergencies. As our law enforcement partners state in their testimony, this is not about being soft on crime, it's about being smart on public safety. The research is clear, OPCs reduce fatal overdoses and do not increase crime. Communities where they operate have seen significant reductions in public drug use and publicly discarded syringes. Fewer than 1% of overdoses occurring inside an overdose prevention center require emergency transport compared to more than 40% outside of supervised settings. These programs also increase engagement in treatment and reduce the spread of infectious disease, outcomes that improve community health and reduce long-term costs. OPCs are not a radical departure from public safety priorities. They're a continuation of the collaborative, health-centered strategies that have already demonstrated success in reducing harm and strengthening communities. I would also like to add that Connecticut has been here before. In the early 1990s, the state took evidence-based action to authorize syringe exchange programs before federal policy caught up. That decision helped reduce HIV transmission and save lives. It also provided data for the nation to follow suit and save millions of lives across the country.
Excuse me, Ms. Bristow, but you've reached your 3 minutes. Thank you.
Thank you.
Thank you very much, and I'm glad that you're here with us and that we can have this conversation. And a couple questions for you. One, you've referenced some law enforcement testimony, that's written testimony. Would you mind just sharing and pointing us in the direction of who some of those folks are or where that testimony is so that we can make sure to highlight that?
Yeah, 2 of them have been submitted that I'm aware of. One was submitted anonymously from somebody he's a leader in law enforcement. He's been for many, many years, nearing retirement. So his is in there, it's anonymous. And then we also have Sergeant Brandon Kelly, who has submitted written testimony.
Wonderful. How did you cultivate that law enforcement relationship around this issue? Can you speak to that?
Yeah, it's been a long effort. So there's an initiative in the state called Community and Law Enforcement for Addiction Recovery that 2 organizations are piloting, McCall and Liberation. And so for the last several years, we've been working with our local law enforcement partners to build collaborative strategies to deflect people away from the criminal justice system. In that, we're able to have these really honest and open conversations about what health interventions are helpful, including harm reduction. The teams that are the law enforcement partners actually connect and refer people to our harm reduction teams. And it's shown to be a very effective strategy in reducing the calls for service and increasing access to care and to harm reduction services. But again, in those ongoing conversations and the ability to have those honest conversations with our partners, we're able to have discussions like the example I provided where they're saying like, hey, this is a gap, this is a need. We recognize this is really outside of the scope of criminality. This is about humanity. And what can we do? And what can we do together to make sure people get support in our community?
Thank you. I think that's putting a finer point on which one are we valuing, the criminality piece versus the humanity is one way to say it, but also just the effective response. Because we've heard the data and the research around it. And I think your point also about the syringes and the syringe exchange back in the day, prior to probably all of us being on this committee, is a really powerful one as well. And I will just share that when we first started this conversation and Senator Anwar talked to me about this issue, I was very hesitant and skeptical, as has been the case with other issues in this committee. But as I've listened and learned over time, it's very clear to me that this is an evidence-based strategy that actually works. So I really appreciate you highlighting that for us and reminding us of that history, and also just bringing your experience in the role that you have in working with law enforcement. That's also helpful.
Thank you. If I may, I just want to say, the skepticism, I think, it's a normal experience. We've been told one narrative about drug use and who used drugs and what the war on drugs is for well over 100 years. And so now we're asking, to take a courageous change, to take a courageous step to do something different, but something that has a lot of evidence and other communities behind us in support of us. And I think that's the same with our law enforcement. You can imagine early on when we're like, hey, yeah, let's work together, and I hope you're okay with it, but we hand out syringes on the streets, and we also believe in this thing called an OPC. They're like, wait a minute. But then again, just the ability to be present and have those conversations like you all are here today, which I'm grateful for, is the opportunity to come together and make that change.
Thank you for that. Senator Anwar.
Thank you so much for your testimony and the work you're doing. And I just wanted to make one quick comment that Dr. Rob Heimer is going to speak later today from Yale University. He's a national recognized professor in public health, but internationally recognized. And he actually was the one who started the needle exchange. And we as a state was one of the first ones in the country to do this. Now we're trying to strive and always try to be ahead of on public health. Now we have lost quite a bit of ground in the last many years. We are hoping to catch up. So thank you for highlighting that part. And I think you also, the law enforcement part is something that across the board, they have been on board in our conversations with them. They actually recognize it because the common sense and the safety perspective is very clear that what is the right thing to do. They have been very kind this time around to be able to testify, so we truly appreciate your help in that effort. So that's very, very good. Did you see any hesitancy in the law enforcement coming forward because of the structure of organization more than the logical thing to be able to do? Because in my conversation, it was very clear, this is the way to do, please go ahead and do this. But we don't want to be front and center in this.
I think that's a really good point that you make, because I think especially in the eyes of something that is currently portrayed as law and order, for them to go against the grain and speak out and say, like, actually we see the other way, it takes a lot. And so yes, I think there is hesitancy to speak out. There's, in those rooms, in those trainings, in those discussions, in the meetings we hold with them every single month where we have these conversations, there is broad encouragement, endorsement, and excitement about the collaborative work that we're doing and about initiatives like harm reduction and OPCs, but it's another level to ask them to go against that deeply entrenched belief of what law enforcement role is in this space.
And with respect to the EMS, at least in New York, the EMS systems basically said that now we can take care of heart attacks and everything because we were actually just giving Narcan across the board and taking them to the emergency room. The emergency room could not keep the people there because they were backed up, and we could not take care of the people who could have had intervention that were necessary. So it was now with some of those, the OPC over there, the EMS system is truly going after the actual emergencies that need a hospital intervention for a longer term, and we are preventing all the other people who are going to the emergency room in this manner. So can you speak to the data if you have access to that, or you touched on it a little bit?
Yes, and some of that is included in my written testimony as well, but when it comes to the calls for service, you do see that in areas where there's an OPC, overdoses have decreased in that part of the region, which does decrease the burden on ambulance services. And as I stated as well, 43% of overdoses outside of an OPC require an ambulance, but just 0.79% of overdoses within an OPC required an ambulance or ED visit, which if you think about just in terms of burden and strain on the system, of systems that we know across our state and across the country are under-resourced and overburdened, especially in communities where they're volunteer-based, like in the Northwest Connecticut, that strain is felt, significantly. Yeah. Also to think too in terms of cost savings, a lot of these studies have demonstrated significant cost savings in terms of just the cost in reducing response with emergency services.
Right. Thank you for that, because I think that would be one more reason for people to say, you know what, it's a practical, pragmatic approach that's going to save so much money and then reduce the cost of living in some of the communities, but also reduce the burden on the healthcare systems. So there's a rationale for that. Would you be able to talk about the fact that the data has shown that the violent crimes do not increase in the area where there have been OPCs?
Yeah, so crime rates actually in many ways have dropped significantly in the areas of OPCs, and they remained lower in districts where an OPC was established. Some of the research from OPCs in New York found no significant increase in crime and decline in arrests for drug possession in the surrounding area. There's no significant changes in trafficking and assaults, which is important because sometimes the narrative is that if we put it there, you're now going to have more crime, more assaults, more trafficking of drugs in front of those OPCs. That does not seem to be the case. And additionally, there was significant declines in vehicle break-ins in those areas as well.
So now another reason, not only we can save money, we can reduce the crime as well, and that's why the police is very clear where they stand in their conversations, and they don't think it's a law enforcement, it's a public health issue.
Right.
So this testimony that you have with some of the data and information is really helpful. So thank you for adding to the data, the rationale for this. I know many of my colleagues say, we want data, we want data. We have so much data. It's coming out of our ears now. And this is helpful. Thank you so much.
Yes, thank you.
Thank you, Senator Anwar. Seeing no other questions, thank you very much for spending time with us today. We
Thank you.
appreciate it.
Thank you.
Next now online is Dawn Brown, to be followed, I believe, yes, by Rao Vandenhout. Welcome, Ms. Brown. Please proceed.
Good afternoon, Honorable Chair, Senator Anwar, and Representative McCarthy Vahey, along with the esteemed members of the Public Health Committee. My name is Dawn Brown, and I have the privilege of serving as the Executive Director for the National Association of Social Workers Connecticut chapter. I am here to speak in support of HB 5166. I also want to acknowledge and thank the multiple social workers, faculty, researchers, employers, and students who have provided testimony in support of HB 5166. NASW Connecticut has thousands of members throughout the state, but we also interact with many more as stakeholders and partners in the important work we do together. Social workers are an integral part of the Connecticut workforce. We are in schools, hospitals, at the VA, working in nonprofit agencies, private practice, and I'm also proud to say we have plenty of social workers serving in multiple roles at the Connecticut General Assembly. I also want to acknowledge, as I've been on the hearing today, that there were discussions about expanding access in rural health services and improving access to treatment and recovery services for substance use disorders. Those are also areas where social workers provide services. The LMSW is the first level of licensure offered in Connecticut for Master of Social Work graduates. The LMSW exam suspension was granted in Connecticut in 2023, and unfortunately that exam suspension ended on January 1st, 2026. The exam, as you all have already heard, was suspended due to data released by the Association of Social Work Boards that showed disproportionate pass rates based on race, language, and age. And now, while not every state has an LMSW level of licensure, several of them that are similar to our scope of practice, such as our neighbor, Rhode Island, Illinois, and Colorado, have either removed it completely or extended their exam suspension. In order to obtain licensure in the state of Connecticut, an applicant has to have graduated from a Council of Social Work Educated accredited program. The requirements to meet the CSW standards are not only rigorous, but also require ongoing assessment and evaluation of the program's curriculum, faculty, staff, field placements, and multiple other standards that schools of social work must meet, including code of ethics, to remain accredited. As a result, by the time a student graduates from the MSW program, they have had to meet multiple benchmarks to attain their degree. I think you've heard earlier from Dr. Lane and Dean Curran, who talked about not only the hours of classroom study through multiple classes, but the hundreds of hours of out of the classroom experience by successfully completing a supervised field placement. Please know these field placement hours occur with one of our many agencies, schools, and hospitals already serving the individuals, families, and communities of Connecticut. Also note, several of our Connecticut social work students are doing this effectively, as evidenced by many being hired on to be employed at those agencies after graduation. According to the Connecticut Licensed Behavioral Health Workforce Annual Survey conducted by the Child Health Development Institute, social workers make up the largest number of behavioral health providers in the state, with the total of over 13,000 practicing at either the LCSW, which I know you all talked about earlier, or the LMSW, which is in relation to this bill. One thing I want to keep in mind for all of us is that it is imperative that we do not add to the wait time for services for our Connecticut residents and continue to hire and retain diverse social workers in our workforce that are representative of the communities we serve. I am asking that we eliminate the LMSW exam permanently in Connecticut and make it effective upon passage with the inclusion of all MSW graduates retroactively from January 1st, 2026. Thank you for your time, and I'm happy to answer any questions you have.
Thank you very much, Ms. Brown. I appreciate that, and I appreciate you adding that piece at the end. I think while we were sitting here today, I received an email from a social work student who will be graduating in May and is concerned about what this means for those between that January and May period. So we will be discussing that as we move forward in this bill. Thank you for making the time today. Oh, Representative Steinberg. The former chair, he loves it when I say that.
How many years do we have to be before it's not brought up again?
It's forever, Rep. Steinberg.
I guess it is. Thank you very much. Thank you for your testimony. We have received a lot of emails today from social workers who say that this would be weakening the licensing standards and undercutting the educational work that they had done in the past. Frankly, we've seen this in so many different areas when it comes to scope of practice issues where there's concerns about education and experience. How would you respond to those who seem to be under the impression that this would be weakening standards and undercutting the quality of care?
Thank you very much for that question. We get those questions sometimes too in our office. And so the way I would respond to that is, one, I want to remind us that this is the initial entrance into social work practice, right? So we're not talking about the clinical component. We're not talking about an LCSW where folks can operate on their own. Folks still are working, depending on the arena that they're in, as mentioned previously, under someone who is in supervision has an LCSW. The reality is it doesn't weaken the licensure. Not every state actually offers this as an exam, and also that doesn't weaken their licensure. I think what it does do, unfortunately, is allows us in Connecticut to be mindful of the unfortunate bias that and other variables that have existed within this exam from ASWB, and to be mindful of how that will impact our workforce. We have had the exam suspended within the last couple of years, and I think if we went out, and I know I've been on meetings and advisory boards from workforce, that I have not heard that there have been challenges with those folks that they have hired recently who have their LMSW who did not take the exam. The other thing I would add, because this came up earlier about, I think integrity and ethics. The fact is, unfortunately, there are folks who are brought up to, in Connecticut, our Department of Public Health with concerns or complaints, and many of those folks have passed the exam, right? So the exam is not the piece that really makes a difference, I think, in this case. I would definitely echo what Dean Curran said related to that. And for many other folks, I will see many professionals and other folks and educators, that the exam is not going to be what weakens the licensure. As a matter of fact, I think being able to have people use their experiences from, we have these same folks doing work as students, quite honestly, before they're licensed in many of these agencies, before they graduate under supervision. That supervision would continue after graduation in those spaces, and they cannot practice independently without then getting their LCSW, which does currently include passing of the clinical social work exam.
Thank you for that response. If I might, I would also suggest that in your role, you may have a role to play to make sure you educate some of your colleagues that that is not the intent of this legislation, and that we are confident that the quality of care will be enhanced and not decreased, because there seems to be a number of social workers out there who have drawn the opposite impression. Thank you.
Absolutely. Thank you for sharing that.
Thank you very much. I don't see any further questions. Thank you for being here with us today. We appreciate it. And we know we'll remain in conversation with you and others around this bill as it moves forward.
Thank you.
Next online, we have Raoul Vandenhout. Welcome.
Thank you, and good afternoon, esteemed members of the Public Health Committee. My name is Raoul Vandenhout, and I'm speaking today in strong support of Senate Bill 195. I speak as a public health scholar at the Yale School of Public Health, as a Connecticut resident, and as one left behind in the wake of an opioid overdose. Samantha and I met in undergrad, where she studied at the business school to go into marketing, and I studied biology. And we would sneak into each other's classes, help each other with homework, even though we had nothing to offer but emotional support. And we were inseparable. So when she graduated summa cum laude, we moved to New Haven and built a life together. And I was working in a COVID lab while studying for the MCAT, and she was home alone for long days by herself. And somewhere along the way, she and loneliness fell victim to substance use disorder. Samantha hid her disease, and she was scared, she was sick, and needed care, but didn't know how to reach out and ask for it. On October 17th, 2021, she died of an opioid overdose. And I believe that if she had had a safe place to go, free from judgment, where she could find community or support or just the resources to live to see another day, that she could still be here. So now, as a Connecticut resident and as a student at the Yale School of Public Health, I stand in full support of an overdose prevention center. We know scientifically that substance use disorder is a disease and should be treated as such, and that public health emergencies require public health responses. Also, as Samantha's friend, I stand in full support of an overdose prevention center. And OPCs offer a space free from shame, from judgment, to find an off-ramp and live to see another day. So thank you for your time and consideration.
Thank you so much, Mr. Vandenholt, for your testimony and sharing your story and then your reliving your pain. We appreciate your testimony. We hear you. I don't see any questions or comments, and we'll move to the next person on our list, which is, I believe, Aisha Midya, and then followed by Ruth Kenobi online. Actually, the other one, if you can turn that off and this one on, and perfect. Go ahead.
Dear Senator Anwar, Representative McCarthy Vahey, and other esteemed members of the Public Health Committee, my name is Aisha Midya, and I'm currently a graduate student at the Yale School of Public Health. Thank you for the opportunity to testify in support of Senate Bill 195, an act concerning the prevention of accidental overdose deaths and improving access to treatment. Today, I'd like to honor a friend I lost to an opioid overdose through my testimony. Providing education and awareness about opioid antagonists, such as naloxone, is critical for individuals who are at high risk of overdose. Given how it can reverse the effects of an opioid within minutes, naloxone serves as a powerful tool if a person is unable to access further treatment. The establishment of Overdose Prevention Center, or OPCs, will not only provide opioid antagonists, but disseminate this critical knowledge for life. With the rise of synthetic drugs, Connecticut residents are losing their lives to opioid overdose at much higher rates as each year passes. In 2024, 78% of unintentional drug overdose deaths included fentanyl. This bill proposes providing people seeking care with test strips or any other drug testing technology, which has the potential to reduce accidental overdoses. This is the most critical harm reduction technique needed at this time, in my opinion. Another concerning opioid overdose-related trend within Connecticut has been the rise of xylazine. Xylazine is a non-opioid sedative that is often mixed with fentanyl. What is most concerning, however, is that while opioid antagonists such as naloxone can reverse the effects of fentanyl, it will not reverse xylazine's impact given that it is non-opioid. With the safe consumption measures outlined in the bill, anyone who has consumed xylazine will be able to be monitored for respiratory distress in a controlled environment. While Connecticut spends millions each year treating non-fatal overdoses, the OPC pilot program can significantly reduce these costs. Based on evidence from similar pilot programs in other cities, estimated cost savings to existing healthcare systems from implementing a single OPC range from $832,000 to $2.95 million. Cost effectiveness increases as more people use the site, so this bill has great potential to drive down costs while effectively addressing the opioid crisis. Stigma surrounding opioid use disorder limits access to care, and the OPC pilot program helps reduce this barrier by making services more accessible. The OPC bridges the gap between those seeking immediate care and those seeking services to help with long-term recovery, which in turn will save countless lives. Thank you for your time.
Thank you so much, Aisha. Have you testified before?
Yes, I actually testified on this bill last year.
Good. Well, you're getting better. We don't want you to get any better, though we'll pass the bill hopefully this year.
Hopefully, yes.
And you're within time and very well said and very articulate. So
thank you so much.
Thank you
for your time.
Seeing no questions or comments, thank you so much for your testimony. We appreciate you physically being here and testifying.
Of course, thank you.
Thank you. Next is online, Ruth Kenobi, followed by Shale Littleton. So Ruth, you're on. Welcome.
Hi, good afternoon, distinguished chairpersons and members of the Public Health Committee. My name is Ruth Kenobi. I am the Director of Advocacy for the American Lung Association in Connecticut. And I want to thank you for raising House Bill 5164, an act concerning the use of funds in the Tobacco Settlement Fund. I urge you all to pass this legislation to dedicate the CDC recommended amount of funds of $32 million annually towards the leading cause of preventable death and disease in the state, tobacco use. Too many kids remain hooked on tobacco products, and every day as the public health community makes progress on the existing products that exist, the industry develops a new medium for addiction. We know that high school tobacco use rates in Connecticut, the last data that we have is from 2023, and that rate was 12.7% of high schoolers in Connecticut. But we also know that from national studies, about 2/3 of youth who use tobacco products want to quit, and half of those actually made a quit attempt just in the last month. Tobacco use costs Connecticut more than $2 billion in annual healthcare costs, including $560 million in Medicaid spending every year. So the investment in prevention, like to prevent youth from getting hooked on nicotine, as well as helping those who are already addicted to quit, in addition to saving lives, actually does save money. When Connecticut was consistently funding this work, we found that the state saved $2.48 for every dollar invested in the programs that existed. And now I look forward to seeing what's going to happen, as we know that the Tobacco and Health Trust Fund has started distributing funds from fiscal year 2023 and 2024. So I look forward to hearing more about that return on investment. Next week, the Appropriations Committee is hearing the governor's proposed budget. And I have to say that the current way that this funding is allocated is very hard to follow as an advocate. This year, the fact that there is no mention of the Tobacco and Health Trust Fund in the governor's budget actually is good news. It means that it won't be diverted. And so right now the proposal is that there would be $12 million towards this work. And we commend that investment, but we think that there was a lot of work that went into developing the CDC's recommendations. And so encourage you to all have that conversation and work on that investment to go up to $32 million. You've heard this from me before, but this is a self-funded program. Every year, the state receives more than $300 million from the Master Settlement Agreement and the tobacco-related revenue that comes into the state. Asking to dedicate approximately 10% of that revenue towards preventing kids from getting addicted to these products and helping adults who want to quit to do so is a completely reasonable request. So we really are encouraged by the work within the Tobacco and Health Trust Fund's board, and the dedication of CDC levels of funding will demonstrate Connecticut's real clear commitment to combating the millions of dollars that we know the industry is putting into hooking the next generation of kids on their products, and make a huge difference in helping address the inequities that exist in who uses these products, what products are being used, and the health outcomes associated with them. So I really do want to thank this committee on the leadership that you've shown in the tobacco prevention and cessation space, and really your commitment to funding this work. So I look forward to continuing these conversations on this critical lung health program. So thanks for your time today.
Thank you so much, Ms. Kenobi, for your testimony. I just wanted to ask you a couple of questions. I know my colleague, Representative Calvados de Guerra, has a question as well. My question, and I've asked you this before too, last year, because thankfully we are pushing for this every year.
Yes.
To make sure that we stay the course to protect our children and adults in our state. Can you tell us where we are with the smoking numbers and the vaping numbers? Do you have that access to some of that data right now in the last few years since we started to invest in the preventive aspects?
Yes, and I'll say we certainly have made progress. It's frustrating because while we're making progress, our cigarette smoking rates in the country are and in Connecticut are much lower than they were 2 or 3 decades ago. But when you look at actual tobacco use rates, they're lower, but not as low as we'd like to see. Again, the industry is nimble and they're developing new products that they put on the market. So while when you talk to young kids and say, are you smoking? No, I would never smoke in a million years. We've done some great work there, but are they vaping? Are they using nicotine pouches? And so that nicotine addiction, we're still getting young kids, we're doing our best to help prevent the young kids from getting addicted, but the industry is putting a lot of money and effort to getting them hooked.
Sure. Thank you so much. This is helpful. Another thing was that the tobacco settlement funds in the last few years, the state of Connecticut has started to use them for the purpose they're intended for. I know many other states have their own models. Is there a preventive model which is giving the highest ROI, and the ROI is in the number of people reducing their tobacco intake or cessation of use? Is there a model that we should look at from another state across the country?
Well, I know that Florida has made it a constitutional amendment that they will invest a certain number of dollars, a percentage of dollars towards tobacco prevention and cessation. So that's a great place to look. California has also seen a really massive return on investment. I think the latest number I saw was $155 they've saved for every $1 invested in tobacco control and prevention. So there's certainly, we're not reinventing the wheel here. There's some states that have done this well, and I really have been pleased with the investment that we've shown in Connecticut. Unfortunately, it has taken a while to get those funds out the door. So I know that there's a number of organizations that have recently signed contracts, and I'm excited to see the good work that's going to be done in Connecticut.
And is it fair to say, I'm sorry, I'm spending more time, but with the number of lives that are impacted every year, tobacco is one of the biggest killers in our state. So
yeah, absolutely. So
I wanted to ask you, the fact that we are here as a public health committee every year fighting for the dollars, and it's not a standardized budget item every single year, because we have the tobacco settlement, we know what the money should be, we know what it is, but every single year it becomes more or less zero, and then we have to fight and start the battle from scratch. Is that making it difficult for the people who are fighting the battles to be able to say there's no certainty in this area? And it's getting more complex for them to be able to invest and make a meaningful impact.
Yeah, and so I think, the start stop kind of the funding certainly makes it hard to make the investment to make the staffing investment for community organizations. I am hopeful that, fiscal year 2023 dollars, fiscal year 2024 dollars, and because that took a while to get going, the fiscal year 2025 dollars were put on hold, but there's supposed to be new funding available in 2026. We're there now, but it will be available in April for discussion on the Tobacco and Health Trust Fund Board. And so, yes, sustained funding is so important, and we know that because, again, for the people who are doing this work, it's integral to know that it takes a lot of money to hire people and train them. And so not necessarily knowing where, if money is coming in the future makes it hard to make that investment. But I'm hopeful now that we're seeing some movement here in Connecticut.
Good. Thank you so much. I'll have my colleague, Representative Kavra, stick around. She had a question or...
Thank you so much, Mr. Chair. I appreciate it. And I am always happy to see one of my amazing constituents coming to testify, especially when it's Ruth. I have questions when you mentioned that the $23-24 dollars have just started to sort of roll out. Is there data attached to that? And when would we expect to see that data so that we have a sense of, I know we have the old data where we know that the money we spend prevents, but I think that the old data really was, and correct me if I'm wrong, that was sort of prior to vaping hitting our kids. So my big question is, like, when will we see that data? Because my hope is that when we see that data, that will help inform future legislation. And as you know, I've been on the anti-vaping train for many, many years now. And I hope that we will circle back to anti-vaping legislation in the future. So if you have some sense of when the data might arrive.
Yes. So to be honest, it took a long time once the Tobacco and Health Trust Fund Board got up and running, then came up with a plan, got it approved by the legislature, got an RFP going from the Department of Public Health. Like, those contracts have been signed, but some of the work has started, but it's taken a long time. And again, that's one of the troubles of the start and stop motion of this is the infrastructure for that kind of stuff just wasn't there. So it took a bit. So that's why I'm very hopeful. However, I will just there's requirements for all of these contracts that the organizations doing this work are doing evaluation, and there's an external evaluator. So there will be good quality data associated with the work that's being done. And I would imagine that in the next few months, like that first year, probably be a little bit later, but this year we should get beginning data about the work that's being done, and then kind of that return on investment does take a bit of time to gather, but it's in the works and built in all of the contracts that there will be good data for us to review.
And do you know, and if you don't, it's okay, but is it possible that some of that data would include people who are using it for cessation, but who have actually, once they stopped smoking using a vape product, they then actually stopped using the vape product? Because in my experience, people who use vapes to stop smoking tend to never get off of the vape. And so, or the e-cigarette device. And so I'm just curious if there's also potentially data around that.
I can only speak to the Lung Association, and how we treat all of this is we'll say, quit, don't switch, right? Because that is right. We know that the industry has been walking a line of they're not supposed to say that these are cessation devices, because they're not, because there is a proper way to go about getting approved to be a cessation treatment. There are a number of them that have been approved that are available, not vape devices, but other treatments available that are known as best practices and ways that people get treatment to help their really difficult nicotine addiction. And so yes, the Lung Association really does work to make sure that we are talking about quitting and not switching. It's an important piece, because as cessation treatment, we know that those things have had to go through a process to prove that they are helpful, and it's very rare that we talk about people using those products for indefinitely. Vaping products and e-cigarettes are something different, and they're not a cessation treatment device. And so that's something that we would look at when we look at that piece. So I can only speak for the Lung Association, but that is the way that we look at those products.
No, and that's really good to hear, because I know that in previous testimony, when we have heard bills that are anti-vaping, we have lobbyists that actually were featured in the documentary Big Vape, who have come to testify before us, who continue to say cessation, cessation, cessation. And I just wanted it to be clear that we are also looking into that, because I think it's important for us to know, not just that we are preventing anyone from ever starting, but also that, we are actually getting people to quit and not just switch. So thank you so much for that. And thank you, Mr. Chair.
Thank you. I just want one more question. I'm going to make a statement, and it's going to get me into trouble, but it's worthwhile. Good to get into trouble. People say that our children get addicted to the nicotine in the cigarettes, and the state is addicted to the tax that nicotine produces. And when we are trying to have cessation and policies, other parts of the committee say, hey, what are we going to do about these $300 million that we're going to lose because you are trying to get rid of a combustible cigarette? Because our committee has passed this bill a few times in the past. And that we have said that we don't want the combustible cigarettes, and the bill, while it passes the committee and passes the Senate and the House, the bill changes because there's such a big financial loss to the state. Can we, or has any state used some of the existing settlement funds to offset that?
I don't know. I mean, states are getting, Connecticut is getting more than $100 million every year from the Master Settlement Agreement. That's a significant amount of money. It's not as much money as the state is getting from tobacco-related revenue. It's an interesting question, and probably one for the Attorney General.
The Attorney General has been very clear. He's been fighting these battles quite well on various fronts. So, but it's worthy of a conversation, because we can pass a bill, but if we don't have another alternate source of the revenue, then people who are looking at the revenue, they would not let that bill become a law. So more conversations about that in future, perhaps.
Yes, thank you.
Thank you for your testimony. Seeing no other questions, we'll move to the next person. That is Shale Littleton. Thank you so much for your patience with us. Welcome. You're on.
Can you guys hear me okay?
Yes, you're on.
Okay, thank you. Thank you so much, Chairwoman McCarthy-Vahey, Chairman Anwar, respected members of the Public Health Committee. My name is Dr. Shale Littleton, and my testimony is in support of a modification to SB 190. I'm a lifelong Connecticut resident, and I have been a practicing veterinarian in the state of Connecticut since I graduated from vet school in 2000. I have been an associate vet, a practice owner, and I'm currently a relief vet, which means that I travel to different clinics, filling in for vets when they take time off. I have had a wide exposure to different clinics and veterinarians during my career. I became interested in providing veterinary telehealth last year, but unfortunately, Connecticut only allows telehealth in limited circumstances. So I got a license in another state in order to legally practice telehealth, which I've been doing for several months now. I frequently ask my clients what led them to make a telehealth appointment. I have found that my telehealth clients fall into three general categories. One group has significant financial limitations, and telehealth allows them access to veterinary care that they would otherwise not be able to afford. Generally, the only other option for these clients is no veterinary care. The second group tried to make an appointment with their regular vet, but were told that there were no appointments available for sometimes 3, 4, 5, 7 even days. And it's generally not the fault of the veterinary offices, which are frequently understaffed, overworked, and have to turn away even very good clients because they simply don't have the time or staff to handle all of the appointments. But imagine it's your beloved dog or cat that has to suffer with, say, an infection, a skin infection, urinary infection, and you were told that you couldn't get antibiotics or treatments for several days or up to a week. No one wants to see their pet suffering unnecessarily. The final group are clients with aggressive or fractious dogs or cats who are not handleable during in-person visits. Generally, the pets, the owners, and the veterinary staff experience significant stress trying to manage these patients. Veterinary telehealth can bridge the gap in all three of these scenarios to provide care to pets who may otherwise be underserved. Veterinarians are very skilled at making medical judgments and recommendations. If during a telemedicine appointment we feel that a patient needs in-person care, we will inform the client and explain the reasons behind that recommendation. We do the same thing when we see a patient in person. If we feel that patient needs to be referred to a specialist or an ER, we will inform the client and explain the reasons behind that recommendation. Allowing telemedicine will expand options for clients, pets, and veterinarians, and I strongly support the modification to SB 190. Thank you so much for your time, and I am happy to answer any questions.
Thank you so much for your testimony. Did you get an opportunity to listen to Dr. Michelle Forella earlier from the Connecticut Veterinary Medical Association?
I did not. I was actually at work, so I couldn't hear that part. Yeah.
Dr. Forella was speaking about the fact that the current laws allow telehealth visit for a pet to receive care. The only issue is that we are talking about a modification that may result in even a new client or new patient to have a telehealth visit. And I think that's what you are advocating for.
Yes, so it would be for establishing the veterinary client-patient relationship based solely on a virtual visit, as opposed to having to see them in person. Correct.
Even for a new client, first visit.
Even for a new client, yes, one that we've not seen in person. Correct.
And I think that's. Would you have some limitations around that for an immediate management followed by an in-person visit? The reason I'm saying that is that there is a pushback from some of your colleagues and organized groups of your colleagues with the Veterinary Medical Association, which says, hey, don't touch this, we already have a law. So I'm trying to see where can we find a way to work together.
Mm-hmm. Yeah, so I think that the pushback a lot of times is that they're concerned, a couple of reasons. I believe that they're concerned that it will be inferior quality care. But typically the patients that I see either will not be getting any veterinary care. So many of them, again, I ask them and they say, well, I can't afford to go to a vet. And this is really their only option. And those pets are suffering and they need to be served as well. So these are pets that would not, ever go to a vet hospital in person. The other concern is that, if we don't have, like, it's maybe like an inferior form of care. And the thing to realize is that when you practice veterinary medicine, there's a huge spectrum of care. So even when we see people in person, we can't necessarily do everything that we want to do. So some clients can't afford it even when they come in. Sometimes we would make recommendations, do, X, Y, and Z, and they can't do it in that circumstance as well. So it's not really much different than making clinical judgments in person. And certainly if I see a patient that really needs to be seen in person, then I would inform them right away.
So I'm going to draw a parallel from human medicine. We passed a telehealth law in the state of Connecticut, and that's where, so I've followed some complaints in the community, and there are entities out of California, and a patient can call the company who has somebody from Connecticut who has a Connecticut license, and they would say, I'm having attention deficit. And the person would have met them for the first time and say, oh, okay. In about 3 minutes, they will have a prescription of whatever they want. And that'll be called in. So it's like no human contact except perhaps a picture for 2 minutes or 3 minutes. And it's a prescription pushing entity out of California who has one clinician or more clinicians who are licensed in Connecticut sitting in another state. And those kind of entities start to come into the market and just flood the market, and people who are seeking treatments or are too busy, do not get assessed. The reason I heard about them was complications were happening, and when the complication happened, they said, go to your doctors. And it's just like, wait, you are not even a doctor and you're prescribing all these medicines, and now you are telling us that all the complications, we have to deal with them, and you're not even available to give us the data. So that's part of what's happening. Do you see, if we open this door, that something like that would happen with a large shop out of another state just coming into our state and using this?
Yeah, I don't see that as happening, to be honest with you, because most people practicing telehealth, veterinarians, are using it or prescribing for very simple things. So we will prescribe, for example, like an ear infection, 2 weeks of an ointment for, and we advise them to follow up with their veterinarian. And again, usually these are people that have tried to get in with their veterinarian and were told that there wasn't an appointment available for several days, and their pets are suffering at that point and really need to have care. We also do it for, again, simple skin infections. I myself will not prescribe for anything long-term. I don't prescribe any anti-anxiety medications or heart medications or anything where they need to really have to be examined in person or where they need to have significant follow-up. And if I believe that that patient needs that type of care, then I will explain it. So these are kind of ways to bridge the gap for simple things like flea medication or deworming medication or simple infections. Most vets are not going to prescribe long-term medications using telehealth. And a lot of states do have some restrictions in terms of how long you can prescribe. Sometimes it's only for 14 days or 30 days worth of medications in order to prevent that type of issue from coming up.
Thank you. This is very helpful to us. Thank you so much for your testimony. And seeing no other questions, we'll move to the next person on our list.
Thank you so much.
Thank you. Aliana Manji. Hi, Aliana.
Hello. Dear Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Aliana Manji and I live in New Haven. As a graduate student of the Yale School of Public Health and the Department of Health Policy, I thank you for the opportunity to testify in support of raised bill number 196. In recent years, hospitals across the country have been purchased by private equity firms. These firms often restructure hospitals financially in order to generate short-term returns. This is exactly what happened right here in Connecticut. Under private equity ownership, Prospero Medical Holdings required its Connecticut hospitals to borrow $457 million to pay a dividend to investors. That money did not go to patient care, staffing, or facility upgrades. It was used to generate returns. At the same time, the real estate beneath Waterbury Hospital, Manchester Memorial, and Rockville General was sold in a $1.4 billion sale-leaseback transaction. Those hospitals lost ownership of their core assets and took long-term rent obligations. All three ultimately ended up in bankruptcy. National data shows similar risks. Approximately 25% of hospitals acquired by real estate investment trusts closed or filed for bankruptcy, compared to only 4% of comparable hospitals that did not enter those arrangements. A recent study also found that after private equity acquisition, hospital-acquired conditions increased by 25.4% among Medicare patients, even as financial returns improved. These are not just financial restructurings. They affect staffing, services, ED department capacity, and ultimately patient outcomes. Doctors and nurses take an oath to put patient well-being first. Running a hospital solely as a business can put that oath at odds with financial targets. When we take authority away from the people trained to protect patients and shift it towards primarily those accountable to investors, we endanger the very people our healthcare system is meant to serve. Connecticut is not alone in recognizing this. In 2025, Massachusetts passed House Bill 5159 to strengthen oversight of private equity investment in hospital sale-leaseback transactions. The law requires advanced regulatory review, increases reporting requirements, and mandates disclosure from significant equity investors. It also subjects hospitals to real estate deals to stricter scrutiny. A neighboring state with one of the most sophisticated healthcare systems in the country examined these risks and concluded that stronger guardrails were necessary. Raised Bill 196 is an important step as it recognizes a real problem. But as written, it's not yet strong enough to fully address the risks we've already experienced right here in Connecticut. In my written testimony, I suggested several targeted amendments: stronger review timelines, no exemptions for distressed hospitals, a clear definition of controlling interest, and real enforcement. Without those clarifications, the bill risks identifying the problem without fully preventing its reoccurrence. We've already seen the consequences of weak guardrails in our state. We have the data, we have the lived experience, and we have a neighborhood model that shows stronger oversight is achievable. This bill is an important step, but without thoughtful amendments, it's not strong enough. Thank you for your time and consideration.
Thank you so much. Would you be able to speak a little bit about some of the amendments or changes or you're suggesting again?
Yes. So like I said, online in the written testimony, I've outlined it more, but some of them include, for example, the hospital has notified the commissioner and attorney general no later than 10 days prior to finalizing the sale-leaseback transaction. So 10 days is not a meaningful review period. That's one of the things that I've highlighted. I also highlighted, it says it uses the term controlling interest, but does not define what that means, and has no definition section clarifying what constitutes as control or direct or indirect ownership. Also, the bill does not specify what happens in attestation. So the Mass Bill, House Bill 5159, talks about imposing penalties of $25,000 per week. In the current bill right now, we don't have those types of penalties, and I think that having that would make it a lot stronger. And then also the bill states that nothing in this section shall be construed to prohibit a hospital or any affiliate of a hospital from investing either directly or indirectly in a joint venture. So a joint venture isn't inherently problematic, but we're not really sure what that means. Without clear definitions and guardrails, the hospital could enter into a joint venture with an entity that's partially managed or financed by a private equity firm. So that's not clear enough in our existing bill.
Okay, so some of the clarity around that would be worthwhile. Good.
Yeah.
Excellent. Good. Senator Gordon has a question or a comment. Senator Gordon, you're on.
Thank you, Mr. Chairman, and I appreciate you testifying. I did read through your testimony. You may not know, but I'm also a doctor, so I'm well aware of how hospitals work in patient care. This has been an issue I've been highlighting and working on, including this session, to see what we can do about private equity dealing with any interest in a hospital. My feeling is it should be outright banned, and so should the real estate transactions, which serve no purpose when it comes to a hospital other than another way for an entity to make money at the expense of the hospital. I did read through some of the things that you mentioned. I'm familiar with how the Commonwealth of Massachusetts does its determination of need. They call it a DON process. We call it a CON. It's the same thing. They actually have some good stuff. I know there's some things based upon their model and Rhode Island's model that I submitted with several of my colleagues last year and again this year to put in certain timelines and certain reviews. One of the things that I would like to ask you, and I did read through your testimony, is if you can just expand a little bit upon when you're talking about some of your concerns about what is being defined or perhaps not well defined. Are you referring to if hospitals wanted to make any arrangements at all with a private equity, for example, but the private equity doesn't have a controlling interest financially? Or are you more concerned about what arrangements, let's say, a hospital might make with some other entity that then somehow that one ends up being in the hands of a private equity or things like that? I just want to better understand some of what, in that regard, when you're talking about wanting to better define things. If you have just a couple of bullet points, you don't have to if you don't have them, but as far as, you know, some examples that your concern is about.
I think it was more on the second point. I think that kind of goes back into the joint venture part. It's just kind of unclear of how that structure would happen. Yeah, honestly, I think I need to do a bit more work and research towards your question. I can look into that more and get back to you.
Oh, thank you. And again, I wasn't trying to put you on the spot, but the issues you raise are issues that a number of folks have raised, including myself. And there's certainly a realization in this state that private equity in hospitals has been devastating, Prospect Medical, and then when they entered into that real estate transaction, that just made things worse. And you know, you did also mention about a hospital facing financial distress. Can they be allowed to have to go to private equity or go to a real estate transaction? If they're already in that degree of financial distress and they're going to want to partner with the devil, it's not going to turn out well. And I just want to make certain I'm understanding that. I don't want to put words in your mouth, but my question is that how you're viewing it, that if we're giving any exemptions or any way of letting hospitals in such distress that they have to go to those entities to quote unquote be saved? Is my understanding from what you're saying in your written testimony that that's something that you're not advocating for as far as what you're testifying and looking for us to take into account relative to this situation?
Yes, I think that would be correct. Yeah, I mean, I think I pointed out how, like you said, if they're already in that much financial distress, why are they, like you said, like making a deal with the devil? Why not, you know, take out loans, or there's other options. So I think that's correct. Yeah.
No, I appreciate that, and there was certainly a very interesting report that came out from the Congressional Budget Committee, bipartisan, just highlighting the sheer magnitude of what for-profit private equity has done in various hospitals. And we certainly saw what unfolded in Massachusetts. Far worse, 2 hospitals lost. The state on the hook for far more than Connecticut's on the hook for. And just the sheer number of healthcare jobs that were lost, which is a shame. So I appreciate you testifying and highlighting this, because I hope lessons have been learned in this state, and I think there is certainly an effort to see what we can do to not have this happen again, because there's no way one can afford it to happen again. So thank you for testifying. Thank you, Mr. Chairman.
Thank you. Seeing no other questions or comments, thank you so much, Aliana.
Thank you.
Thank you. Next person on our list is Liz Evans. Welcome. Thank you, Liz. Good to see you again.
See you too. Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Liz Evans, and I'm here in strong support of SB 195. I'm really grateful for the opportunity to speak again to this bill. It's important, and it allows us the opportunity to come together and show our support for something that is sadly poorly understood. I'm a nurse by training. and I moved from clinical nursing into housing and community public health during the first major overdose epidemic in the mid-1990s, when communities were losing people at a pace we'd never seen before. I never stopped thinking like a nurse, and nurses are trained first and foremost to keep people alive. In the early days of the crisis, I would walk to work and pass people lying in doorways. Sometimes they were asleep, sometimes they weren't. I checked their breathing, I felt for their pulse, I initiated CPR, and I learned that line between life and death, which can just be minutes away, and that those minutes matter. At first, I believed that if we could simply offer more treatment to people, that they would stop using. I'd not yet been fully up close to the daily reality of working with people who use substances. And without that kind of closeness, I think it is really difficult to truly understand what's going on in people's lives. And I say that with humility because it was true for me. How could I have understood until I was standing beside somebody who was no longer breathing? This issue changes when you witness that level of pain, and when you see oxygen levels fall, and when you begin CPR, and when you wait to see whether a pulse is going to return. In that moment, it's not about a debate. There isn't really any ideology. There's only a human body in front of you and the urgent need to keep that person alive. What I learned from being embedded in communities that were suffering is that people do not stop using drugs because we would like them to, but they do stop dying when somebody is there to intervene. Since last January, 856 Connecticut residents have died from an overdose. And since we last had the opportunity to come together and vote to open an OPC pilot in Connecticut, 516 more people have died. These are precious lives, they're not abstractions. They were kind, clever, funny. They were loved, and their lives mattered. Obviously, we cannot say how many of those lives may have been saved if we had an OPC already in place, but we do know that no one has ever died of a fatal overdose inside of an OPC anywhere in the world, not one. That means at least some of those 516 people would still be here. There's a human cost to delaying that's measured in funerals, empty bedrooms, parents who will never stop wondering if there was more that they could have done, and in families permanently traumatized by a preventable death. In an OPC, the critical moment does not end in a funeral because there's oxygen and there's naloxone and trained staff. There's immediate response, and when that crisis passes, there's the possibility of connection and help when a person is ready.
Excuse me, Ms. Evans, but your time has run out. Thank you.
Actually,
I know.
If you want to finish your thought, please go ahead.
Well, I think that overdose prevention sites are often misunderstood. They're portrayed as permissive or irresponsible spaces where drug use is somehow celebrated, but they aren't. I think they're socially responsible places because they acknowledge that there is a real epidemic and that we're willing to use every evidence-based tool in our arsenal to respond. They're not a replacement for treatment. They're not an entire recovery system, but they are a recognition of a reality that people are using drugs and often in profound pain, with trauma and isolated. And the question isn't whether or not we approve of their drug use, it's whether or not if they'll end up doing so alone and dying, or in a space where someone can intervene and keep them alive. The only other thing I'd like to add, and thank you for letting me continue, is that OPCs in the system of substance use treatment in any community and society are kind of the equivalent of an emergency department in a healthcare setting. So in our response to substance use, no one would ever suggest that we eliminate emergency rooms and rely only on inpatient beds if we're talking about any other illness. The emergency department stabilizes a person when they're in crisis, and it keeps them alive long enough to access further care. Without that, there can be no recovery, and OPCs do that by helping create the possibility of a tomorrow. It's been said repeatedly that where they operate now in New York, Rhode Island, and where they operate all around the world, they are effective at reducing overdose deaths, reducing ambulance calls, reducing public drug use, reducing the spread of infectious disease, drug-related infections, and increasing treatments to connections to treatment. when someone overdoses and they're met with dignity in a space that establishes trust, anything then becomes possible because treatment can emerge from that place. To the point of showing leadership and next steps given the federal climate, I'd just like to add that Connecticut has already shown tremendous leadership with this federal government and also in the way we address substance use. We've expanded naloxone services, we've invested in medication-assisted treatment, and we've strengthened our recovery services. This is a pilot bill. It's regulated and it's fiscally responsible. But for the people that would use this space, it represents the difference between life and death. We're not choosing between drug treatment and public health. We need both. We need both stabilization and recovery. We need emergency response and long-term care. This bill strengthens our continuum and keeps the people most at risk of dying alive long enough to have that chance. Thank you so much for your public service and for your thoughtful consideration of this bill.
Thank you so much for your testimony, Liz. And I think for the people who are listening or who are here or outside of this room, I just want to say a few things about you. You are the most experienced harm reduction person in North America, and you're one of the most sought after speaker internationally on harm reduction. And it is because of your efforts for the past some 20 years that Vancouver has had this harm reduction center, which has churned out so much literature and data and saved hundreds of thousands of lives and rehabilitation. And you've been very gracious to spend time in Connecticut and be here to help out. And it's unfortunate that a person who's saved and helped save thousands of lives across the world through some of your efforts have not been able to get the state of Connecticut to come together and pass a law, which is such a basic thing in the bigger picture. So I just wanted to say that, and I wanted to thank you for your work. Can help me bridge this gap. If, God forbid, right here somebody is overdosing and somebody produces Narcan and helps him out, they would be called a hero. And if you do it in an organized fashion, you'll be called a criminal. How did we get to this point?
Yeah, I mean, I think that there's a history of morality around substance use that has unfortunately led to confusion around the difference between public health and public safety. And I think it was really excellent that Lauren provided the testimony from our police partners and the CLEAR initiative, which Liberation is a partner with them on. And I was at that meeting that she was referencing when the police came out and said, we need a place where people can go to use drugs. And I was like, that's a good idea. And it was literally them saying, this is a problem that we encounter every day. But I think, and what my point earlier was about standing there and watching somebody die, is it isn't theoretical, and that's why the police understand it. And we often found ourselves most aligned with people who are the most in the front of this, you know, which is why people like yourself who work as physicians in hospitals, you know, understand you have to talk to families that have lost loved ones. I don't know how many parents I've had to speak to directly. I met a mom at an airport one time. I had to tell her son had died and watched her crumple in front of me, you know, and it's just the reality of dealing with this in the real world changes the way you think about it. And so when you're distant from it, it's easier to think about these terms like illegal drugs and be afraid of them, as if somehow they have this magical kind of capacity to infect everybody that is in the same room as somebody who uses drugs. But we use polite terms like stigma, but what we're really talking about is human beings that have been so mistreated and so marginalized and so blamed and vilified that it becomes very difficult to understand what's public safety and what's public health, you know? We're just trying to help people get better. That's what we all want.
In the streets, what I'm seeing right now is, and in the last many months, I've been going in the middle of the day or early morning to see people who are unhoused. The patterns that we are seeing in our society, maybe the death rate has decreased, but there's usually a situation where as the death rate decreases a little bit, the total number of people who are consumers increases. And we're seeing an increase in that pattern where there's already evidence by reality that we cannot get people into treatments. We cannot get them into detox facilities. We cannot get them into outpatient facilities. So we are running out of the clinical options, and we have sort of walked away from that, and the number of people who are in need of help has been increasing. Is this probably just going to go away because we are not willing as a collective to pass a law and then address this? And are we going to just continue to celebrate that, oh, the death rate has decreased, Narcan is great, and then let's keep giving people Narcan, which is good, but we're not really solving the whole bigger picture, whether it's a rehab strategy or whether it's an emergency room strategy. So what would it take, and what has it taken for other states to, legislators and perhaps the other elected officials, to wake up one day and say, you know what, enough is enough, this is what we have to do, just like what Rhode Island did?
I mean, I do think it's important that people understand this is just a tiny little thing we're talking about, and it always kind of blows my mind that it is such a tiny little thing, you know? The one we opened in Vancouver back 24 years ago was 1,300 square feet. We used to joke it was the most contested 1,300 square feet in the country, in the continent. But it's a tiny thing, and it's just one piece of what's needed. It's not everything. We need all of the things, but this is the piece that's missing right now. And it's something that's been tested, it's evidence-based, we know it works, and it's just missing. So what will it take for us to change our minds and get there? I don't know. I mean, I hope through conversations like this, by destigmatizing what they actually are and what their objective is. You know, they don't cure cancer, and they don't end addiction, but they stop people dying, and they're an essential part of a continuum of a substance use treatment system that we currently don't have.
So, again, your testimony helps, your presence here helps, and the work that you have done is very helpful. It's helping a number of people. That's generating more data. I think we are hopeful that since we have far more information. In the past, people said, well, 40 years ago, the data was from Europe, so we don't want to believe Europe today. Okay. Then we'll say, well, we have 20-year data from Vancouver, so it's Canada, and we don't want to believe Canada. Now we have New York, we have Rhode Island and other things, so I don't know what else can we do on this to convince individuals to figure out that we have to save these lives and then take care of.
The data is remarkably consistent across all the sites, and it
Yeah.
always has been for over 40 years. So I think it's important to understand that the data is only part of what convinces people, right? If it was just data, then I don't think there would be any disagreement because the data agrees. I think it's more complicated. I think it's level of comfort, culture, you know, lack of familiarity. But I mean, I say that with the deepest love in my heart for people that are scared of this as an intervention, because I also came from a place where I didn't understand it, and that's my point.
Yeah.
You have to come up against a person who's no longer breathing and realize there isn't an option. The option is they die, or we do something else. And if we really do care about the long-term well-being of our state, then we need something else. Yeah.
So the stuff I'm struggling with is that 40% or maybe now 50% of people in the state of Connecticut know somebody personally who's impacted by substance use. So half of us have direct person, not like distant. Somebody we know personally. And this is not a political issue because frankly it's equal opportunity for the most part. And I'm using the word for the most part because there's data to support that sometimes challenges are more in the cities and minority communities may be impacted more. But the solutions aren't as status quo is the solution, and I'm having difficulty personally to navigate why is status quo a policy when we have people dying every day, and we have 519 people dying, and then we are saying we are going to wait and see. So maybe you're my therapist today. But
well, I am really grateful that you keep introducing bills to do this, and I think it's essential. And I know that I have a team of amazing human beings in this room who are dedicated to this work every day in Connecticut. So it's a privilege and an honor to be here and to be part of this conversation with you all.
And I'll just add, it's just not me. It was the ranking members joined us. My co-chair has been. We really want to address this issue collectively. So
you as a
while
collective.
I'm sort of the in-your-face kind of a person on this issue at times, but we are all in it together. We are all feeling the pain, and we feel that the status quo is unacceptable, and we really want a solution. So we are hoping our conversation today will get us to the solution that is evidence-based, experienced, and human, and it's coming from the families who are hurting. So thank you for your testimony. I want to make sure, yes, Representative Carpino, followed by Senator Gordon.
Thank you, Mr. Chairman. Thank you for coming. I'll speak for myself, but I suspect there are many around this room and who will be back and are zipping around that this matters to everybody. I think the difference, I am going to disagree with you a little bit. I don't think it's stigma. I don't think for the members here it's fear, but I do think you were accurate in what you said is we all bring different experiences and have different comfort levels and different cultures that we bring to the table. But I don't know anybody on this committee that doesn't recognize the significance of the problem or discounts the lives lost. So I do want to start with that. That is important. But I do have a question. I was waiting all day to find the right person to ask, and based on your experience, I think you're the one. Can these centers be successful, particularly with all of the wraparound services they provide that we've heard about at length over the last couple of years, because they're important? Can they be successful without allowing the open use of illegal substances?
You mean, can they be a drop-in center and not be a consumption site?
Correct.
Well, that's an interesting question. That was a question the Canadian government also asked. However, I think you have to understand that that won't impact the act of using substances, right? So you hand somebody a clean syringe and they have to go somewhere to inject that substance. So right now they're going into public toilets, they're going into McDonald's bathrooms, they're injecting in their car or in the shrubs or somewhere outside. And that will still happen. And if that person is alone and they overdose, they'll die. So you can have a drop-in center that has access to services for people and is very effective at building connections. You know, we have 4, I think, harm reduction centers funded through DEMIS in Connecticut now. You know, showers, laundry, a place to people to go, talk to people, connect them to services, and get clean syringes, get supplies. That's effective. It's a central place for people to come and build relationships. But it doesn't stop that person having to go somewhere when they're using or consuming substances. And it's during that time that their risk of dying is the highest.
And I appreciate your honesty in explaining the difference. I think that is the one sticking point. I don't know of anybody that I've spoken to, I can't speak for anyone, who doesn't believe in the centers. I want to be very clear, that at least my personal struggle is with that one element of the center. It is not about the centers and the very worthwhile and life-saving treatment that they provide. And I know you commented, and I actually wrote it down, that these centers don't end addiction, is exactly what I think you said. I wrote that down. And I recognize that we need to meet people where they are, and that people are on different parts of their journey. But that is still disappointing to me, that if we're going the distance and are allowing them to openly use, if we're still not ending addiction, are we serving these folks with the best tools we have available? And I know that's not an easy answer, but that's something I struggle with. If they're still not ending addiction, isn't that our ultimate goal, is to truly save these folks and help improve the quality of their lives? And again, that's just maybe a bit of a commentary after listening to you, Senator. That might be where I struggle personally, but I want to help them end their addiction. I want to see them improve their health outcomes beyond their struggle. And personally for me, that's my goal, is to help end the addiction and prevent others from going down that road. So I thank the committee maybe for indulging me, but this is an emotional topic for many of us. You're right, I don't think there's too many folks who haven't been impacted by having a friend or a loved one struggle with substance abuse, but I know my personal goal is to prevent folks from turning to these substances initially, and for those who have, not just having a safe place to use, but actually having enough resources to quit. Thank you. Thank you, sir.
I appreciate that. I would just add, though, that in saying they don't end addiction, that's just the truth. Nothing, no one single thing ends addiction. But are they part of an addiction treatment system? Absolutely. They're the entry point, like the emergency department, like the place that people go to not die. And in that place, like Carson said in his research stats that he recounted, you are 42% more likely than if you don't go in to go to a detox. The studies show the increased likelihood of accessing medication-assisted treatment, detox, or inpatient treatment go up just by walking in the door. Do they end addiction? No. Does residential treatment end addiction? No. Does detox end addiction? No. I mean, if I'm just speaking honestly, that is the great mystery, right? We'd all be very rich if we had the answer to that question. It's not that none of us want to watch people suffer and struggle with their relationship to drugs. It's painful, and that's why we do this work.
And then I appreciated your honesty, and I know that. and that is why I think it is a struggle for some of us, because all of these centers are one step closer and connect them to important vital services. That's why this committee has historically addressed opioid addiction and the ailments and the struggles of
We
individuals.
lost the voice again.
It's okay. Thank
Wait.
you for your kindness.
Don't go away yet. We're going to fix this. Check one.
It may be back, but it's no.
There you go. Can you hear me? No. Is that working? Hello? Oh. Hello? Hello?
No.
Nope. There, that sounds like it's working now.
We're back. Sorry. Go ahead. Representative Carpino, you want to finish your?
Just wanted to say thank you, but now I'm really loud. I just wanted to say thank you for your experience, and everybody's voice here matters, and I appreciate you also giving voices to those we've lost.
Thank you.
Do you want to answer any of the parts, or should we go to the next person?
I think you can go to the next question.
Okay, good. So Senator Gordon, followed by Representative Sapkus.
Thank you, Mr. Chairman, and thank you for your testimony. I don't think any of us, even if we've not supported the legislation in prior years, is saying we don't want to follow evidence-based data, or that we don't want to be helping people. I think we all look for responsible and realistic things we can do, but also staying within appropriate legal frameworks that we do have to be aware of. And I do appreciate the work that's done in wanting to help people. One of the things I'm mindful of, it's been cited about Vancouver, and Vancouver is not the United States, as we know, and they have different federal law, and I think it's section 56.1 of their Controlled Substances and Drug Act that gives an exemption for overdose prevention centers to allow people to use illegal substances there. And whether or not they come off drugs or not is a separate issue. But that's Canadian law, and we have a different Controlled Substance Act. And people can debate and continue to debate what the interpretation of it is, and that spans several presidential administrations of both parties. But one of the things that I think it's important is that it's not that, speaking for myself, I'm looking at a stigma for people who use. I'm a doctor. I actually do take care of people who are using and try to connect them to the right resources. And also extremely mindful of the narcotics I prescribe to people who have cancer pain, being careful about overdose and what we have to do in that regard, and sometimes treat it. But part of the concerns that get raised, and we don't always hear much about it, I'm not blaming you, but from people who are advocating, is there are legitimate concerns that have to be taken into account about what the federal law allows and doesn't allow. And that's a reality. And we've had prior testimony from Demas, not this year, but prior years, stating that concern. Right now, since we've heard earlier today from the DPH Commissioner that she's not aware federal law has changed, and I'm not aware there's been any further court rulings or the Supreme Court has changed anything relative to prior legal interpretations of the law, I think it's important to make certain that people understand that that is a legitimate concern. And I do want to mention that because sometimes it doesn't get brought up as far as what we have to think about. So I do appreciate and I do understand the points that you've made, and I know when we received data previously about outcomes and benefits, I've reviewed through all of that and been very open-minded about that. But there is that concern, and it's important for people to understand that that is one of the things we think about in anything we do as a state legislature as far as where we stand legally with what we can and cannot do. And there is federal law that overarches state law. So I just want to raise that, but I do want to thank you for advocating and the work you do, and some of the points that you've mentioned are certainly very important for us to be reminded about. So thank you. Thank you, Mr. Chairman.
Thank you.
Can I make one point?
Please.
In response? In Canada, we did go to the Supreme Court, and it was Section 56 of the Controlled Substances Act that we requested an exemption from in order to open the injection site. We had one federal government when we won the first case, so we opened as a 3-year pilot. During that 3 years, the government changed, and they were going to not extend that exemption. So we went all the way to the Supreme Court, took us 8 years, and in the end, we won a unanimous Supreme Court ruling where all 9 Supreme Court justices ruled that not allowing the exemption would result in death. And so it was unconstitutional not to grant that exemption. The exemption only covered our site, that's it, just Insight. Didn't cover any of the other OPCs that opened after that. Then, because of the overdose crisis in the province that I was in, the provincial government, state government, decided it was an emergency. So they declared a medical emergency, and they opened overdose prevention centers without any further federal exemptions from the drug law. So nothing changed in the drug law at all. And they opened about 40 more overdose prevention centers across the country with no change to the federal law, similar to what's going on in Rhode Island, similar to what's happening in New York. So the state has power and can act. I totally understand the fear of the federal oversight and that that it's real. But I would say that, we haven't seen any repercussions yet in Rhode Island and New York, and they've been able to function. And as somebody who has literally stood over loads of bodies of people not breathing, the legal context doesn't change what happens to the brain without oxygen for 4 minutes. So the limit to the legal context in my rationale does not cover the entire reality of this topic.
And I'll just follow up that, what you cited relative to Section 56.1 in Canada and whatever court cases they did there, that's Canada. Right now, we don't have anything similar on the federal level. And we have to be mindful, and I understand your viewpoint. I just want to make certain that folks understand that As legislators, we do take an oath to want to uphold laws, and so that is a legitimate concern from some people. Not that we don't want to help. I'm not fearful of that regard of the federal government relative to the Controlled Substance Act. But however, there is concerns that some people raise, I do as well, making certain we're comporting with the law. If the law changes at the federal level, either by Congress or by the United States Supreme Court, then situation changes. But I think one has to understand there are some legitimate concerns when it comes to legality, and that is important that we have to take into account as a legislature the way we do function. So I appreciate the discussion. I don't want to belabor things, Mr. Chairman. I know a lot of other people want to testify, but I do appreciate your testifying and for your comments and for the information you provided. Thank you. Thank you, Mr. Chairman.
Next is Representative Zupkus, followed by Representative Claire Disteacher.
Thank you, Mr. Chair. Thank you for coming. It's very powerful. I can't imagine probably some of the things that you've experienced with people. I mean, everybody is somebody's child, mother, father, sister. But I kind of have a process question, if you will. Someone comes in and you give them clean needles, you test the drugs, I guess, right? That's what I've been hearing. Does the person stay there through the whole process of the high experience?
People do all different things because people are individuals. It's not like a required process. There are required steps for people when they come into sites. The first step is that you have to be a registered person at that site. So it's not open to the public. You have to have gone through a registration process, which consists of some questions, some underlying knowledge about your patterns of use, what drugs you've used, that kind of thing. Typically, a person is asked, what type of substance are you going to be using, so that we know what to watch for in terms of signs and symptoms of overdose. In Rhode Island, they have consumption rooms for smoking, and they have booths for injection. In Canada, we only had injection booths, but they have now other sites with lots of smoking rooms as well, because the general trend in substance use over the last 20 years has been away from injection and towards smoking. So we're seeing a lot more smokers than injectors, which is actually a good thing when it comes to infectious disease, but also skin infections, deep tissue infections, that kind of thing. But then the person would be led to either the booth where they're going to inject or the room where they can go and smoke. They're given the clean equipment and they're monitored. So that means there's people around within usually several feet of where the person's using. There's usually mirrors the person's using in front of, so they can see behind them, so the person behind them can see their face if they were to lose pallor or color, so a sign of, low oxygen levels. And they would intervene. They'd bring the oxygen up and do the overdose intervention right there. It's usually very quiet and calm. It can happen quite quickly, because if you catch the person, it's like drowning. The second they go under, if you pull them out faster, they're less likely to die. So it's a important thing to be able to monitor immediately what's going on. And then usually there's, in the designs of the ones that I'm familiar with, there's a room that people can go to after they've used, and called all different names, but in our site it was called the Chill Lounge, and that's the place where people can go and rest after they've used and be monitored. And usually that room is where there may be other types of supports and resources that people can connect to, or they may be other services in the actual physical building that that program is part of. So they could, for instance, leave that injection area or that consumption area and go out, and there might be, like in Rhode Island, a clinical space right across the hallway where they can go and talk to a therapist or a counselor and meet with a physician and get a prescription for MAT or get tested for Hep C or HIV or get primary care. Or if you're in Vancouver, you can go upstairs and go to detox, So all those things are around for people to access.
So they're there for access, but when someone comes in, uses, they could stay as long as they wanted to or not.
At the actual booth where they're using?
So you go into a booth or your smoke room, you do your drugs, and then can someone just leave right after that, walk out the door? or do they?
They're not forced to stay. They could, yeah.
Okay, so they could.
Mhm.
Okay. All right, and what about, you mentioned when people walk in, they're asked questions and all, and so if they're minors, do you do anything different?
In Canada, we had separate protocols for anybody under 18. They were youth protocols. They included a whole load of extra steps, including notifications and stuff like that.
Notifications to parents and families?
It depended on the person's circumstances. But we had a liaison in the equivalent of your DCF type office that we worked with. So we worked with a lot of youth that were in care or had fallen out of care living on the street. So we had like a youth liaison team through our DEMIS equivalent that we worked with. So we always talked to them, and then we connected them to those youth resources as part of coming to the center.
So just as my last question, so could someone come as many times as they want to? They could come forever if they want to. And as regarding the youth, is that the same for youth? They can come as many times as they want before someone is contacted?
Well, the youth protocols are put into place the first visit. So the first time they come and we find out that they're under 18, we implement those youth protocols. So if it's connecting the person to a youth worker or somebody who is going to engage them in follow-up supports and care, that gets initiated at that point. That doesn't then prevent them from using the site. And in fact, the Vancouver police at one point went on the radio after a 13-year-old was found dead in a hotel room and said, everybody should know that people need to go to Insight no matter how old you are, because we don't want to find 13-year-old bodies in hotels.
Of course.
So it wasn't like a...
Right.
Yeah.
But I'm just curious as the process, I understand everyone's different, but the general process is if the minor comes in, they're automatically connected with someone, and then parents or guardian or someone would be notified.
There were protocols in place in Canada that would probably be quite different from protocols in the US. It's a different system. It's a different set of services. It's hard for me to do an equivalency in my mind about what those would look like. But obviously we don't want people dying, and so we would rather they used there than use somewhere where they could die. But my assumption is that we would connect youth services in some way to anybody who was underage that was coming in. Yeah.
Thank you.
But not to deter them from having access to a life-saving health service, yeah.
Thank you, Representative Zupkis. Representative Claridis Dietra to be followed by Representative Dauphiné.
Thank you, Madam Chair. Thank you for being here today. You were talking about, with Representative Zupkis, minors, so someone under 18. Is there an age restriction on the youngest side? Like who's the youngest you'll take in one of these centers? Like, can you have an 8-year-old coming in there?
Never met an 8-year-old who
Right,
injected
I know,
drugs. So.
I hope not. I'm just saying, is there a limit to, is there an age restriction at all? So you'll take anybody. I'm asking, not judging.
Okay, the site's been open since 2003, and I doubt we've ever served anybody under the age of 17, to be honest.
Okay, thank you. And then we've talked a lot about, and you mentioned in Canada, about the legal restrictions, whether it's federal or local. And we know that Rhode Island opened in January of last year. But also Pennsylvania is having some issues. They haven't opened because they're having federal and state issues with their centers. So I'm just concerned what happened in Pennsylvania could possibly happen here in Connecticut if these open here. Or for that matter, in any other state, if someone challenges it federally, even in New York or Rhode Island.
Pennsylvania, before they opened, decided to ask the question, can we? And they went all the way through the courts to ask that question. And one court said yes, and another said no. Because the court that said yes, they appealed the decision, and then the second, I forget which circuit court it was, that said no, was where the appeal hearing happened. So it's sort of on the fence. One decision was in favor, one decision was against. That's why when Scott Barris did his testimony last time, the actual legal expert on this issue from Temple University says there is no definitive ruling on this, so we can't really point to the Pennsylvania example and say it was a failure. What we can point to operationally in reality is we've got 2 functioning sites under the authority of state permission that the feds have done nothing about and have been allowed to operate. So we know that. That's really all we know at this point.
Okay, thank you for that answer.
Yeah, you're welcome.
Thank you, Rep. Claridis. Teacher Rep. Delphine.
Thank you, Madam Chair. Thank you so much for being here. I've learned a ton. I too am a nurse, so I can relate to that. My question is, it kind of is a spinoff of Representative Zupkis, what she said with regard to people come in and they have their own little cubby and they go in and they can inject at the site and then they can leave if they want to. And it occurred to me that if you were in a bar drinking and if a bartender saw that you had what they thought was too many drinks and you weren't able to drive, they would stop serving you, or I don't know if they would call the police so that you wouldn't drive intoxicated. I wonder what the ramifications of that were in these centers, right? Because they're injecting and they're either high or some kind of intoxication and they're walking out of there. Did they drive there? Did they walk there? Is that something that you look at?
It's an interesting question. You know, Connecticut is a real car state. And the place where I worked, where we opened our site, was on a very residential area that was walking only. The people that we served, nobody would have driven there. Lots of people got on the bus after. And we had relationships with everybody that used at the site, and so we could tell if somebody had used something that had had a negative effect on them, and we would encourage them to stay. So I would make that point as well. It's not people. Hello.
I think.
Okay.
Are we back? No.
Maybe? No.
How about this?
Hello? Can you hear me now? No.
Faintly.
I feel like I've really dominated the oh, there we go. Okay, I feel like I should get out of here because other people want to speak. This is very granular level operational detail. I mean, the sort of flow through the space and whether or not people stay or leave or go back to the street after they've used is, you know, the staff know the people who come in there, and through relationships and through developing relationships with the people that come in, they're going to know if somebody's not in a good state or not, and would encourage them to stay. I saw that happen a lot. And I would also add, well, none of our folks drove, so that was never an issue. I think in Connecticut, if we saw somebody inebriated trying to get into a car, we would strongly encourage them not to do that.
Yeah, thank you for that. I guess I was thinking of liability, right? I mean, a bartender would have liability in a bar, and in these centers, you said you try to encourage them. I think probably bartenders do the same, or family members or friends sitting around watching someone get intoxicated. I've driven friends home who've had too much to drink. So I guess where does the liability lie, I guess is my question. So something that hasn't come up that I can recall in all the testimony.
Insurance is a whole other conversation. Like it's complicated. We had state indemnity when we opened, which was a key part of opening.
I mean, if somebody were intoxicated and left and drove and killed somebody, there would be huge liability. Just throwing it out there. Just didn't know if that was something you could answer.
Yeah, we did not see people leaving who were getting into cars. Not at the site I operated.
Okay,
They
thank
did
you.
not drive.
Thank you, Rep. Dauphiné. Liz, thank you so much
very
for
welcome.
bringing your expertise, your calm, your wisdom and experience, and we are very grateful for you being here and for also for the work that you do.
Thank you for all the work you guys do. Thanks.
So before we go on to our next, I say witness all the time, I know we're not in a court, but I just want to note, we're at 542 and at number 34. So we want to try and make sure we give everyone a chance to speak tonight too. So with that, I'm going to move us on to Joseph Breen, and I hope I said it right earlier with your family member as well. Please proceed. Welcome.
Thank you very much. You did say correctly. Good afternoon, everybody. Co-chairs Anwar, McCarthy Vahey, and members of the Public Health Committee. My name is Joseph Farine, and I'm a resident of New Haven. I'm here to testify in strong support of Senate Bill 195. Connecticut is currently losing too many residents to preventable overdoses. These residents are not just statistics, but parents, children, siblings, and friends. It's 17:45. Who deserve a chance at recovery. This bill proposes a pilot program for 4 overdose prevention centers. These community-based centers allow individuals to have direct access to licensed healthcare providers who can administer immediate life-saving actions. In over 100 sites globally, including those in New York City and Providence, there have been 0 on-site fatalities. Let us let that sink in for a second. 0 on-site fatalities. Over 1,500 overdoses were reversed in New York City alone over the past few years. These overdose prevention centers are also entry points to healthcare. Visitors can receive counseling and direct referrals to long-term treatment. These centers provide safety for our communities as well. Utilizing a designated space, these centers reduce public drug use and reduce the discarded drug paraphernalia we find in our parks and in our neighborhoods. A single overdose prevention center can save a community over $1 million annually by reducing the strain on emergency rooms, first responders, and our neighborhoods. Many people ignorantly fear these sites will encourage drug use. The reality is quite the opposite. Overdose prevention centers reach people who are currently using alone and in secret, the most dangerous way to use. We cannot help people find recovery if they are dead. It is painfully obvious what we are doing now to stop this in our state is just not working. We need to take our heads out of the sand and stop wishing this problem would go away. We must try creative solutions to this issue. We need to stop sitting on top of the hill, acting high and mighty, while others are dying alone and with no help to prevent their deaths. Connecticut must use every tool available to stop this tide of loss. I urge the committee to vote favorably on SB 195 and lead us with honor, science, compassion, bravery, and common sense. Thank you for your time, and thank you for your service to our state.
Thank you so much, Mr. Farine. Thank you for your ongoing advocacy. Seeing no questions, we will go to number 35, Neha George, to be followed by Leo Nguyen.
Dear Senator Anwar, Representative McCarthy Vahey, and esteemed members of the Public Health Committee. My name is Neha George and I live in New Haven. As a graduate student at the Yale School of Public Health, I've learned, conducted research, and worked on issues related to healthcare accessibility and social safety net programs. Thank you for the opportunity today to testify in support of SB 93. This bill would strengthen oversight, coordination, and accountability across health professions to increase access to emergency medical services across rural regions in Connecticut. There are over 51 million Americans who reside in rural areas where healthcare disparities are prevalent. From cultural perceptions to simply getting to the doctor, rural residents experience barriers to accessing high-quality health services with both health facilities and digital health tools. Connecticut's rural population represents about 9% of the total population, with only 29 health facilities across rural Connecticut, an alarmingly low number.
The financial instability that Connecticut's healthcare system endured in federal fiscal year 24, for example, with only 8 out of 39 hospitals receiving DSH payments, contributes to the constraints on service expansion by providers. Rural Connecticut also experiences challenges with limited transportation, workforce shortages, and resource shortages. Connecticut was awarded $154 million for the first year of the Rural Health Transformation Program. Based on this award, if similar amounts are awarded in years 2 through 5, would result in the program totaling around $750 million. According to Connecticut's project narrative, the workforce initiative is supported by $58.1 million. If or when this bill is enacted, it will empower Connecticut to increase coordination efforts with neighboring states by entering into an interstate compact through which participating states would recognize the home state licensure of EMTs and of the other states in the compact. This could enhance emergency response throughout the New England region. One recommendation that was posed by the Comptroller Office is to identify and connect chronic condition patients to rideshare programs. This bill, along with the Comptroller recommendation, provide effective solutions to this transportation barrier. Some other important DPH-led workforce development initiatives worth mentioning include the Workforce Residency Development Grants and Rural Provider Incentives. As stated in the State Comptroller Healthcare Cabinet Report 2026, incentives such as expanded loan forgiveness and tax credits can help with medical personnel retention. With collaboration across these agencies, this recommendation promotes healthcare accessibility. To conclude, SB 93 would support the modernization of healthcare by an integrated network of agencies while also putting residents at the forefront of decisions. Thank you for your time.
Thank you so much. Thank you for spending time here with us today and for investing in reaching out about this important bill. So we appreciate your time here with us today. Next, we are going to go to Leo Nguyen and followed by Arya Pelletier, who is online. Is Leo here with us? No. Okay. Arya, are you ready to join us?
Yes, I am.
Oh, wonderful.
Okay. There we go.
Welcome. It's so nice to see you.
Nice to see you as well. Honorable legislators, I'm Arya Pelletier, a high school junior at Greenwich Academy and a research intern at Cornell University's Health Policy Center. I request your support for Senate Bill 195 that would allow for overdose prevention centers in Connecticut. Last year, I testified for Senate Bill 1285, which unfortunately did not pass. Since then, over 700 people have fatally overdosed. I sadly know what losing a loved one to overdose does to a family. I remember visiting my brother Alec at a treatment center in Kent, Connecticut on Father's Day in 2018. I was 9 and recall seeing Alec with hope in his eyes, smiling lovingly as he taught me soccer ball rainbows. He looked forward to spending time and moving back home. I recall telling Alec I was leaving for a trip and couldn't wait to see him again upon my return. That was the last exchange we had. 3 weeks after leaving the treatment center, Alec left this world from fentanyl poisoning on his 26th birthday. We were in shock. How could someone on the mend who had so much to look forward to be snatched away so suddenly? The answer lies not in Alec's actions, but in the gaps within our societal and public health system. If Alec had access to a safe place that night where he could find some help in his moment in despair, he would be here today. Alec was a handsome, funny, and athletic teddy bear. He played competitive hockey and inspired my brother and me to play. I was a goalie like Alec and proudly wore his legacy while on the ice, calling on him to guide me from above. Alec's absence is a void that can never be filled, a testament to the failure of our systems to protect the vulnerable. Addiction is a disease, not a choice, just like cancer or diabetes. It is not my brother's fault that he'd succumb to this battle. It is the fault of a system that didn't regulate the greed of Big Pharma that distributed addictive OxyContin, which unfortunately my brother fell victim to. It is the fault of a public health protocol that doesn't prioritize the creation of safe spaces for individuals struggling with addiction. My parents told me Alec would often take a while to ask for help when he relapsed because of societal shame that he did not want to die. That last night on his birthday, Alec had carefully placed Narcan by his side, but was afraid to tell his roommates that he was vulnerable and needed help. Public leaders have made Narcan readily available, but what good is it if no one administers it? If there were a safe, non-judgmental place for Alec to go to that night without shame, where an overdose could be reversed, he would still be with us. Often I wonder what life would be like today if my brother was still here. I wonder what he would be doing for this epidemic, though I have no doubts that he'd be testifying today. Please pass this bill so families don't have to be deprived of their time with loved ones. This bill is essential to reducing deaths and is essential to providing safety and comfort to a loved one and their family. Thank you.
Thank you so much, Aria, for your testimony. Thank you. And you have testified before as well, and you've written a op-ed too. I appreciate your efforts and your leadership and your help. One of my colleagues has a question, Representative Dauphiny, and then I'll make more comments. Representative Dauphiny.
Thank you so much for your testimony. So sorry for the loss of your brother. I'm sure that you think about him every day, and I'm very sorry for that. I think you said that you go to the Greenwich Academy. Do you live in Greenwich?
Yes, I do.
I couldn't help but be curious. Do you think the community in Greenwich would be open to having a center in Greenwich?
I mean, yeah, I would think so. I'm not like super involved in the harm reduction programs that are around Greenwich, but I think so. Greenwich is a pretty inclusive community and tends to invest a lot in the health resources such as harm reduction, so I would say so, yes.
I'd be curious to know, it might be another endeavor you might pursue with going to your town meetings and just inquiring about that. But again, thank you so much. You did an excellent job testifying, and I'm sorry for your loss.
Thank you. I appreciate it.
Thank you again, Aria. Aria, I think you put the human value and the human face to the aspect of the family members, what they have to experience, and then the younger siblings, what they have to experience. And I think that's a very important part of this conversation, and I want to thank you for that. I know it's not easy to do this, and you've done this time and again, and I'm so sorry we have not been able to pass this bill, and you're trying to make sure other families are protected, and that's truly heroic. Anything else you want to say? Anything that your brother would do to make you smile and laugh?
I mean, honestly, I think just being here today, and I know my brother's testifying later today, and he would greatly appreciate that as well as this bill. But other than that, I don't have anything else unless you guys have any questions.
Okay. We do not see any other questions, and then we want to thank you for your testimony.
Thank you.
Thank you. The next person on our list is Jalen Ortiz, who's here. Jalen, thank you so much for being with us, and welcome.
This one? Perfect. Hello, distinguished members of the Public Health Committee. My name is Jalen Ortiz, and I work as a mobile ambassador with Connecticut Harm Reduction Alliance. I thank you so much for the opportunity to testify in strong support in SB 195. I started doing street outreach mid-2023, and frankly, was very inexperienced. I barely knew what Narcan was or even how to use it. Addiction has been a source of so much trauma for my family. Merely being curious about drugs was taboo during my childhood. And I'm a very inquisitive person, so it was very hard for me to not ask questions. Sorry. I got into this field through my father, who wasn't even sure I could handle it because of how deeply sensitive I am as a person. And one thing motivated me, my innate passion to help others feel seen and heard. I say all of this to say there are many, many things I've learned working with my people. But the biggest takeaway so far for me is that a little bit of passion and empathy goes an extremely long way. And as someone who has no lived experience with opioid addiction and therefore makes it my mission to listen to those who do, all I have is the firsthand accounts from people who have benefited from the community built from having something similar to an OPC. Having somewhere to go, to build a sense of community, and find people who are solely there to support our participants and their well-being, in my experience, encourages growth in an unimaginable way. There are people who look forward to going to our drop-in center and hang out there all day, not just to exchange their needles or get a new pipe, but for the fact that we might be the only people they interact with throughout the day that ask for nothing from them but to take care of themselves and their health. This impact shows even though the drop isn't an OPC, and I can only imagine what it'd be like if our participants were allowed to safely use there. They already know we care about them, but having a legal, safe place to use where they can, for example, be taught to find their veins to ensure they're shooting safely, get tested for any bloodborne pathogens that can be transferred from having reused equipment in the past, and potentially even start the recovery process would only benefit them and the community we serve. Last year, when it came to passing or vetoing this same bill, I heard common questions uttered when debating the topic of harm reduction as a whole. Won't allowing OPCs to exist just enable addicts to use? Won't this increase our community's mortality rate? And to that I say, having had my boots in the ground in this community for over 2 years, when it comes down to the difference between life and death, I raise my own questions. Who do we think is more likely to die? A person who's told by their government because of their disease they must live in the shadows and hope that someone gets to them in time in order to save their life? Or a person who's allowed to use surrounded by trusted community members, around-the-clock medical care, Narcan on standby, and phone numbers to call if and when they want to get better? Allowing our people to exist in the light instead of shaming them into darkness not only brings our community together, it saves lives. Thank you for your time.
Thank you so much for your testimony. Thank you for the work you're doing. And then you said you were kind of shy?
Yes. You see the laughter. When I first started working for Connecticut Harm Reduction Alliance, I didn't talk to anybody. Even people within the organization who knew my father from the work that he does, he's been doing this work for I think at least the past 6 years, were asking around my office whether or not, like to my dad, whether or not I even liked them because I didn't talk to anybody. I had just come from, as a transgender person, I had just come from a work environment that was not very accepting, that didn't really give me the opportunity to express myself, and coming into such an open, accepting environment was honestly jarring for me. And for a lot of our people, I feel like I can see that, where they're almost shocked that we care about them so much in a way that, like I said, we ask for nothing from them but their health and their safety. And relating to our people in that way has helped my job in an unimaginable way. Because though I don't have any lived experience, being a shy person and it being so hard for me to ask for help from others, I can completely see why it'd be hard for a lot of people to get help because of states saying that they should live in the shadows and pushing them to the side almost. That's helped me tremendously in my career.
Well, I want to thank you for your testimony and being here. You're a great ambassador and you bring in a lot of positive energy. If I'm going through struggles, I'd love to have you around me.
Thank you.
All right.
Appreciate that.
All right. Thank you so much.
Thank you.
Next is Joanne Flores. Welcome.
Thank you. At first, I was going to say good morning, good afternoon, but it's good evening now, right? Thank you, Senator Anwar, Representative McCarthy, and members of the Public Health Committee for allowing me to stand before you today. My name is Jovan Flores. I'm a certified recovery coach professional and a CT board certified peer recovery professional with MAS, a division of CASA. Again, thank you for the opportunity. In my recovery, I've done a lot of inside work and have had a lot of opportunity to reflect on the trauma and risk that I've caused many innocent bystanders, including children, and what's important to me. I'm sorry, I get choked up when I talk about recovery because it means everything to me and my family. It's a big deal in my family. One of many examples is 2014, my father and my now stepmother have been dating for several years and split the time between his house and her house. Every weekend they would spend the time at her house. across town. I've been missing for several days, so they made what turned out to be a life-saving decision. They decided to stay at my father's house that weekend just in case I surfaced. My memory of the events that follow are very blurred, but my stepmother has sat down with me over the years and talked to me about the late night and early morning. I ended up arriving at the house sometime after midnight and collapsed full overdose on our front entryway. 911 was called, and I flatlined multiple times in the ambulance. And after, for what I was told, 4 hits of Narcan, I pulled through. I can't help but to think, and this is why I share this story, that I was operating a motor vehicle that night in that condition. If I died while I was driving, I could have killed someone, a family, children, and I would have no idea. I have no idea of many sleepless nights and trauma and pain that I suffered and inflicted to my family and through the years of my active addiction, and additionally, jeopardizing the lives of countless innocent bystanders. I do not promote using, and I'm not here to glorify it, but I 100% believe in harm reduction. My personal pathway is a complete abstinence-based recovery journey. I will say I believe that all human lives matter. We don't deserve to be found dead in park benches, public bathrooms, or even in a car at a rest area on 95 or in a Merritt Parkway, because we suffer from a disease that carries such a negative stigma. Without hope, we cannot recover. Without support and safety, it's a risk to everyone in society. I can't help but think of my fiance, who's coming up on 6 years clean with 9 overdoses, but yet beat all odds through early harm reduction and risk prevention. Recovery is possible for everyone, and this disease does not discriminate. In conclusion, I am in favor of the OPC bill that would provide controlled, safe environments with life-saving resources and professionals on hand for the unfortunate human beings who suffer from this killer disease, whose lives matter just like any other American lives in this country. Thank you for your time, and God bless.
Thank you so much for your testimony, and thank you for sharing your experience. It means a lot, especially because we worry about if recovery is possible at times, right? And you're a living example, and you're an inspiration, and you're speaking out to make sure others see you and recognize that absolutely possible to get better and improve and make a difference in other lives too.
Yes, sir.
Thank you. So I have one of my colleagues, Representative Zupkus, who has a question or a comment. Representative Zupkus.
Thank you. Wow. We're really glad you're here and you're clean. I'm going to start crying. You are a blessing and a testimony to a lot of people.
Thank you.
And you're very courageous. You know, when you were talking about driving, that's scary. It's scary for you. It's scary for all of us on the road. And I don't know, because I instantly think of my daughter driving, who's 18. Before I had asked a woman that was here about people driving, leaving, and should they stay until their, pardon my, their high is finished. Would you agree with that?
I think honestly, I think there would be some protocols in place. I know certain bars, the bartender can make the call of a person who's drinking too much. They can make the call of cutting that person off. And some bars, they will take your keys. I feel like there should be something in play in that sorts. You know, like a person dedicated to like a parking attendant maybe, seeing if that person came in. I'm sure there's cameras outside or something, and say like, listen, that person drove here, and if they want to leave, there should be some protocols in place. So I do agree with that. You know, this is a very selfish, self-centered disease. I mean, I used for over 20 years. multiple decades, and I had zero consideration and zero knowledge of what I was actually doing. I can't tell you how many countless times I was driving up and down the Merritt, 95, because call it what it is, I had nowhere to go. OPCs will give me that, an option to go there. I'm not saying I would have, who knows, but I hope I would. I hope I'm it was that decent of a human being to say, I don't feel safe driving on these roads, I would take advantage of an OPC, you know?
Or if you couldn't, which you said you don't even remember driving.
Exactly.
Which is scary for you and everyone.
Mm-hmm.
I would hope that someone at those places, if you were there, that wouldn't let them leave.
Mm-hmm.
And honestly, if you're walking or driving, you know. So I just want to thank you because you really touched me, and I'm grateful that you are here and you've changed your life and your fiance. 9 overdoses. She's blessed to be here for some reason.
It's a miracle.
So good luck to you and your fiance.
Thank you so much.
Seeing no other questions or comments, again, thank you for being here.
Thank you for bringing this bill forward. I appreciate the work you do.
Next is Rachel Lampert. Professor Lampert, welcome.
Thank you, chairs and members of the Public Health Committee. My name is Rachel Lampert. I'm a cardiologist and professor at Yale Medical School, and I'm here representing the Connecticut chapter of the American College of Cardiology. I also serve as a subject expert on the ACC's Sports and Exercise Council. I'm here today to provide comments on Bill 194, which aims to require pre-participation cardiac screening for certain athletes. As a sports cardiologist and electrophysiologist, arrhythmia expert, nothing is more important to me than preventing sudden cardiac arrest in athletes, which is often a heartbreaking phenomenon. Research shows that to do this, identifying those at risk and also providing CPR and AED training are each essential. The Connecticut State Legislature is making a significant step by codifying a pre-participation evaluation process through this bill. The ACC has long supported and highlighted the importance of a thorough history and physical with appropriate follow-up to help prevent cardiac arrest in athletes. As written, however, this bill will establish an additional parallel process that will cause confusion without providing any benefit. Currently, the Connecticut Interscholastic Athletic Conference, CIAC, already requires a process in which, prior to an athlete's participation, a healthcare professional conducts a heart assessment and completes a form, which is then given to a school nurse. This review includes taking a personal and family history and performing a physical exam. This ensures that athletes and families are working with healthcare providers to determine the next steps. As written, SB 194 shifts the responsibility for completing the forms onto parents and coaches instead of medical professionals. While it's appropriate for coaches to distribute information, they're not medical experts and should not be involved in medical processes. I and the ACC urge the committee to amend the bill to formalize what is already being effectively done rather than creating a separate process which will be likely less effective. Couple other comments. The requirement of EKGs for all student athletes for any, quote, yes on the form doesn't provide the highest quality medical care. An ECG is very often the next step, but there may be other important aspects of the workup. The next steps after completing the form during the athlete's exam should be at the judgment of the provider, and we should not imply that the follow-up care is just an ECG and you're done. Finally, the pre-participation screening should involve all athletes and not just high-intensity sports, as all can die suddenly from heart disease, and the data are not adequate to show that there's a difference in types of sports. Thank you for allowing me to provide testimony today. The Connecticut ACC hopes to work with the committee to ensure that this bill aligns with evidence-based science to improve further on what's working and give the best care we can to athletes in Connecticut.
Thank you so much, Professor Lampert. Appreciate your testimony, and thank you for being here in person for this conversation. I just wanted to give you a little background of the rationale for this. And again, like any state, in every state, there have been sad incidents where a young athlete has died. And in the past, we have tried to bring a bill like this before, and it gets less from the science, more from the logistical perspective. So if every student is going to have an evaluation performed, and perhaps see a clinician, a pediatrician, just for that purpose, it becomes, and if it's mandated, it dies on its own, under its own weight at times, the bills. So we started to look at what other states have done. And the various states have done is that they've looked at the risk profile, and most of the time they're looking for two things, perhaps a prolonged QT interval, and maybe if there's a aortic stenosis, IHSS. Those may be one of the couple of things that can be a problem in some of these athletes. So their issues may become more relevant in high intensity sports, because if we do it on every sport, everybody will be up in arms, and the bill will not necessarily pass.
So we have data that show that basically what sport doesn't make a difference. And so to give some athletes more care than other athletes really doesn't follow the science. I think that CIAC, we're doing this in Connecticut, and I think using this bill to make the process that does involve healthcare providers stronger, I think there are ways we can make it stronger. But I think we're doing it now, and I think by codifying what we're doing, rather than putting in a parallel process that takes the healthcare provider and their judgment out of it, we're not doing a favor to the athlete. So I think we can make the bill better. We're not opposing the bill. Rather, we're suggesting that we should all work together, get the AHA, the ACC, Connecticut Medical Society, CIAC themselves at the table to really talk about how can we make this process as strong as we can.
Okay, this is helpful. I know some of my colleagues have some questions and comments, so we'll go around and we'll come back. I want Representative Claire Teacher, followed by Representative Dauphiny and Senator Gordon.
Okay. Thank you, Mr. Chair. Me, over here. Thank you for testifying today. So my concern, or my critiques of this bill, as an athletic trainer, as one who looks at the physical forms, to me, I think the more seamless route would be the state of Connecticut physical forms, just add another question on the form. And then if that ticks something, let the medical provider say, okay, well, if you've checked this box and you've had symptoms or family history, now as your medical provider, I'm recommending you get this extra testing.
Yeah, I totally agree. The form as it is, that Department of Health form, it includes a lot of the 14-point AHA points, and I think we absolutely should think about how can we make that form as strong as possible to say, if you click yes for 1, 3, and 5, consider EKG. I think there'd be a lot of ways that we could use that form to guide appropriate care. I totally agree.
Exactly, and I think taking the coaches out of the mix, they don't need to be involved because that's not their expertise. I think we already have a system in place. Let's just add something that would be the easiest and seamless.
Yeah, completely agree. Thank you.
Thank you for being here.
Yeah.
Thank you, Mr. Chair.
Thank you, Representative Dauphiny.
Thank you, Mr. Chair, and thank you for being here today. I'm just curious, given that we're all data-driven, and I was thinking that it wasn't that long ago, we didn't seem like we had that many young people with cardiac arrests. It seems like it's really on the rise, these sudden deaths. I wondered if you knew the data on that and what the cause might be. And I know Representative Claridge just mentioned like the question on the form, and I was thinking, from what I understand from reports I'm hearing, there may not be any familial information to put on a form, and they may not have had any symptoms. It seems as though some of these young adults and minors are suddenly just having cardiac arrest. Can you speak to that and the data with regard to that?
Well, so a couple of things. So the incidence of arrest isn't actually rising. In the NCAA, it actually has gone down a little bit, likely because of the CPR, the emphasis on CPR and AEDs, but certainly we hear more about it. I think the rise of social media, the internet, like all of these, something that happened 10 years ago in Kansas, we might not have known about in Connecticut, so I think, but certainly it remains a very important question. So the type of pre-participation evaluation that we're talking about will identify many people. It's not going to identify everyone. So lots of people will have something in their history. They will have passed out, or something in their physical. Someone will hear a murmur. The question about family history is actually probably the highest yield of any of them. Has anyone in your family died suddenly before 35 or 40? Because that's the main red flag for the type of problems that Dr. Almer was talking about earlier. And so many will have those. Now, we're never going to catch everybody, but we can catch a lot of people. And that's why we also need CPR and AEDs. So I think they're really complementary approaches. But same thing with seatbelts. Seatbelts don't save everyone, but they save a lot of people, so they're worth doing. So making this pre-participation evaluation as good as we can, I think, is a worthwhile endeavor.
Thank you, and thank you for your testimony. Appreciate it.
Senator Gordon.
Thank you, Mr. Chairman, and I thank you for being here today. I always, when we talk about cardiology, like to thank my wife, who's a cardiologist.
Oh, great.
And a member of ACC.
Oh, great.
I just want to make sure I understand a couple points on this. But one question I have for you is that EKGs in and of themselves, I mean, almost any healthcare professional, especially if you have medical staff privileges, one of the automatic ones, I know it is in internal medicine for me, you automatically get EKG privileges to order them. Not necessarily to read them, but you can just order them on anybody. But just because an EKG looks okay, isolated, without the clinical context, you mentioned about family history, maybe there's an exam finding like a cardiac murmur, but the EKG in and of itself being quote unquote okay doesn't mean you're okay. Is that my understanding?
Yes,
that
that's,
you want to tag
yes.
it to the clinical assessment.
Yeah, and that's why it's so important to keep the healthcare provider in the loop and not move it to coaches, because the healthcare provider is going to have some sense, the pediatrician we're really talking about for these high school students is going to have some sense of where the history and physical is taking them. So the EKG, so they're going to, types of things, chest pain, shortness of breath, passing out, and then the family history, murmurs, are going to send you to the EKG. The EKG doesn't pick up every cause of sudden death. It picks up a lot of them. And again, as kind of mentioning before, we're not going to catch everything, even with an EKG. But keeping the healthcare provider in the loop, that person is going to know, when do I need to even go further, even if the EKG is normal, get an echo, go to the next step. So I think it really emphasizes why it's so important to keep the healthcare provider in the loop.
No, and thank you. I think that's an important point, and I appreciate the intent of this bill. I think more we can do to be of help to try to decrease the risk of sudden death and things where one could intervene ahead of time is always, a good goal when we're dealing with this issue. But you hit the nail on the head, which is have the healthcare professional do that assessment. And my last question is, and I think you've already answered it, is it may be that an EKG is quote unquote okay, but based upon something on exam, based upon clinical experience, judgment, family history, that there might be more cardiac testing. And you want that opportunity
Yes.
because you might pick something up that the EKG won't. That's my understanding from what you're testifying?
Yes, that is absolutely true. Yes.
Thank you, Mr. Chairman.
So I'm just going to repeat what I understand. The existing forms should be modified to be inclusive of some of the questions that will help us identify high-risk athletes. Those forms are filled for all students, and when they are filled, if there is some of those forms have a yes answer, it should trigger an EKG. And that means not everybody's getting an EKG, but the ones who trigger that will get an EKG. If the EKG is fine and the examination is fine, they're home free, go win for their team. But if there is an EKG issue, then accordingly they would have to have further workup. So at least we'll be able to identify. And if the examination shows something, that the pediatrician will make the decision whether an echo is warranted or whatever. Is that a fair summary?
Yes, that we basically work with the forms and process that we have, but I think as several have pointed out, that there are ways that we can make that process even better.
Yeah, good.
Yeah.
Thank you so much. This is very helpful.
Okay, thank you.
Thank you. We move to the next person on our list. Oops. That is Catherine Hill. Welcome, Catherine.
Hi, everybody. Good evening. Hi, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Katie Hill, and I'm here to testify in strong support of SB 195. I'm finishing up my PhD in epidemiology of microbial diseases at Yale School of Public Health under the mentorship of Robert Heimer, who was mentioned earlier. My research focuses on substance use, addiction, harm reduction, and novel substances in the unregulated drug supply. And through my research, I've had the opportunity to work with many of the great harm reduction organizations around our state, Alliance for Living, CTHRA, Liberation Programs, and many more. And we truly have really some of the best harm reductionists in our country here in the state of Connecticut, many of whom have testified today. My research has also extended on the importance of and the need for OPCs, which is why I'm in front of you today. I've helped author scientific literature calling for the need of OPCs based on decades of research from around the world showing that they save lives. And this information can be found in my written testimony. Now, last year, I sat in the same spot as many of my colleagues and tried to make an appeal to you as a scientist, and I'm certainly happy to do that again. I could give you the numbers, give you the data, as so many of you often ask for, and my colleagues have provided yet again another year over. And frankly, let's be honest, if this really was about just the data, we would already have an OPC in Connecticut, because I know, and the evidence points to, the need for an OPC in our state, and the data and the evidence certainly points to OPCs being life-saving, cost-saving, services, all while providing community benefits, decreasing the harms associated with infectious disease and addiction. As my advisor often tells me, the plural of anecdote is not data, but the plural of anecdote is policy. So with the remaining time I have today, I want to lift the voices of those who are typically not brought into these rooms. So over the last week, we asked people who are actively using drugs on the streets why they want an OPC in our state. So I encourage you to please hear their words. So these are actual testimony from folks that are actively using drugs right now. So an OPC would be a saving grace for many of us. I've seen firsthand one too many overdoses. Anonymous. An OPC will help the addicted community use in a safe fashion around people who want us to be comfortable and steer us in a more positive direction. Anonymous. I think it would be very helpful and cut down on the death rate, increase education around drugs and infectious disease. Anonymous. An OPC would be safer. We would be able to use without being alone and at risk of overdose and harm. It also keeps us inside instead of using on the streets. Anonymous. A safe place to use Narcan would be a lifesaver for me. I've overdosed too many times and know my luck is running out. Anonymous. That would benefit me because I would not use in public places and I wouldn't overdose without having someone there to save me. Anonymous. That would lower loss of life as well as privatize the use of illegal drugs. Anonymous. I believe an OPC would be very helpful for people who need it to use safe with dangers and especially the homeless. Anonymous. If I had a place to use, I could go use inside and leave and not be in trouble. Anonymous.
Excuse me, Ms. Hill, but you've reached your 3 minutes. Thank you.
Of course.
How many more testimonies do you have?
There's about 50 submitted online.
Oh, all right. But I think your point is strong, that the people who are living the challenge right now, they feel the same way that this is going to help them. So I'm going to ask a transactional question from a different angle.
Absolutely.
In my interaction with some of the people who were using substances, I sense that they were self-medicating themselves because the healthcare system had failed. Would you be able to see what your experience is in those interactions?
Yeah, absolutely. I mean, I think people use substances for a variety of different reasons. I think in my research, I would say what some people call self-management, some people call it self-treatment, but people also use just for enjoyment or other reasons. But I do think our healthcare system has failed people for a variety of different reasons, and our systems, larger than just healthcare, our social services, housing, our criminal justice system, a lot of our systems have failed people routinely, and drugs are one of the many ways in which people can respond to those systems. And yeah, absolutely. And yeah, I think the drugs that we have today, I would also like to say that, for instance, people talk a lot about fentanyl being, one of the main drugs in the drug supply. And if you look at the testimonies online, people talk a lot in the written testimonies that were submitted about fentanyl being a primary reason why people want to use OPCs, but they also talk a lot about the contaminants in the drug supply and how they would want to access an overdose prevention center because they know that they want to be able to have a place to test their drugs and then use their drugs under the watch of somebody, because they don't necessarily know what the contaminants in the drug supply will do to them once they've used. And so, for instance, we have xylazine and medetomidine in our drug supply, which are sedatives. And these drugs, we don't necessarily think they necessarily can cause, like necessarily impact overdose specifically, but they cause heavy sedation. And this could cause impacts for people to their health because they maybe fall in uncomfortable positions for a long time. Overdose prevention centers can help with the impacts of that as well. They might be in an uncomfortable position and get nerve damage. Overdose prevention centers can help with that as well. People are also using stimulants, right? We don't just have opioids in our state. Overdose prevention centers can help with overamping. If you look at which is essentially a overdose on a stimulant. So if you're using substances like methamphetamines or cocaine, it can help
do you mind
with
if
that.
I ask another question?
Absolutely.
Okay. I forgot my question. You were in a different.
No, I was talking a lot. That's my bad.
Do you have a solution for dealing with stigma?
Oh, big change up. It's a really interesting question. We talk about that a lot in our statewide harm reduction group. I think passing a bill like the Overdose Prevention Center bill is a huge statement for our state to make in terms of saying that our state provides services for people in active use, saying that there's a place that serves you and you can come here and use drugs. This is a place that you can come and there will be people here that love and support you. That is a huge step in the right direction for moving towards an anti-stigma campaign. It's lovely to have a bus that drives past you and that says like end stigma. And while that's lovely and all, it doesn't necessarily like cure the stigma problem. No, I think having something that actually, gives people a place where they feel loved and comforted is much more impactful.
Okay. And my final question is, you work with Professor Heimer, and
Yeah.
he's also helped internationally in Europe.
Yes.
Have you been to one of the centers over there or worked on their data over there?
I've been to Europe with Robert Heimer, Dr. Heimer, but I've not visited one in Europe, but I've been to the one in Canada.
Okay.
Yes. And they're amazing.
Yeah, and do you have looked at the data in Europe in the recent past?
I've looked at the data in New York and the one in Rhode Island. I'm very fortunate my partner works on the data for the Rhode Island one, and I go to Rhode Island almost every other weekend, and it's another fabulous program. I'm close with a lot of the Rhode Island folks and their testimonies online as well. The manager of the OPC in Rhode Island submitted testimony online. I would encourage you to look at that as well.
Perfect. This is very helpful. Thank you so much for your testimony. Thank you for being here.
Absolutely.
Next person on our list is Emmeline Franklin. And go ahead, Ben.
Good evening.
Good evening. Thank you for being here.
Thank you. Senator Anwar, excuse me, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Emmy Franklin, and I am a social worker. I'm also here today speaking in my official capacity as a public policy and advocacy associate at the Connecticut Community Nonprofit Alliance. The Alliance is a statewide association of community nonprofits, and community nonprofits provide essential services to over 500,000 individuals and families in Connecticut every year and employ 118,000 people across the state, improving the quality of life for communities here in Connecticut. The Alliance supports HB 5166, an act concerning social work licensure, which would end the requirement for social workers to pass the Association of Social Work Boards associate level examination prior to beginning practice. Nonprofits operate in an environment of chronic workforce shortages, rising service demand, and constrained reimbursement structures. Their clinic-based work relies on recent graduates who are working towards independent clinical licensure under the supervision of fully licensed clinicians. The Licensed Master of Social Work, or LMSW exam requirement creates a barrier for social work graduates entering the nonprofit workforce. These workforce barriers directly translate into reduced access to care for Connecticut residents. Public Act 2331 temporarily suspended the examination requirement for Master Social Worker license applications. The suspension ended on January 1st of this year, meaning that Masters of Social Work, or MSW graduates from a program accredited by the Council of Social Work Education pursuing a licensed Master of Social Work were once again required to pass the Association of Social Work Boards licensing exam prior to beginning to practice. As we've heard today, the ASWB exam has proven to show a higher failure rate among people of color, older adults, and for people whom English is not their first language. The high failure rate has become such a large barrier to filling critical clinical positions that states like Illinois and Utah have eliminated the exam requirement for non-clinical licensure, with other states pursuing similar changes. While the 2023 suspension was passed in Connecticut with the hope that ASWB would address these disparities, there is no evidence to suggest that the exam has changed. It's also worth noting that there are no licensing exams for the associate licensures for other similarly credentialed staff, such as licensed marriage and family therapist associates and licensed professional counselor associates. And like LMTAs and LPCAs, LMSWs are required to work only under the supervision of fully licensed clinical staff while they train to achieve full licensure. When the exam exemption from PA 2331 expired on January 1st, providers, students, and universities were left scrambling. As of today, anyone who graduates with an MSW will be required to take the test, and with a class of social workers graduating from educational institutions this spring, it's urgent that the committee act on this legislation.
Excuse me, Ms. Franklin, but your 3 minutes is up. Thank you.
Okay, thank you very much. I'm happy to answer any questions.
Thank you. Do you have a couple of sentences you want to
Yeah.
complete? Go ahead.
Yeah, permanent elimination of the LMSW exam requirement is a workforce stability policy, a service access policy, and an equity policy. Thank you.
Thank you. This is your first testimony?
Yesterday was my first testimony.
Yesterday. Well, that's why you're a pro now.
Yes.
Excellent.
This is my third one. Thank you.
Good. I see no questions. I think you were very clear. We appreciate you and the time you've taken to be here. Thank you so much.
Thank you very much.
You guys. Thank you. The next person on our list is, I just want to make sure she's not here, Elizabeth Nemirowski. Oh, you are. We were looking for you in the computer. So, perfect. That's why we actually delayed the whole thing. We just wanted you to be here.
Thank you.
Welcome.
It's good to see you all again. Co-Chair Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee, my name is Elizabeth Znamierowski, and I thank you for the opportunity to testify today in support of Raise Bill 195. I speak to you all today as a nurse practitioner at the Community Healthcare Van and Syringe Services Program in New Haven, and as a member of the New Haven community. My views and opinions are strictly my own and do not represent those of Yale University, Yale Medicine, or Yale New Haven Health. I've had a year to reflect on the concerns raised by this committee at our last hearing, and much of the hesitation seemed rooted in a familiar worry, which is engagement and treatment for substance use disorder. And if we are judging an overdose prevention center by the standard, does this intervention cure the disease of addiction, we are asking the wrong question. No single intervention meets that standard. Instead, a constellation of providers, community organizations, and safe spaces for recovery are crucial to positive outcomes. Addiction is a chronic medical condition, often characterized by a return to use. Engagement with medical systems can be one step along an individual's journey to recovery or remission, but engagement is an enormous step, built on trust, and trust takes time. In our current landscape, devoid of safe places for people who use drugs, time is a luxury that many will not have. And if we are to judge OPCs solely by treatment enrollment, we fundamentally misunderstand their role in the continuum of care. OPCs are not treatment programs. They're harm reduction interventions. They reduce mortality and morbidity so that when someone's ready to walk into my clinic and engage in treatment, then they're alive to have that opportunity. The difference between OPCs and other medical settings it's not medical complexity. The difference is stigma. We do not measure life-saving interventions by whether they eliminate human behavior or judge those interventions based on a diagnosis. We measure the effectiveness of interventions by whether people survive. And we do not abandon our patients because their disease persists. Data from 2022 show that only 25% of people with an opioid use disorder receive medications, and only 16% of those receive medications for opioid use disorder in the 90 days following an overdose, despite 85% of people having some contact with the medical system. In Vancouver, 42% of OPC participants engaged in treatment within 2 years. For a population often disconnected from care, that's meaningful engagement, and it doesn't happen overnight. It's built through repeated, non-judgmental contact. If we want people to heal, we must provide them with the space to do so. OPCs are a step forward towards comprehensive care delivery that prioritizes the whole person. And today we have access to real solutions and the expertise in this room to guide legislation that would impact the lives of thousands. I implore you to recognize the benefits of this life-saving measure so that my patients and your constituents have access to OPCs that will support them, create opportunities for accessible treatment, and provide them with resources that they need to live. Thank you for your time and for considering this bill.
Thank you so much for your testimony. Thank you for the work you do. And would you be able to share a brief anecdote, a brief one, where things changed life for somebody who was recovered?
Yeah, and I think so many people have touched on this before too, but for me, it is the daily interactions with someone. While someone may not come into our clinic immediately ready to start treatment, it is getting to share a little part of their day, and maybe it's just having a snack with us in the lobby and recognizing that this is a human being in front of us. And that, for me, being continued over time longitudinally, and then seeing people who may be ready to engage in treatment is a huge success. And that may not be everyone's story, but I think in my mind, an OPC is another chance for people to engage repeatedly with medical assistance, and if they want it, it's there to support them.
Thank you. And when we talk about stigma, the stigma is actually the self-stigma. And then so you use the term non-judgmental interactions. Mm-hmm. Can you go a little deeper into this? Because that's important, and perhaps people listening, myself included, we can do better.
Yeah, I think there is self-stigma, but I also think our medical system is an incredibly uninviting place for folks who are using drugs. And I think that that is often reflected by people who will wait until the very last minute, until they're deeply sick, to receive medical care. And that should never be the case. We should not have folks ending up in our ERs with endocarditis and septic. We should have folks who are accessing the medical system regularly and in a way that makes them feel welcomed, rather than they need to stay away until there's no other choice.
Yes. Okay. Thank you so much for your testimony. I appreciate you being here in person. Thank you.
Thank you.
Next person on our list is Laura Cordiera. Do not see her going once, going twice, and goes to the next person, Taylor Adelman.
Sorry, Taylor said that he was removed from Zoom by the host and can't rejoin. I don't know if that's something they can.
Okay, so we'll pass this on. So Taylor is trying to join in. Can you get Taylor on while we move to Laura Pryor, who is also not here? Is it okay if we go to Joyce Rowe? Joyce, you're on. Welcome.
Thank you. Good evening, everybody, members of the Public Health Committee. I'm grateful to be here. I'm Joyce Rio, and I represent the Connecticut Occupational Therapy Association. To supplement our written testimony, I am here to support HB 5169 to establish an alert system within the Connecticut's Health Information Exchange. As a birth to 3 provider, I've delivered care in the most intimate setting possible, the family home. Community-based practitioners often work alone without critical information about the setting we are entering. In those moments, information can be the difference between a well-planned visit and one that must be shortened, delayed, or unfortunately discontinued. So here's what it looks like in practice. I once worked in a neighborhood during a spike in local violence. To ensure that I could actually get services to the child, I had to develop a DIY alert system. I'd call the mother before I arrived to assure it was okay for an unknown person to enter the block. That mother was just so committed to her child's therapy that she would meet me at my car with a bat in hand to escort me inside. In another instance, after making a necessary DCF referral for unexplained injuries to a child, I was told by a parent, "Don't return or you will be faced with a gun." I've also been in homes where a family member's behavior was just so unsettling that it compromised the therapeutic focus of the session. In every one of these cases, I was lucky. I had agency support, but luck is not a professional standard and should not be. To ensure this bill achieves its intent, we respectfully request two clarifications. Please explicitly recognize occupational therapists and occupational therapy assistants as healthcare providers within the statute, so we may access and contribute to the health information exchange. And then broaden the criteria beyond the patient's history alone. As my examples demonstrate, risk often stems from household members or environmental factors, and the alert system should reflect that reality. HB 5169 is really all about informed planning. As we expand community-based care, we must be proactive. Providers need a system that allows us to learn from one another so care is never compromised by a lack of information. So thank you. And, I just want to say it feels as though our request kind of pales in comparison to some of the weightier topics discussed today. And I just want to express gratitude to the Public Health Committee's compassion, thoughtful reflection, and the space that has been provided today to highlight the needs of Connecticut. So thank you so much.
Thank you so much, Ms. Rio, for your pronunciation. Sorry I mispronounced it. There are two ways to pronounce it. I wasn't lucky with my first attempt.
It's
But
quite all right.
I think your point is well taken, and we will look at adding occupational therapists and occupational therapy assistant to the process. And I think to highlight what you just said, we had a public conversation about a year or so ago, or 2 years ago, and a police officer came. And the police officer said that there are parts of our state that the police have a protocol that no police officer goes there alone. And late in the evening, we have visiting nurses and occupational therapists and other people going during the day and in the evening, coming out of some of these areas where the police have a protocol never to go alone. And so that puts you in harm's way at times, and it's important to look at the comprehensive. We as a Public Health Committee have some laws we have passed, and thanks to some of our colleagues, we are working to improve them further. So thank you.
Thank you.
I see no questions or comments, and we'll move to our next person on our list, which is Christian Damiana. Okay, and Kathy Flaherty, I see you. Welcome. Thank you for your patience, and thank you for being here.
Thank you, Senator Anwar and members of the Public Health Committee. My name is Kathy Flaherty. I live in Newington, work in Middletown as the Executive Director of the Connecticut Legal Rights Project, and I'm here to offer comments on two bills tonight. First is Senate Bill 192, the Act Concerning Patient Protections and Standards of Care at CVH. I know this bill was raised last year, testified about our concerns about it last year, and those concerns have not changed. I believe that the bill as proposed would require separation of people who are being evaluated, which is, in terms of the language, it sounds like they actually have to be separated by their biological sex at all times. And people who receive services from DEMAS are entitled to humane and dignified treatment, which includes respect for their gender identity. Gender identity is a protected class under state law, and DEMAS instituted a policy respecting the rights of transgender persons in compliance with those state civil rights protections. And I think this bill, as written, would represent a step backwards from acknowledging the humanity and dignity of all people. And we, in our years of advocacy at CLRP, we've rarely received complaints about mixed gender units, and a lot of the treatment that goes on in terms of groups and things like that, separating people out based solely on biological sex, may not lead to the best clinical outcomes or the best outcomes for people, because having to learn to deal with people, with all people. So I'd encourage the committee to take no further action on the bill. I also wanted to relay some concerns about House Bill 5169, the alert system. I think the bill has a very important purpose. I think protecting the safety of healthcare workers is a goal that we all have. But I think we have to balance that against patient protections and privacy, and I'm really concerned about the bill potentially presenting a problem for people with mental health conditions, especially because it doesn't have real specific definitions of what patient violence and combative behavior is. And there's a lot of people with mental health conditions who, due to their disability, exhibit behaviors that by some people would be labeled as combative when they're really just having a trauma response, or they're perhaps in crisis. And my concern is not only might it discourage people from seeking emergency care if they know that there's going to be this permanent label placed in their record, but how will it impact future care and the ability to get it? And I know I did hear when I was in the room earlier, there was statements made that nobody wants to deny anybody care, but perhaps it needs to be explicit in the bill that having an alert in the system cannot serve as a basis for denial of care. What it should deal with is, like, how do you safety plan for that? How do you make sure people stay safe but not deny people care? The other concern is that it doesn't seem to have any time limit on the alert, and a behavior that somebody might have exhibited when they were in crisis, if they have been engaged in treatment and that's resolved, but that alert is still sitting on their system, people are actually judging people based on bad information. So there should be a couple of things. One, some way for people to deal with perhaps incorrect information that's in that alert system, and two, perhaps some expiration date on those alerts, because they should not follow people indefinitely. So I think also.
Excuse me, Ms. Flaherty, but you've reached your 3 minutes. Thank you.
I was pretty much done.
You are good. I
Yeah.
have a question, and that'll probably give you an opportunity.
Okay.
On your first point, Senate Bill 192, I think that's the bill is triggered based on a situation that developed. There's a small unit. Men and women are in the same area. There are challenges, mental health challenges in the community that we're dealing with over there. There was a situation where one of the female had been traumatized and attacked by a male who was in the same unit and did not help the situation at all.
Right.
So that was the reason why there was a request made that, look, we can do better. And then this really harmed the female who was traumatized, and the trauma worsened because the perpetrator of the trauma was right in the same area, walking distance from her. And then we said maybe we should have the separation from the two areas. So that was it. It was not about their gender issue as much as it was about the protection based on some of those aspects. So how would you feel if the language was modified to be a little bit more inclusive but at the same time protective?
I think the challenge with it, though, is that how you would actually do that, because if you were going to I think it's one thing if the hospital, and I think I actually put this in my testimony, if the hospital were to decide to let's create a unit that's just for women only, particularly trauma-informed, focused on that, and people had the right to choose to want to go to that unit because they felt that that's where they could recover best. That's absolutely something we'd support, because we have clients who very much, might find something like that helpful. I just think it coming from the legislature telling the hospital, this is what you must do, becomes problematic, and potentially disrupts people who are already getting care from a treatment team that they've established a therapeutic alliance with, and might perhaps have to move units if there was some requirement that they could only be served on single-sex units.
Okay, so, and then I know Senator Summers is not here.
Right.
She was the one who actually put in this request, but I'm on my own when I was interacting with the CVH system, so I learned about this case too.
Mhm.
And then she learned about it as well. And we're trying to address that issue, but perhaps there's another way to do it, to your point, and we can start to have more conversation. But your testimony is helpful to look at things from another angle and then make sure we are not doing something unintentionally that goes against some of the other responsibilities, collective responsibilities we have. On the second bill that you've talked about, I think it's a worthy suggestion that you have made, and maybe you can modify the language. So thank you for your testimony.
And you're very welcome, and happy to provide any additional input I can if it's helpful.
Representative Carpino has a question.
Thank you, chairs. It's nice to see you.
Nice to see you too.
Not to put you on the spot, so if you have an answer or a suggestion to the question that was asked, either now or at a more reasonable hour on another day, I would love your perspective of how we can keep folks safe. You know that facility pretty well. You've been a huge asset over the years as we've really tried to do much better at that facility. So if you have any suggestions as to how we keep everybody receiving treatment safe, I understand nobody wants to be heavy-handed in legislation, but I'd love to sit and chat with you about how maybe we can look at other alternatives.
Would love to continue that discussion offline.
Thank you.
You're welcome.
Thank you. Thank you for waiting all this time and in testifying. Thank you for being a strong voice for the people who are not in this room.
Thank you. Appreciate
Thank
it.
you. All right, moving on to the next person on our list, which is Mark Jenkins. I saw him, yeah. Mark, if he comes back, he's been here a few times, and he's probably around here. So we'll see if he comes back, and we can look at that. And next person is James Sanders. Going once, going twice. Mr. Sanders is not here. Then we have Peter Brown, and then we will actually have two people join together, and they're going to share their time. Peter Brown and Jeffrey Tomczyk. Thank you so much. If one takes 2 minutes and the other take one, I don't know how it's going to work out. Welcome. Thank you for your patience with us, and thank you for your willingness to share the time.
No, thank you, Mr. Chairman, and thank you, Madam Chairwoman, ranking members, and all the distinguished members of the Public Health Committee. My name is Peter Brown. I'm the president of the Uniformed Professional Firefighters Association. Is that me causing the echo there? Sorry about that. Which represents 4,000 career firefighters across our state. I'm also here with my colleague, Jeffrey Tomczyk, who serves as the legislative director of our organization. I'm here to talk for a couple minutes about Senate Bill 93. As emergency responders and healthcare workers ourselves, we understand just how important it is to expand healthcare to our communities, especially our rural communities and underserved communities. If accessing the compact, the EMS replica compact, does open up the state to access rural healthcare funds that are currently not available, that's something we would obviously take very seriously. We would never want to stand in the way of expanding healthcare, especially for those that need it most. We do have some concerns as the bill is written about potential unintended consequences to our Connecticut workforce. Specifically, the language allowing transient multi-state privilege to practice raises some questions about our workforce impact. Connecticut's fire-based EMS system rely heavily on highly trained, locally accountable firefighters who provide integrated emergency medical care and transport services under the care of carefully negotiated municipal staffing models. We're concerned that without guardrails, the compact could create pressure to introduce lower wage, out-of-state personnel into the system, potentially destabilizing fire-based EMS models that are working efficiently now. This is not simply just about labor, it's about system integrity. If the goal of this bill is to expand healthcare access and strengthen our emergency medical response system, we believe it can be achieved while also protecting Connecticut workers and preserving the stability of fire-based EMS. We would respectfully ask that the committee consider amendments to ensure that local control over EMS delivery remains in place, existing collective bargaining agreements are not undermined, and that Connecticut standards for staffing, training, and accountability remain strong. We stand ready to work with the governor and this committee to make sure we get it right. And with that, I'll turn it over to my colleague, Jeff.
So not to repeat anything that President Brown said, but our concerns stand, undermining our statewide workforce is very important to us. As he said, we have 4,000 members, actually over 4,700 career firefighters in the state. Almost 90% of them have some sort of EMT certification. With that workforce alone, there is approximately 24,000 certified EMS workers, EMS certified people in the state. The workforce now currently stands at 11,000. So there is a pool of candidates. Why they're not entering the workforce and we're experiencing a shortage, or the workforce is flushed with this pool of applicants is unclear to us, but it shows that we're questioning why a need to go to an outside compact for a transient workforce or ease other workers from outside the state to come in makes sense. Along the lines of, we're not really sure where the system is broken and we're not understanding what needs to be fixed about it, especially with this compact. But also, a very important fact is a diminishing standard of care. What we've developed through the state of Connecticut is a specific educational curriculum geared around EMS and making sure that our first responders are prepared to the highest level with our geography, our demographics, and our specialty hospitals that can handle the specific cases. And it's important that our institutional knowledge that was built in Connecticut maintains that level through having a consistent in-state workforce.
Excuse me, Mr. Tomczyk, but you've reached your 3 minutes. Thank you.
Thank you. Just in conclusion,
I have a question. So, and perhaps that's going to give you the opportunity to answer my question. So the challenge with Connecticut is we have 169 towns. Every town has a different formula. And there's a mix and match of things. There are career EMTs and paramedics, and then there are fire department collaborative groups as well. So you represent the model which represents a fair amount of towns, but not all the towns. And then on top of that, to make it confusing, the ambulance services are also mix and match between hospitals owning them, the towns owning them, and insurance industry and others owning them as well. So it's a sort of a hodgepodge in some respects. In our previous conversations, there was this whole issue that the rural part of our state does not have enough ambulance service and the response time is not good enough. And then there have been ambulance services that have not been as effective. And there are a variety of reasons for that, but that was the end product that we are seeing, and there was mutual aid that was being requested. So in parts of our state, if somebody had a heart problem, they will ask mutual aid and there would be one ambulance in the next town. Sometimes it takes 30 minutes, 40 minutes before a chest pain is responded to. And then when we started to look at the depth of what was going on, the results were that we don't have the workforce, but we also don't have enough ambulance services. And as we go further into our state, the way the makeup on the rural part of our state is, that it's the homes are far away. So even if you're in the center of the town, it'll take you 15 minutes to get to a place. So this bill that the governor has proposed is trying to address the workforce issue, which will help us be ready for a robust EMS system in some of those areas. I think that's the rationale, but I'm sensing that you were never part of that conversation when this was proposed. So we will take your testimony back, but if you want to reflect on what I've just said and see if you have thoughts.
I certainly would. I appreciate those comments, and I want to make it clear to the committee and all of those who read our testimony, it is certainly not our intention to impede the ability to expand services across the state of Connecticut. Patient care is our highest priority, and we recognize the same stats that you presented to us today. regarding gaps in coverage, I guess we could call it. But what we're failing to understand, and maybe it is because we didn't have maybe the right stakeholders weren't in the room to have the compact conversation. But where we're missing a piece of it is how to understand how a compact is going to improve that. I think that we have had some models, as President Brown had expressed, developing and expanding on a fire-based EMS model. Yes, there are some very large rural areas of the state. We have some suggestions or maybe some long-term strategies on how to facilitate accomplishing a broader response district for certain areas. But when we look at how we're operating currently, with all of the systems that you had explained, with the private, for-profit, nonprofit, hospital-based, fire-based, it is a hodgepodge. In fact, to complicate things, like myself that lives in the city of Danbury, and works in the city of Danbury, President Brown, and Norwalk and Stamford, and then going on to Norwich on the east side of the state, there is already a system in place for New York or Rhode Island EMS systems to operate across state lines in a manner that they're abiding by the medical control issues for whichever facility they need to go to or whichever medical region they're going to. And it's in our opinion, of course, open to further education on the subject matter, but it's in our opinion that there are alternative ways rather than entering into a compact with several other states that's forcing more of a one-size-fits-all for EMS when we're identifying that Connecticut is a very unique situation and we need to handle it within the state with the systems that we have in place.
I'll make a comment and then I'll have my co-chair ask a question or a comment. Your being here helps out. This raises the concern, and then what we can do through this conversation is probably have you be part of the stakeholder conversation to make sure that the intentions are clear and there is way of, if there's an opportunity to modify some things, we can actually start to look at that. But I'm going to give it to my co-chair.
Thank you. Thank you to both of you for staying here today for so long and for being here to have this conversation. Jeff, can you share, you shared something about 11,000 people in a pool of candidates. Can you just go back to that and repeat that? Because I missed the full detail there.
Sure. It's my understanding that the recent statistics from OEMS is that there's approximately 24,000 certified EMS certifications in the state currently, or for the calendar year of 2025. And the workforce through the ambulance services employed within the state is approximately 11,000, I believe my comment says. Let me just refer to my notes, my testimony, so I have that right. Yes, approximately 11,000.
Okay, thank you for repeating that. And I will just say we've been in conversation just for the benefit of the committee. I've also been in conversation with the governor's office. I have provided them your contact information. We will make sure that everyone is having this conversation together so that we can address any concerns and assure that we are meeting everyone's needs and meeting the needs of the people we serve. Thank you. Thank you, Senator.
Thank you very much. We appreciate the time.
I apologize. I just want to add one thing briefly. We did have a conversation about specifically, and another speaker had brought that up in her testimony, specifically about the veteran situation and how to facilitate a much smoother transition from somebody leaving the military service and coming to the state as a certified EMT or EMS worker. Through my research, I've recognized that the state has not fully achieved the National Registry of EMT certification process for the state, but it is moving into the steps of that direction. That is something that the military is offering to all of their personnel that enter into that certification class. If there was, this is one example of how there's a redundancy in a system like a compact and the National Registry of EMTs that already exists today, where a military member currently comes into the state with the National Registry certification, they can go to OEMS and get the reciprocity to be certified. There is a nuance apparently for the family member if they're in a workforce where they need to, working on transfer, which we discussed. But for the veteran itself, there is a smooth transition.
Good, thank you for your comments.
Thank you very much for the opportunity. I hope you enjoy the rest of your evening.
Yes. With that, we move to the, oh, sorry, please don't go away yet. Representative Kennedy, I'm sorry I missed you.
Sorry. I know you've been here all day. Thank you both for being here. Just for further clarification, when you mentioned the registry, when you become an EMT in the state of Connecticut, does not everyone become registered with the, isn't everyone into the national registry? Am I
That's a
correct
good
on that?
question. So the way the system is set up currently, when you take a class, the curriculum is based off of the National Registry of EMTs. That first certification process, when you enter, you complete your testing process, you do receive that initial certification as national registered. The state currently does not require you to maintain your national certification, so you can pay extra money and submit your testing standards to the National Registry to maintain it, or you can just complete the required steps for the state to maintain that certification.
Thank you, I appreciate that. It's really important clarification. And also, you mentioned the number of EMTs in the state, and is that a breakdown? Because I know you can be an EMT, just an EMT, but you can be an EMT IV, I think it is, or EMT tech, because some of those EMTs have more, I don't want to say knowledge, but they can run an IV line or something, but a regular EMT doesn't do that, if I said that correctly. Is that not true?
That's correct. So theoretically, there's 4 particular rankings. MRT, which is a very basic level of
Right.
providing first aid. But in the certification process, you have the EMT, and which was the EMTI, but now it is called the AEMT, Advanced EMT, and then the licensure for the EMTP, which is the paramedics level.
And that was my next clarification on the AMET. It's been a little while since I've been involved with the fire service, so thank you for that clarification. And I just want to point out the amount of time that someone goes through to take that EMT certification. I know that you can do it in less time than it's several months, is it not? Like 8 to 16 weeks, something like that?
It is. I apologize. I should have the amount of hours that you are supposed to
I probably
take.
should know it too, since my son is an EMT, but.
But it certainly has increased with the advances of emergency medicine, but also the cost has increased significantly as well.
It has, and just because we talked about this being a hodgepodge, and we're talking about EMTs, and then paramedics are a totally different animal, because that's even more training, more classroom time, is that correct?
Yes, absolutely, with clinical time added as well. So now you're
Appreciate
talking
that.
about a specific component. And the program itself, I'm not an expert on this, but the program itself had fluctuated from a sponsor hospital-based program to a 2-year associate's degree program, and now I believe it's somewhere in between.
That had changed, correct. And then the last thing I want to say, thank you, Mr. Chairman, is, I don't think sometimes people realize there's a really big difference between a career firefighter and a volunteer firefighter, and that's not to dismiss anything, but career firefighters go through, well, let me backtrack that. Volunteers do a lot of training as well, but on a career firefighter, they train on a regular basis. Is that not correct? Almost on a daily basis to refresh?
So, yes, absolutely.
I
But
try to
think
say that carefully because I'm not trying to slight a volunteer, but the training is slightly different. And I think that's important as we move forward with this process, that's why your input is so valuable in this bill.
Right, and I think that's what we're really trying to bring to the table is an understanding that, that while conceptually we look at programs like the Compact or the National Registry or certification standards and curriculum in a specific emergency medicine like microcosm, right? But realistically, there's a significant amount of population that is in the day-to-day operations. And oftentimes, what really works well for doctors and medical control to understand, the day-to-day operations inside a controlled environment like a hospital, oftentimes is completely different outside in the field when you're trying to operate on mutual aid positions and doing paramedic intercepts and really trying to coordinate with Lifestar and things of that nature. So
Exactly.
it becomes a very complex issue.
I appreciate it. Thanks for expanding on all that. It's always difficult. I represent a town that has a career and a town that's strictly volunteer, and I get all that about response times and everything. So I think we have a lot to work out in this bill, and I think that having you both at the table is very, very important. So thank you for your time, and thank you for waiting all day. Thank you, Mr. Chairman.
Thank you so much. Seeing no other questions, we'll move on to the next person on the list. But before we move on to Mr. Taylor Adelman, who is number 45 online, I just want to take a moment to recognize one of our fellow legislators who is quietly sitting here listening to each and every one of us, and it's his birthday. It's Representative Biggins. Happy birthday. And I have inside information that the family is waiting with a cake at home, and he's rather listening to everybody, and we said, you can do this. Technology allows you to do this from home. You can multitask. It does do that. So. I'd rather spend my time with all of you. Oh. Whoa, I take that back. Hold on. Yes. Rather is a strong word. Hold on. I appreciate my time with all of you. Well said. We'll they've taken that video and then put that. So, Representative Biggins, it's okay to go home and listen to us online. We look better on the screen. Some of us do. All right, with that, speaking of looking good on the screen, Taylor Adelman, you're on.
Wow, what an intro. Thank you so much. Oh my gosh, I love that. So dear members of the Public Health Committee, I'm not sure how much more here I'm going to add, how much more than my brilliant colleagues have already attested to. But anyway, with that, I'll use my time. So I'm Taylor Edelman. I'm here in support of SB 195. I live in Brookfield. I'm a dad, I'm a husband, I'm a lifelong resident of the state. I'm here as just a regular human being, but I've worked in harm reduction for nearly a decade. I worked at a syringe services program. I was in a mobile unit, did case management, help people use more safely, educate harm reduction staff, which I still do from time to time, and so much more, right? And like so many people here, even very recently, I've lost coworkers, people who do this work day in and day out, and they are no longer here, right? I've lost friends, I've lost family members to overdose, tons and tons of people. Even 10 years ago, I lost a friend who cycled through treatment for years. She completed a program, used soon after her release, and died alone. I lost somebody, a really close colleague, in the middle of working on a resource that was teaching people how to use drugs more safely. So I would hope to honor and really speak for those who can't, not to speak over them, but to amplify their lives and to, properly honor their memory. And I also speak as someone who has visited the 2 overdose prevention centers in New York City, which is like 70 miles from my house, mind you. I've walked through the doors, I've talked with staff, I see what happens inside. And you want to know the first thing that they handed me? A snack, which I love, something to drink. They had no idea that I was there to train their staff first. Most people on any given day, they're there for food, for laundry, for vaccinations, counseling, medications for opioid use disorder, housing referrals and help, right? The supervised consumption room or the site itself is such a small part of it, but people love to focus on it. The other thing I will say, because I'm a big fan of harm reduction history, and I find so fascinating that youth was brought up, is that, youth not only represent a very small fraction of the overdose deaths, not to diminish anything in Connecticut, and that number is decreasing, but people don't realize that one of the first OPCs that was actually opened by youth, and it was youth-led, was in the 70s in Amsterdam, and that was to curb hepatitis B rates. And people don't know that. They always think that it's, Switzerland banned in the 80s. That was the first OPC, but I love to just kind of put that little nugget in there. So I know my time is coming to a close, but happy to answer any questions, and thanks so much for your time.
Thank you so much, Taylor, for your testimony, and thank you for being here and being with us late this evening. Your testimony is very important, and I think you added more value as well. So I wanted to thank you for that.
Thank you. Appreciate it.
So seeing no other questions or comments, we move to the next person on our list, which is Jennifer Chudakiewicz. Going once, twice, and then we are going to go to online, Katie Rudek. Ms. Rudek, you're on. Welcome.
Thank you.
Go ahead.
Good evening, chairpersons and members of the committee. My name is Katie Rudek. I'm a licensed mental health professional and serve as Vice President of Clinical Integration at Kooth Digital Health. Prior to joining Kooth, I spent more than a decade providing therapeutic services to youth and young adults in community mental health settings, where I saw firsthand how difficult it can be for youth to access support, particularly in communities where services are limited and stigma remains high. Thank you for the opportunity to speak in support of Senate Bill 93 and for your leadership in advancing rural health access across Connecticut. SB 93 represents a significant opportunity. Connecticut's Rural Health Transformation Program is designed to strengthen access, workforce capacity, and technology-enabled care in rural communities. Behavioral health must be part of that transformation. Rural communities face unique challenges. Provider shortages are more pronounced. Transportation barriers are real. Wait lists are longer. Youth often have fewer confidential options for support, and stigma can be heightened in smaller communities where privacy feels limited. These structural realities make prevention and technology-enabled access especially important. If rural health transformation focuses only on expanding in-person treatment capacity, we will continue to struggle against workforce shortages and escalating demand. But if transformation includes prevention and accessible digital supports, we can reduce downstream pressure while expanding reach. Saluna by Kooth is an example of the kind of intervention that fits squarely within the goals of rural health transformation. Saluna is a secure, evidence-informed digital behavioral health platform that provides youth with immediate access to self-guided tools, pre-moderated peer support, and licensed professional support without requiring a diagnosis, referral, or travel. For rural youth, this matters. It eliminates transportation barriers. It offers privacy in communities where stigma may prevent in-person help seeking. It extends access beyond traditional office hours, and it engages young people earlier before symptoms escalate into crisis. For more than 20 years in the United Kingdom and now across multiple US states, this model has demonstrated statistically significant improvements in anxiety and depression symptoms while engaging youth at earlier stages of need. Importantly, many young people who use the platform report that it was their first time accessing mental health support. That is prevention, that is access expansion, and that is system protection. SB 93 creates the framework for Connecticut to reimagine rural health delivery. We respectfully encourage the committee to ensure that prevention-level technology-enabled behavioral health services are included as eligible investments within the rural health transformation strategy. Thank you for your leadership and your commitment to rural communities across the state.
Thank you so much, Ms. Rudek, for your testimony, and thank you for sharing the background of your organization. You have spoken to us before, so our committee is aware of the work that you do. Therefore, that's why we are not seeing any questions or comments. Thank you so much.
Thank you.
And we'll move to the next person on our list, which is Ralph Baker. You are remote. Mr. Baker, you are on. Welcome.
Hello, how are you? Thank you for having me today.
We cannot see you. If you want to turn your camera on, Mr. Baker, that would be great.
I don't know how to do that.
Okay, don't worry then. We want to listen to you then.
There we go.
Oh,
there we go.
Love it.
Thank you for your time, and I appreciate the senator to cheer on his birthday. That's a level of commitment that's admirable. I'm here to speak for a population that's not able to speak for themselves. There was a young lady on earlier that said some statements about people that she's talked to in the community that were active drug users, and they announced themselves as anonymous. That shows us the shame they're feeling already. The OPC is a very important place to make connection. The opposite of addiction is connection. And as a person in long-term recovery, the last time I got high was September 2nd, 1988. And I sit before you a miracle based on the recovery that I got through somebody telling me that they loved me and that I was worth it. And these people just don't hear this enough. And the folks at these harm reduction centers and all that, this is that they spread the love. They help people feel connected. They bring a sense of self to these people that have been lost. There was a committee member that asked a question about how can we justify allowing people to use illegal drugs when we are not going to prosecute a burglar that breaks into my home. Well, the burglar doesn't have something inside of him that's screaming. The withdrawal and the state of panic that they're in makes them do the things that they do, and to allow them to do that in a safe place where they feel loved and expected rather than looked down upon and shamed keeps them alive until they can make a better decision. I was a member of an opiate task force for a while back, about 4 years ago. I got working with the local PD. We went to a park. We got called to a park on an overdose. There was two youths there under 25 years old, a male and a female, sitting by a fire next to a tent. Both of them overdosed and had unfortunately passed. This is going on out there all the time. I understand you're a driven, a data-driven entity, and I understand why. However, at the expense of that data, lives are being lost every day, and these OPCs can help so much to deter that. And if we save just one life, that justifies the data that we're talking about. I'm in long-term recovery, and at 30 years old, I had a GED, and about a year ago, I graduated with my master's degree in addiction counseling, and I now serve the population that I'm a part of through liberation programs, and it's an honor to do that. We need to get together as a society and help these people help themselves, because there's a lot of people out there with brilliance and so much. They could give so much more if they just get. Somebody told me they loved me and they didn't want me to die. That was 37 and a half years ago. And I sit here, a product of that statement, 37 and a half years later, and I yield the time. Thank you.
Thank you so much for your testimony. Your last part was very powerful, very powerful. And then that speaks about the connection that everybody talks about, that love saves lives, and you're an example. And then you're giving back by speaking at this time. So I wanted to thank you. And thanks for staying with us throughout this day. Thank you, Mr. Baker. Seeing no questions or comments, we will move to the next person on the list who is physically here, Sarah Piatti. Welcome. Thanks for being with us all day today. I said hello to you in the morning, and here we are. Thank you.
Is this the right one? Okay. Good evening. My name is Sarah Piatti. I work at Connecticut Harm Reduction Alliance, and I'm one of the program directors there. I work with the unhoused population, but I'm also a woman in recovery from the disease of addiction. And up until about 2018, if anyone had brought up Bill 195, I probably would not have supported it, because when I first came into this field, working in the field, I worked during the pandemic with pregnant women and moms, and I went into the field thinking I was gonna, I have a good life now that I found my own recovery, right? Got my kids back, everything that I wanted. And I was gonna help everybody else do that. That was the most unrealistic thought I've ever had in my life, because I can't want somebody else's recovery. I could only want mine, and meet them where they're at and support them. And with that being said, during the pandemic, after losing several friends, several participants that I worked with, watching children lose their mothers to an overdose, my whole mentality changed. Then it became, how do we keep people alive? And for me, at first, it was obviously handing out Narcan and fentanyl strips. But I truly believe these centers will keep people alive. Because I used to use alone. Towards the end of my addiction, I used alone quite a bit. But the difference between then and now is fentanyl wasn't around. Xylazine wasn't around and all the drugs. It's
Right.
no longer a choice
Why is
for
this- you
people
can't
to
hear it.
get high or not get high.
Most people do not
Now,
support that
live
because
or die. So, did I hit my 3 minutes? I
No, no,
did.
no, you're good, good.
Okay. So I am fully in support of SB 195, and I truly believe that somebody asked about, maybe how do we just stop addiction? I wish we could stop addiction, because even though I'm in recovery, every single day I have to wake up and make a decision every day that I'm not going to use. And there's many people who live that way. So if we can't stop addiction, how do we keep people alive? Bottom line, how do we keep people alive? That's all I really have.
Sarah, thank you for your testimony. It's powerful. It's still reverberating. I have my co-chair who wants to make a comment, and then I wanted to make a comment as well.
Very quickly, because the night is wearing on, but thank you for what you said. I can't want somebody else's recovery. I can only want mine. And that is really the heart of what this conversation is about in so many ways for me. Even though, as I was sharing earlier, as loved ones, we want recovery for the people we love. We want it so badly, but it's not for ours. It's not for us. And I know may seem like a very silly analogy, and forgive me if it's offensive to anyone, but I was thinking about potty training my children. And there is no way to force a child to go to the bathroom. They have to figure that out for themselves. And that is not to minimize it's probably a terrible analogy, but I think what you're saying is extremely powerful and really gets at the heart of this issue, because I think what we've heard here from so many of us over and over is we wish for recovery for everyone. That's what we wish for. But it's not for us to want, it's for the people who are struggling through that journey. It's for us to walk with them. Thank you.
The work that you're doing, and we talked about the homeless population increase that we are seeing, and the homeless population which has a lot of substance use issues is the segment that is increasing in our state. I would love to talk to you. If you have one line, you can say it right now, and then I'll follow up with you later, because the night is getting one liner that's going to solve all the problems.
That's gonna solve all the problem? Yeah, I got nothing. I got nothing on that. But what will assist in keeping people alive is this pilot program for the OPCs.
Thank you. So, seeing no other questions, you are we are very thankful for you being here. Don't leave. I wanted to give you my card, and then we'll talk about the homeless population and the substance, because we are failing on that end. Next person is Rebecca Allen, who is not here, and she was here for a long time. We are sorry. Next is Mr. John Lally. Thank you so much, Mr. Lally, for being here, and thank you for the work you do.
Good evening, co-chairs Anwar and McCarthy Bay and distinguished members of the committee. My name is John Lally. I am a psychiatric nurse practitioner who's worked in mental health and addiction for almost 40 years, and now president of a nonprofit helping people with advocacy, education, and support. I did submit a written testimony, which you can all see, and in that there's some statistics for people who like data. I've heard that today. And if it was all about data, this would be done, because the data is all positive. I haven't seen any negative data yet worldwide. But I know it's more than that, and I think there's three things I want to speak about tonight. One has to do with treatment, one has to do with stigma, and then there's I understand that there's the legal question as well for federal law. My son Timothy died just over 10 years ago, alone in the basement of his drug dealer. By the time someone got to him, Narcan was not effective. He was in cardiac arrest. He was defibrillated. He was intubated. He was brought to Hartford Hospital, brain dead. He was alone when he went down. He had no choice that day. And my wife and I had to make the horrible decision, 36 hours later, to let him go, take him off the ventilator. Imagine that, having to do that with your own son. Let him go. Enough is enough. He's not coming back. My wife and I are medical people. We knew it was getting worse. It's not coming back. But the three things I want to focus on, again, the law, the treatment, and stigma, is that as far as treatment goes, I've been listening to a lot of the talk today, and I know one of the things people are not happy about is that people are not required to get treatment in OPCs. Well, it's not that easy. It's as crazy as the just say no idea. Just get treatment. It's not that easy. You can't just get treatment when on demand. There's a lot of things. Being unhoused gets in the way. Finances gets in the way. Availability of actually evidence-based treatment is not always available. And the treatment that happens, if we know, especially what we know about opiate use, there is relapse that happens all the time. That's a normal part of that. My son wanted treatment. He went into treatment. He went into rehabs. He went into inpatient outpatient programs. He wanted treatment, but it didn't work. And the thing that got him into drug use was his mental health issues. There was inadequate treatment too. He had depression, he had anxiety and panic attacks so severe he had trouble getting out of bed. And we tried therapists, we tried medications. Nothing seemed to really help for him. If the meds helped a little bit, they made him sick, and he didn't want to take them. So there was inadequate treatment for this guy to begin with. One day someone gave him a Percocet. He told me, "Dad, man, I felt so calm. It was like a warm blanket on me. All of a sudden, wait a minute, I can handle things now. I can do this." Well, this is a guy who tried all different kind of treatment already. But as we know what happens with addiction, one pill turns to 2 pills, turns to 10 pills, and then the pills dry up, and then he's on the street and he's using heroin. And he was injecting heroin, even though he'd been through treatment a few times. And when he was in treatment, he'd say, "Dad, I like this. My head feels so clear. This feels so good. I'm going to do it this time."
Excuse me, Mr. Lally, but your 3 minutes are up.
Sorry.
Mr. Lally, no, please continue.
This
Finish it.
this is the reality of treatment here. It's not just go get treatment and the problem's over with. And then the next thing I want to talk about is stigma, okay? That's part of the reason people don't get good treatment too. I know of a recovery coach who works in an emergency room who went in to see someone who had overdosed for the second or third time, and they were met by a physician who said, "Why are you bothering? This person's going to come back tomorrow, probably dead. Don't you have better things to do with your time?" Well, this is in the healthcare system. I hope we're getting better here in Connecticut, but these things happen. And when if that person had overheard that physician, you think he's coming back? You think he now has any confidence in treatment? So where's he going to go? And like my son who died alone, if there was an OPC, I neglected to say I'm certainly supporting 195, if you couldn't tell that, but it's going to save lives. And then what happens next? Maybe people will get abstinent, maybe not. But dead people don't get better. And I lost my son, and I want people to think about I can't imagine you're all caring people, you dedicate your lives to the people of Connecticut here. I can't imagine if any one of you was in this position where your son or your daughter or your loved one was using, would you rather them use alone, or would you rather there be an OPC? Think of that personal choice. And if it's good enough for you, it's good enough for the people of Connecticut. I got to see that. And lastly, I'll say about the legal thing, I understand there are federal laws that seem to put up an obstacle, but there are states or other people who are bravely saying, we're going to put our lives first. In our state, we're going to put our lives first. Connecticut made marijuana legal, right? Recreational marijuana. That's not legal federally, but we decided there are reasons to do it. Now, maybe that had a lot to do with money or taxes. I don't know. But we're talking about lives. Lives are more important than money or tax money, income, and I'll leave you with that.
Thank you so much, Mr. Lally, for your testimony. And your organization is doing some national level work on the stigma part. You're like, I don't know many other organizations who are fighting the stigma as much as you are. Would you be able to say a few words on Today I Matter?
Well, Today I Matter, the T named after my son Tim. I got his button here, TIM, to keep him next to my heart all the time. You know, that's why I'm doing this now. And that's our main mission, is to really work hard to reduce the shame and the stigma. Someone mentioned self-stigma too, right? Where people feel ashamed and embarrassed to go for help. You know, the day before my son died, he was actually living in a sober house, but he was thrown out because he was, you know, he had used an opiate. And he was too ashamed to come home. And my wife and I would have let him come. He never lived on his own. He was 29 years old. That's how debilitated he was. We would have let him come home. But it was the stigma that got in his way. He was ashamed and embarrassed. So what we do is try to educate people. First of all, talk about the problem. But I think if you talk about it in a compassionate way and think about your own lives, the people you love, how you want them to be treated, you know, do unto others as you want others to do unto you, then there's no such thing as stigma, right? But also, it helps for people to understand the science behind addiction. The brain is actually changed. People who are under opioid addiction are not thinking clearly. We see that and we blame them for it. Their judgment, their impulse control is impaired. Their reasoning is impaired. So when we say, why aren't they making better choices? That's part of the reason. So the more we can educate people about the science, about the compassion, about the reality of what happens to our loved ones every day, we're hoping. I'm also doing a lot of work with Hartford Hospital, start working with ER staff and doctors there to do trainings about stigma, to think about the words they use, the attitudes they use when they talk about people that come into their healthcare facility. Because the words we use when we call someone an addict, a junkie, a frequent flyer in the ER, guess what? They're not coming back. When they hear that, then this is not a place that wants me. So that's the kind of thing that we do.
Thank you so much. Would you just take a few sentences? Tell me about the music things that Tim used to play.
Well, Tim loved music. We both loved music. We grew up on music. And he got to play professional one night at the Webster Theater in Hartford. He thought he was a rock star. He was some buddies in him. He was up on stage playing his bass guitar. I videotaped the whole thing. I look at that every once in a while. That was one of the few happy days he had in his life. Music brought that to him. So one of the things we do with Today I Matter is we give out scholarships for music and art, because those are things that can be healing for people and motivating for people. And we want to spread some of Tim's love in that way.
Thank you for your testimony. Who's this beautiful woman that came with you?
This is my wife. This is Tim's mom.
Okay. Thank you. Thanks for being here, both of you. I appreciate you.
And thank you all for sticking out this whole day. I appreciate your dedication to Connecticut.
Thank you. Next person on the list is Donnie Woodyard.
Thank you so much, Mr. Chair and members of the committee. And boy, you've had quite the long day. My name is Donnie Woodyard. I am the Executive Director of the United States EMS Compact. And by way of brief background, I am a paramedic. I'm a former state EMS director in 2 states. And I have been part of the EMS Compact since the inception of it. I currently serve as the Executive Director after briefly serving as the chair of the board of the Compact. You've obviously already heard about SB 93 and the compact included in that as a federal priority. But let me first answer the question as to why is it a federal priority? The EMS Compact was initially conceptualized in 2011 under the Department of Homeland Security because it was a national security, defense, disaster planning priority for the United States. It's remained a bipartisan priority through the Obama administration, Trump, Biden, and current administration. You heard from my colleague at the Department of War speaking on that briefly today. Connecticut is ready for the compact. You use the same EMS education. You take the same licensure exam as every compact state. Your training, your education, your licensure is already aligned. Connecticut is part of 7 compacts already. EMTs and paramedics certainly deserve the same recognition and mobility as the others. I want to just briefly talk on a couple things that was brought up earlier. One is local control. The EMS Compact absolutely supports, reinforces, and encourages local control. The bill is designed that way. Under the EMS Compact, EMS personnel can only practice in Connecticut if they are affiliated with or hired by a Connecticut authorized EMS agency. It does not allow independent practice. You must meet and follow the Connecticut standards of care. You must meet and follow all the laws, protocols, and regulations of Connecticut. And you must have a Connecticut-based physician medical director. The EMS Compact encourages and requires local agencies to screen individuals and to make sure they're right for that local agency. The EMS Compact, however, closes a critical accountability issue that exists today. Right now in Connecticut, although you take the same exam as the rest of the nation for the most part, Connecticut has no way to know if a clinician in Connecticut has been disciplined or had a license revoked in any other state. That is a priority for public protection. It's actually a national issue as well. Being a state EMS director, I can speak to that point. The EMS Compact through the National EMS Coordinated Database closes that, strengthens accountability, and provides Connecticut the only access to the national system that has that information in it. EMS clinicians, I hear previously something about workforce. And, I heard a stat about half of Connecticut EMTs and paramedics, or a percentage, may not be working. That's not unique to Connecticut. We see that in many states. However, what we also see is that you probably have a few thousand people living in Connecticut that are licensed in another state. In EMS, the reality is that if there's friction, people do not go through the extra steps to get licensed. In the states that have adopted the EMS Compact, we have over 450,000 EMS clinicians working. And what we find is that communities have people embedded in those communities who are actively licensed in other states that through the EMS Compact can actually join the workforce. You remove the friction point.
Mr. Woodard, but you've reached your 3 minutes. Thank you.
Thank you. I'll close with this. The EMS Compact is a priority, a national priority. It's important for Connecticut. There's zero cost imposed on clinicians or individuals. Local protection is important. It provides more accountability, not less. And I'm happy to take any questions you may have. I know it's been a long night for everyone.
Thank you very much, Mr. Woodyard. I have a quick question for you. Were you involved in the initial conversation here in Connecticut with respect to this legislation, or is this just you're aware of it now and you're here to make sure that we have this information?
Yeah, so as I'm here to make sure you have the information. As a government official, I do not lobby. I'm not permitted to do that. I can be a technical resource. And so when local individuals brought up this bill, and furthermore, when it became part of the Rural Health Transformation Grant and states were losing money for not participating, then I certainly did get phone calls. I will note that our legislation was co-wrote by the IAFF. We very carefully considered union concerns in it. And one of our largest user groups in the nation is the union. I'm sorry if those connections have not been made well in Connecticut. Our office is ready to help answer their questions, bridge any gaps that might be there.
Thank you. That's a very helpful answer. And I think what we want to make sure here in the committee is that all of these connections are made so that we all can be speaking together and making sure that everyone has a comfort level and understanding that we're all on the same page around this. So, Mr. Woodyard, I expect that you will hear from us and hope that we can bring all the parties together to work through some of these questions and concerns. Thank you very much for your testimony today. Seeing no other questions or comments, questions actually at this point. I have lost track. Is number 62, Leah Sforza? Is Leah here? Oh, did I? I'm sorry. I'm sorry. Leah, hang on. We've got I missed 63 Trip Johnson. So Leah, if you kindly mute yourself and we'll give you a turn. Just a second. Thank you. Okay, forgive me. Mr. Johnson, come on forward. Welcome.
Thank you for having me. You know, one of the benefits of going later in the day is all of the people smarter than me have covered all of the points better than I could have. So I'm going to say thank you to the community members who came before me and who are going to come after me, as well as to the body receiving our testimonies. My name is Tripp. I'm here to testify in support of SB 195. I'm a person living in long-term recovery who, like many of us in this room, has attended too many overdose-related funerals of high school classmates, college classmates, childhood friends, colleagues, clients, and all manner of loved one. As alluded to by others, OPCs, as described in the bill, provide a bevy of social, medical, hygiene, housing, and other services, including drug checking. They are not simply sites where people get high, unlike bars, for example, which is the other form of supervised consumption that we have available to us at this time. OPCs save lives. Professionally, I have participated in the opening of 2 CARF-accredited recovery homes specializing in the treatment of co-occurring disorders, and I've overseen a number of different housing programs, including low-threshold housing for the chronically unhoused experiencing substance use and/or mental health challenges. And I am now the community drug checking technician for Connecticut Harm Reduction Alliance, which means I work directly with people who use drugs, and in particular, I analyze and report on the local drug supply in the greater Hartford area. When we identified medetomidine in the Hartford drug supply in August, which was triggered by a spike in overdoses, we were able to spread this information to the community and our partners to mitigate further risks of overdose. OPCs will, among other things, help standardize and regularize monitoring of our highly volatile drug supply, which itself will save lives. I see people every day who are using and who are at varying stages of change. The majority are living outside with co-occurring disorders. They don't have cars. They don't want to die. They want to live. Their children, their partners, their parents, their siblings, their friends, and their community members want them to live. And in their absence, all any of us have left are the memory-laden keepsakes, pictures, and rooms that have somehow become more sacred and simultaneously more profane. Over the past 3 years, roughly 3,000 of those same people have died from fatal overdoses in Connecticut per publicly available Connecticut data, which is to say nothing about the unquantifiable but preventable deaths stemming from medical complications originating in the physical and mental traumas connected with substance use. I'm, in closing, just going to quote a study from The Lancet, which I'm happy to provide to the committee. I'm just going to read some of the findings. This was a study looking at overdose deaths between the year 2000 and 2020, so all the way up until basically COVID.
Excuse me, Mr. Johnson, but you've reached your 3 minutes. Thank you.
Mr. Johnson, why don't you quickly give us some of those results, if you could?
Sure. So the fastest increase in drug overdose deaths occurred in Black Americans beginning in 2012, and Americans of all races born after 1975 had higher mortality risk, with mortality risk increasing rapidly in more recent cohorts. The peak of mortality has shifted to the 30 to 40 year age group in the past decade, and their interpretation was urgent action is needed to prevent an entire generation of young people being consigned to decades of preventable mortality. Thank you.
Thank you. That's a powerful ending. Thank you for staying here with us today. We really appreciate that. Now we will go back online to Leah Sforza. Welcome.
Hi, everyone can hear me okay?
Yes, we can.
Great, thank you. I'm here providing testimony in support of overdose prevention centers as outlined in Senate Bill 195. Co-chairs Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee, thank you for having me here today. My name is Leah, and I'm a resident of Oakville, Connecticut. I was present at the hearing earlier today and was looking forward to speaking in person. I was not aware that these hearings can go on late into the night. However, I'm grateful to have a space to share my support from home. I believe people struggling with drug dependencies deserve to live. I am an honest employee, a new Connecticut State student, and I am a person with long-term recovery. Today, I have the chance to be free from drugs, and I have found a new way of living, a way I could have missed out on if I had overdosed. Too many of my friends have overdosed on opiates. These deaths could have been avoided if they had had a supervised environment. They could have received the second chance that I had been given. My loved one was sentenced to over 7 years in prison in May of 2025. A friend of his who had just left an inpatient rehab reached out for fentanyl after relapsing on alcohol. He provided drugs to his friend who overdosed that night. This friend did not want to die, but no one was with him to help. We hide our drug use from our families out of fear of consequences, judgment, and hurting them. We use alone. This life wouldn't have been lost if he had a safe place to use under supervision without fear of consequences or arrest. A life was lost and another thrown into a harsh sentence he wasn't deserving of. 2 more humans who could have been saved. Since the first time this bill was considered, roughly 3,000 Connecticut residents have died of preventable overdoses. We cannot let more families experience this devastating pain. Please choose to be a part of the solution, this solution being overdose prevention centers in Connecticut. Thank you.
Leah, thank you so much for staying with us both in person and online, and for sharing your story and the pain that you've experienced in an effort to help other people. Senator Anwar.
Thank you so much, Leah, for your testimony, and thank you for being here earlier. I just wanted to thank you, and I know we were looking forward to your opportunity to be in here in person, but we appreciate you. Thank you.
Thank you very much. I believe that Dita Bhargava may be looking to testify online, if I'm not mistaken. And so with that, we will go to Carol Jones. Is Carol still here? No. Okay. Thomas Burr is not here in the room. Milagros Marrero Johnson. Is Milagros here? No. Okay. Kaylin Pelletier Kalyan. Yes, I believe will be. Oh, I'm sorry. There we go. Thomas Burr. Hello, Mr. Burr. Welcome. I didn't see you on there. Thank you for raising your hand. Please.
Yeah, no, I missed the prompt to join as a panelist, so my apologies. But thank you, and good evening, Senator Anwar, Representative McCarthy Vahey, and members of the Public Health Committee. My name is Thomas Burr, and I am the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness also known as NAMI Connecticut. NAMI is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. NAMI Connecticut and its 9 local affiliates provide support groups and education programs for people with mental health conditions and their loved ones, and provide public awareness events and activities to communities throughout Connecticut, and advocates for policies to improve the lives of people affected by mental health conditions. And if any of you are unfamiliar with us, I have more information on my written testimony. Tonight, I am testifying in support of SB 191, an act concerning the psychedelic assisted therapy pilot program, SB 195, an act concerning the prevention of accidental overdose deaths and improving access to treatment and recovery services for substance use disorder, and HB 5164, an act concerning the use of funds in the Tobacco Settlement Fund. All right, so here we go. Regarding SB 191, the use of psychedelics in treating chronic, hard-to-treat depression has shown great promise when it has been researched, particularly with psilocybin, MDMA, and ketamine. You're probably aware of the research done at Yale University. They've had great success with ketamine, which led to an FDA-approved medication, S-ketamine. You have a lot of detail in my written testimony. I'm not going to go through it all, but I cite several studies that show that this type of treatment shows great promise, and that they also mention, though, that more research should be done. So I'm really supportive of this pilot program and appreciate you considering that to move through the process here and become a real thing. Regarding SB 195, I've been listening since mid-afternoon to a lot of the testimony on this from some of the people who've been directly affected, and it's just so moving. And, you know, certainly you should know that harm reduction is a concept that NAMI Connecticut supports wholeheartedly as an evidence-based practice. Therefore, we support this as a pilot program to prevent drug overdoses, and the establishment of overdose prevention centers in the 4 municipalities in the state as selected by the Commission of Demas. Last, regarding House Bill 5164, while we support this bill as written, since the state of Connecticut has been experiencing these huge surpluses in the past 8 years, we think that instead of the disbursements from the Tobacco Master Settlement Agreement should be completely dispersed to the Tobacco and Health Trust Fund for the purpose of both tobacco as well as marijuana cessation efforts, especially in light of the troubling increases in youth and young adult vaping of both nicotine and cannabis. So in conclusion, we support SB 191, SB 185, and House Bill 5164 with the changes in disbursement levels as I just discussed. So thank you. Appreciate you guys staying so late, and would be happy to entertain any questions.
Mr. Burr, very well timed. Well done. Thank
Not
you.
my first rodeo.
Nope, it is not, and we're happy to see you here. I just will note, in terms of the Tobacco Trust Fund money, I appreciate your comments related to nicotine, tobacco products, and also cannabis. And as you are probably well aware, those Tobacco Trust Fund dollars are very specifically legally limited, but your point is well taken that the issues intersect, and I appreciate that commentary. Seeing no questions, we say thank you for sitting with us, being with us, and we appreciate you. We will certainly be in conversation with you as we move forward.
Thank you so much. Have a good night.
Have a great night. Next, we should have Amy Bogert. Is Amy here? Oh, wonderful. You have literally been here waiting all day. Oh, many of us understand that very much. We're very, very grateful that you stayed with us. Welcome, and please proceed. Could you first push the button right in front of you so we can hear you and everyone at home
There
can
we
as
go.
well?
I'm Amy Bogert. I'm from Niantic, Connecticut. My son Mason overdosed in 2016, a month and a half before his graduation from high school. He lived for almost 5 years with a resulting brain injury and died 2 days after his 23rd birthday. Mason began to use drugs like Tim Lally because he also struggled with mental health issues. And my husband and I struggled to find him appropriate treatment that would address all of his issues, and were unable to. Mason's and our family's struggles to find appropriate treatment led me, after his death, to advocate for better treatment options in Connecticut, particularly more co-occurring treatment. I'm a member of the treatment subcommittee of the ADPC, and I serve on NAMI Connecticut's Public Policy Coalition. I'm here to support SB 195. The existence of harm reduction centers saves lives, which is of paramount importance. And that alone should cause you, as public health advocates, to support this bill. I would also argue that harm reduction centers should be seen as part of the treatment spectrum. Many people who struggle with substance use disorder also struggle with the stigma put upon them by society and perceive themselves as worthless. If we don't care if they live or die, why should they? Harm reduction centers exist to keep people with substance use disorder safe and save lives if needed. When a person struggling with addiction realizes that someone thinks their life is valuable, they can begin to value themselves and their future. With this new perspective, people can be more likely to accept treatment. In 1988, New York City's harm reduction effort, called ADAPT, got more than half of the people who came to their center enrolled in treatment. As a retired educator, I know the value of meeting people where they are and supporting them in making small steps toward a goal. The addition of harm reduction centers to the array of treatment entry points, centers where people are treated with dignity and acceptance, and where there is an increased possibility that people will begin treatment, strengthens the state's abilities to protect and support people with substance use disorder. Thank you.
Thank you very much. And you being here today just makes me think that a mother will do anything for her child. And you
I'm also
are.
trying to do it for other people's children and to spare other families the hell that we lived through.
Thank you so much for that. One other comment, Senator Anwar.
Thank you so much. You've been here all day, and we're so sorry it took us such a long time to get to you. And I know you had to be somewhere else, and we could not move things around. I apologize.
No, that's okay.
It was almost like
Now I know it's a marathon.
It is a marathon, but we appreciate your testimony, and your words and your presence means a lot to us. So while we're not asking you a lot of questions, but it does not necessarily mean that we're not valuing all your work and your advocacy today.
Thank you.
Thank you. Drive safely when you go back.
Yes, thank you so much. Next, we have Dr. Robert Heimer is here with us. We are very grateful that you were able to make it here, and welcome your comments tonight.
Well, thank you. Forgive me, I'm out to dinner with my family who's up from Philadelphia. So I'm sitting outside, and I'll try to be as brief as I can be. My name is Robert Heimer, and I'm professor of epidemiology at Yale University. I've been working on the problems related to unsafe drug use and opioid overdose for more than 35 years. This work confirms that harm reduction remains a most effective set of strategies for increasing health and the well-being of Connecticut residents who use drugs. And despite the decrease in fatal overdoses of late, recent fluctuations in the drug supply have made their consumption more dangerous. Therefore, reducing overdose will require further actions, especially those that deter individuals from using alone. One such action would be the establishment of harm reduction centers. In my prior testimony in previous years, I focused on the research conducted that demonstrate the strengths of overdose prevention centers. Others have provided testimony about this topic tonight. So instead, I wish to focus on 3 stories of individuals who I have met over the years and how their use of harm reduction programs have, in fact, saved their lives. I know a lot of people have talked about people who've died. I want to talk about people whose lives have been saved. The first of these goes back to the days of the early needle exchange program in New Haven, which began in 1990. A dozen years later, we were doing work in Portland, Maine, and we met a man who told us that he'd used the New Haven Exchange program and that he'd also used the alias of Road Runner, and that the program saved him from getting infected with HIV and helped him overcome his addiction. He did not have to reach out to us, but it was important to him that he had the opportunity 12 years later and 200 miles removed to tell us about how important the program had been in saving his life. More recently, I received an email from someone whose name I didn't recognize. When we spoke on the phone, he told me that as a teenager, he developed a heroin problem and had used the New Haven Exchange program. He told me his alias. He appears in the exchange record logs that I retain as Lowell Weicker, who was governor at the time. The program kept him HIV-free. He was able to join the military. He served as a medic in Iraq and Afghanistan, returned home, became a physician's assistant, and he now plays a major role in a national training program in harm reduction for PAs in training. He attributes his life trajectory, at least in part, to the welcome he received as part of visiting the exchange van. The third story is over the last decade, I've come to know the outreach team at the Alliance for Living in New London. Each member of the team has experienced problematic drug use, and each has a unique story about how their interactions with harm reduction in their several forms have given them the strength and the purpose to help others as they themselves received help.
Excuse me, Mr. Heimer, but you've reached your 3 minutes. Thank you.
Okay.
If you can just sum up that last story, we would love to hear the rest.
Sure. They believe that they would be able to do a better job, make stronger connections to people, and save more lives if they could link their work to a place where people are allowed to use drugs safely. These 3 stories only give a glimpse into what functional overdose centers can provide.
Thank you so much, not only for your testimony tonight, for stepping out of dinner, say hi to that Philly crew for us, and for your decades of work on this. Senator Anwar.
Thank you, Professor Heimer. Thank you for your testimony, and thank you for the work for the past 35 years and being literally at the cutting edge of some of these aspects. The question I had for you was, back in 1990, we were facing similar challenges for the legislators and everyone to understand harm reduction and the concept. How were we able to overcome the resistance? And now if somebody questioned that, we'll all laugh at them. Could you tell me how you were able to achieve that?
Well, I think there were resistances both at the state level and at the national level. At the state level, we had made syringes, the purchase and possession of syringes without a prescription, except in certain exceptional cases like veterinarian use, illegal. And so to allow an exchange or a program to give syringes to people required a variance from the state law at the time. And that was only done after 3 years of lobbying. So you guys are now on your 2nd and 3rd year of lobbying. So you're approaching what it took to get that needle exchange program in the first place. At the national level, there was tremendous opposition to a needle exchange program. We were told when we submitted a grant to do work on the project, not even to mention the words needle exchange in our grant, that would torpedo the whole study of the project. So clearly, Connecticut was in the forefront. Connecticut was willing to take risks and change the state law, or at least give an exception to the state law, and to really act progressively in the face of what the federal government at the time was not viewing in any way as contributing to the problem of solving drug addiction in the country. We demonstrated quite to the contrary, that in fact, not only was the program able to reduce the spread of HIV and hepatitis, but to get people into treatment. All the things we had hoped the program could do, in fact, it did, because the state legislature, in its wisdom, allowed us to do this.
Thank you so much. So you give us some hope in this picture. You are helping the world at this time. You're in Europe. You're being able to influence the policy. You've been able to help in other parts of the world. You live in Connecticut. Can you help us more? What can you do?
I can do whatever you call upon me to do to move what I know is an evidence-based, life-saving, humane program and put it into existence in the towns that wish to have them.
Okay. And maybe we'll take you up on your offer and set up a meeting with some, probably the highest executive in our state to listen to some of the data and perhaps information around it. Would you be able to make time for us?
I certainly should be able to find the time.
Okay. We want to thank you for your testimony and the work that you do. We truly appreciate your work. You're a hero, and it's great to be ahead of the curve, and you're way ahead of the curve on so many things, and it's just amazing. So
Well,
I appreciate you.
I just hope the curve catches up to me.
That's a great, beautiful word. Okay, thank you so much.
All righty. Good evening.
Thank you. Enjoy dinner with your family.
Thanks.
Thank you for spending the time with us. Next, I know Mr. Williams was here earlier today. He is not here now, and we will communicate with him about some of the questions and concerns about the bill. And next is Paul Kidwell, Connecticut Hospital Association, and he is still here. Mr. Kidwell, welcome. Probably, I think the other one is.
That one? Does that work?
We'll see.
I know we were having some technical difficulties, right? Real quick though, before we start, basketball score update. The women are up by 6 in the third quarter, and the men are up by 3 in the start of the second half. So, good evening, everyone. Representative McCarthy Vahey, Senator Anwar, Representative Claritas Ditria, and other members of the committee. Thanks for taking some time this evening. My name is Paul Kidwell, and I'm here today representing the Connecticut Hospital Association. I'd like to take my time to testify in support of SB 196 related to private equity investment in hospitals, as well as offer comments on HB 5165 related to hospital receivership. As we've testified before in this committee previously, we acknowledge the damage that unregulated private equity investment has caused in certain situations in our state. We have also been concerned that blunt prohibitions on this type of investment could have unintended consequences. Prohibiting modest yet important investments that support healthcare delivery. We support reasonable measures to ensure that investments are transparent and to prevent future scenarios where a hospital's financial health is jeopardized by interests other than those of the community it exists to serve. SB 196 reflects a measured approach to this issue and reflects language informed by public hearing testimony last session and developed in partnership with this committee's leadership and CHA during the last session. Related to HB 5165, the primary cause of hospital financial distress is the state's insufficient support of the Medicaid program, which I believe Representative McCarthy Vahey, you indicated earlier today as something that you hear regularly from providers. Before the use of receivership is considered, we believe that the legislature should task the DPH commissioner along with the DSS commissioner and the secretary of OPM with evaluating and reporting all feasible solutions that Connecticut could adopt to avoid financial distress and operational crisis for hospitals, including, but not limited to, evaluating how a reasonable and stable approach to Medicaid reimbursement for hospitals would create financial sustainability. In addition, we urge that the bill be amended to require the DPH commissioner to include significant stakeholder involvement in the evaluation. A receivership law triggered by financial distress or operational crisis should be defined in a narrow way and only used if and when all other remedies are utilized. This is imperative, especially when the state's Medicaid reimbursement policies are helping to create the distress and crisis. As always, we look forward to working with the committee throughout the legislative process and are committed to seeking and finding policy solutions to issues affecting patient care in our state. Happy to answer any of your questions related to these bills or any of the other bills before the committee today.
Mr. Kilwell, thank you very much for the basketball update and also for staying here with us. A couple of questions for you.
Yep.
So 196, thank you for acknowledging that, yes, there was extensive conversation last year, both here around the circle and as well after, as we continued to meet together as leaders of this committee with you and many other stakeholders. So I appreciate that. My question is, do you think that 196 is the end of the conversation about private equity in healthcare?
I suspect it's not the end of the discussion. I think it's a good start, but I appreciate that you and your colleagues likely have some other questions and some exploring that you'd want to do related to private equity. I think we're learning more and more about how it's used, not just here in Connecticut, but across the country more every day. So certainly welcome those ongoing conversations.
I appreciate that answer. And yes, you're right. You suspect and you, I think, know that we will have other conversations. I think it's going to be an ongoing one. So I think that 196 is a good step for us to take. I appreciate also your comments on the receivership proposal, the bill before us, and I do look forward to having some ongoing conversation about how we might look forward to that. I specifically appreciate your ask to include significant stakeholder involvement in that conversation with the commissioner. Senator Anwar.
Thank you so much for your testimony. Actually, at the basketball, they just said, oh, the testimony is at number 71. This is the bigger game in town right now.
My daughters and wife at home have been sending me updates and are very distressed about the closeness of the women's game.
I'm sorry, I if you don't mind repeating the receivership part.
Oh, sure. So I think we generally understand the interest there. I think we would like to see the bill expanded a bit so that not only is the study looking at whether receivership is a good idea in certain circumstances, but that the DSS commissioner, the DPH commissioner, OPM commissioner are also tasked with identifying opportunities to ensure that the state is helping to prevent the circumstances which lead to hospitals potentially needing a receivership. And I think we've testified before this committee, the Appropriations Committee, and the Human Services Committee related to the Medicaid underfunding in the state, which leads to a $1.5 billion shortfall every year. And for certain hospitals where their government payer mix is significant, that Medicaid shortfall becomes a hindrance to financial stability.
Yeah, we get that. I think obviously it's multi-layered issues. There's so many variations that the hospitals are going through, and between the insurance industry's bureaucratic process, the Medicaid funding, your hospital tax, and so on and so forth, and the issue comes down to is that in other states, when things got pretty ugly, there've been like 6 hospitals that we are having transactions on right now, and or perhaps even more by the time things clear up. And if something fell through the cracks and there wasn't a larger entity or the state did not show the leadership that it's showing right now with the UConn, the hospitals could close. And then that means certain communities, and most likely the vulnerable communities, would have the problem, because that's where it comes down to. So we need to have a receivership, and that should be looked at separately from a plan to address the challenge if it gets to that point. The preventive strategy obviously is a conversation that would be outside the scope of this bill. I completely recognize, respect, and we'll work on the other components of the prevention to get to the demise of a hospital. But if there is a demise, what do we do? That's the part.
Yeah, so appreciate that. I think our perspective is we should cure the problem before we have to take the medicine. So appreciate it. In the instance of the bill, I think we need to think really hard in how we define financial instability. The 2 Prospect hospitals are not the only 2 hospitals in Connecticut that are looking at financial instability. If you look at hospital margins across the state, they're at 0, slightly above 0 over the last 3 years.
Yes.
So we have a chronic underfunding problem in our government payers that is creating those situations. And if we're going to advance a receivership study, which we think is not an inappropriate thing to do, we do want, though, to make sure that when we're thinking about financial instability, we're talking about what that measure looks like, because I don't think it's I don't think it's the intent of the legislation that the state of Connecticut would be then, like you said, looking at multiple hospitals in receivership in any given year. I think it needs to be used judiciously, and I think that's likely the intent of the bill.
But this happened in Massachusetts and in other states too. In Massachusetts, they were able to intervene, and the state was able to intervene and protect a hospital. So that's the and the state of Connecticut does not have that mechanism at all, and had something fallen through the cracks, we were going to have a large population without health care, and we don't have that safety in our state, and that's what the bill is. And I want to look at that bill separately as that safety valve, which hopefully, and we pray that we'll never have to use, but we need to have something like this. The problem with larger healthcare systems is that if the state breaks it, they have to buy it, right? And right now there's no mechanism for the state to buy it when they break it. And there are so many things that you're speaking about that are going to slowly break many of the healthcare systems, but we have to figure out a strategy to prevent that. That's going to be a separate bill and separate conversation. Perhaps a lot of that is going to be outside of the scope of our committee.
Yeah, definitely understand it. In this instance, the state had plenty of opportunity to help make sure that those two hospitals didn't get into the position they did, right? They had a willing buyer, and they had a CA1 process that took more than 300 days to complete, which caused those hospitals to go into even greater financial instability. So, Senator, appreciate that you want to make sure that there is an apparatus for when things don't go right, and we appreciate that. We just don't want the cure to get left outside of this discussion, and appreciate you don't have jurisdiction over everything. But it's critically important that we look at this holistically.
Thank you. Thank you for your testimony. Thank you for staying with us for.
I always learn something when I'm here, so I appreciate it.
Thank you very much, Senator Anwar. Senator Gordon.
Thank you, Madam Chairwoman, and thank you for the testimony. And I'll preface my remarks that anything I say doesn't mean I intend anything negative about the work that hospitals do. I've worked at a number of different hospitals in Connecticut, and proud to have done so. You've mentioned, I'm trying to understand your testimony. I've read through the written testimony on 5165. I'm just trying to understand your testimony. You talk about dealing with the cure and not taking the medicine. Not certain that's the right analogy. Many times to cure someone, you actually have to give them some sort of treatment.
Poor analogy on my part.
As I was continuing to talk about, I'm just trying to understand your testimony in 5165 in the written testimony. Are you saying that the Connecticut Hospital Association is opposed to the bill, or looking to see what to do to perhaps make the bill better? I'm not
looking to see what we can do to make the bill better. We are not opposed to the bill.
Because it would seem to me that if a hospital is in distress, we can learn from some of the things that were done up in the Commonwealth, right to the north. I mean, this was unfolding up there before state government decided to even acknowledge there was a real problem with Prospect Medical here, despite alarm bells ringing and I think the fire raging. And things got horrifically bad up there, as I'm sure you know, with Steward Health, a gigantic mess and 2 hospitals lost, including an emergency room in the central part of Worcester County, which is going to be rectified in a different way, but still a disaster. And a lot of folks lost their jobs, unfortunately. So I'm just a little confused by what you're looking to make better or proposing to make better. If a hospital is to that degree, I think there should be a mechanism for the state of Connecticut to have to step in. We can't have hospitals outright fail, and I know there's discussions about Medicaid reimbursement, and that's related but somewhat separate, and I agree we should be doing more over time to help with the Medicaid reimbursements. But there's other things that go into issues with regards to hospitals having financial problems. So I would hope that if Connecticut Hospital Association is looking to, I guess, make this bill better, I'm trying to understand, are you saying you don't want to have a receivership option or the state to have to step in if there is no choice to prevent a hospital from outright shutting down, patients then no longer have access to care, there might be an emergency room that completely is gone, and that's horrific for emergency care, and then potentially thousands of healthcare workers lose their job. I'm just a little not
Yeah, we
clear.
think the bill can be improved. We're not opposed to the bill. We're not opposed to a study of a receivership. We think that there are things that we would think stakeholders should be involved in the study. I think we need to think hard about what financial instability or operational instability means. And we want to be part of that process. So we are not opposed to the bill. We think it can be improved with stakeholder involvement. We think that the issues that cause the financial instability should be considered as we move forward, but again, not opposed to the bill.
No, thank you. And then one question I have relative to, I've read through the testimony, and you also had provided information, I think it's on 196.
Yep.
And I'm just trying to, and I just want to make certain I understand the testimony from the position of the Connecticut Hospital Association being in favor of exempting certain situations of these sale leaseback transactions from the provisions of statutes 19A-486A through H, which means exempting from certain approvals. I'm just trying to understand if that's what the testimony is.
Yeah, so we support the bill as drafted, and that includes that exemption. And what we talked with the leadership of the committee over the last session was there may be circumstances in which those types of transaction may be appropriate, and that was the outcome of that discussion, was inclusion in the legislative language.
Let me rephrase my question, if I may. I'm just trying to understand, you know, there's provision in this bill that's written to say exempting certain approvals that are built in already to current state statute. So is it the position of the Connecticut Hospital Association that those exemptions that then could be granted if this bill becomes law, that the Connecticut Hospital Association is okay with then having exemptions from certain approvals that are
in those
required now?
limited, in those
Well,
limited.
as I was just, let me just finish if you don't mind. But exempting then those transactions from certain state approvals, including by the Attorney General, is that the position of the CHA?
In those limited circumstances, yes.
I would just say that I'm opposed to the bill and to that thinking. I think if a hospital is in distress, seeing what damage has been done already with some hospitals that had to deal with getting into these lend-lease, REITs, if one's in that much distress for whatever reason, for example, not good Medicaid reimbursement, and that's not getting better, then all one doing is piling more harm in an attempt to maybe make good, because those payments have to still be made. And so if you're piling on more debt, it makes the financial situation even worse. I think all the more reason, if one supports this bill, one has to support a strong ability by the state of Connecticut to have to step in if there's a financial distress that could cause a hospital to close. Because to me, it would seem to be making a deal with the devil from a financial point of view. I don't see that ends well. I think we have enough history here in this state, the Commonwealth, and even Rhode Island and some other states. So I just am very concerned about it. I don't see any good will come of it, and I think it sets up even more for a disastrous failure. And again, begs that the state should then have to have more oversight and approval. Thank you, Mr. Chairman.
Thank you, Senator Gordon. Mr. Kidwell, can you speak to why you, as the Hospital Association, have supported and are in a position to support that aspect of the bill?
I think our experience with the state and related to financial insecurity is that the state hasn't ever proffered any support that would address the situation. And so two sessions ago, we now report a lot of information to OHS related to our financial health. And OHS is required to reach out to us if they think that a hospital might have some financial issues. But there's no cavalry that comes along with it. So to the extent, as part of this process, we want to discuss what that support might look like. Absolutely, we should discuss that. And what state processes the hospital needs to go through in order to avail itself of that assistance. We're absolutely supportive of that. But that's not the history we've had thus far. And so what we do is look into the private market to see how can we support the enterprise. Again, in the situation with Prospect, completely inappropriate behavior in that instance. There were actions that led up to the eventual bankruptcy that could have been avoided through a state process. I know we're going to be talking about the CON process in this committee in the future, and I think that's a really important part of ensuring that these hospitals don't go into severe financial distress. So I think there are a plethora of things that we can do to make sure we avoid these situations in the future. We support 196 as drafted. If it's the committee's intent to continue to look at the language and perfect it, we'd be happy, of course, as we were last session, to be at the table and talk about those things.
Thank you, Mr. Kidwell. We appreciate you staying with us and for this protracted conversation, which I think has been helpful, actually. Thank you.
Thank you.
We are going to go to number 67, Kalyan Pelletier, who I believe is also with Dita Bhargava, who is a student. So we're going to go back rather than make Kalyan wait until the end of the night. I see Ms. Bhargava. Hello, there you go.
Can you hear me?
Yes, we can.
Hi. Just want to start by saying that I dedicate today's testimony to my dear friend Carol Egan, a true hero in the fight to end the drug epidemic. We lost her last week to a tragic accident. Honorable members of the Connecticut Legislature and Public Health Committee, I'm Dita Bhargava, a board member of Liberation Programs, Shatterproof, and United Way of Connecticut, and a Yale University student pursuing a Master's of Public Health. I support SB 195 to facilitate the establishment of overdose prevention centers. In 2022, I testified for HB 5044, in 2023 for SB 9, and last year for SB 1285, urging lawmakers to open OPCs in Connecticut or allow to open them. Since then, over 4,000 people have fatally overdosed. Since Governor Lamont assumed office in 2019, naloxone has been widely distributed, and targeted funding for prevention, treatment, and recovery has helped reduce overdose rates finally. But still, nearly 9,000 residents have lost their lives to overdose since 2019, with over 700 deaths occurring just last year. Each one represents a child, sibling, parent, or friend. This situation is unacceptable. State leaders must take bold, innovative action. Our son, Alec Pelletier, a funny, smart, charming AAA hockey player, passed from fentanyl poisoning on his 26th birthday in 2018 while in a sober home in Canaan, Connecticut. Alec relapsed after months of sobriety. His reduced tolerance put him especially at risk. Although he kept Narcan nearby, shame led him to use alone, with nearby roommates unaware. Access to a safe, non-judgmental space with medical support that night would have saved Alec's life. Some say OPCs increase drug use and crime, but studies show they reduce deaths, disease spread, and costs while connecting people to support. OPCs expand on Narcan distribution by providing immediate needed intervention. Narcan is simply ineffective without someone present. In Canada, as we've heard, OPCs have operated for over 20 years, and they have seen over 50,000 overdoses and drug emergencies without any reported deaths. There are concerns about the legalities of OPCs. We've heard that tonight due to Section 856 of the Federal Controlled Substance Act, commonly referred to as the crack house statute, which makes it illegal to operate a place for unlawfully manufacturing, storing, distributing, or using a controlled substance. However, Professor Scott Burris of Temple University, who has studied this act and its impact on harm reduction for over 30 years, testified before the Connecticut legislature in 2025, explaining that states have broad constitutional authority to enact health-related laws and that these facilities are legitimate health interventions. They save lives of sick people. That's why Rhode Island's Project Weber Renew began as a state-approved OPC in January 2025. And after a year in operation, it has seen 3,400 visits and reversed almost 100 overdoses already. 80% of their visitors said they would have used alone and potentially died. Our other neighboring state, New York, has also operated OPCs since 2022 and saved hundreds of lives. Connecticut has an urgent opportunity to help our residents find life, love, community, and happiness. It's time our leaders support SB 195.
Thank you, Ms. Bhargava. And I know Senator Anwar has a question. Just logistically, are you also with your son? Is he with you, or will he be testifying tonight?
He will be, and he is. He's next to me. And I'm sorry, we had planned to be there in person, but I had to pick him up in New Milford, and we couldn't get back in time. So my apologies for that. We're in our car right now outside of a hockey rink. So I'm sorry about that.
We understood. Just thank you for answering that. Senator Anwar.
Thank you so much, Dita, for your testimony. Thank you for the work that you've been doing and your advocacy. And I'm so sorry about your loss. And I'm so sorry you have to relive it frequently to be able to advocate. And also thank you for being here most of the day. And then you had to go and pick up your son, so you could not be here in person for the testimony. Earlier, Arya was testifying. That's your daughter. And she's at Greenwich Academy. It's a fair question that was asked that, okay, what if this bill passes, which we hope and pray it will, what would your town, if that's the town that you live in, will say if you went over to them and say, hey, I want an OPC in this town?
Senator Anwar, thank you so much for your advocacy and for having me here today to testify. And thank you for asking that question, actually, because I've spoken to many towns across Connecticut about OPCs and harm reduction and overwhelming support by so many people who believe that every life deserves a chance to live, every sickness should be treated. And in Greenwich, actually, I have had lengthy conversations with the first selectman who is not on the same political aisle as me always. He's a Republican, I'm a Democrat. And I actually ran against him in 2016. And as opponents do, we didn't agree on a lot of issues. This is one that he wholeheartedly supports. In fact, I've had conversations with him last time because we were hopeful we were going to pass. And he was cheering us on, from his position, giving me support. I had lengthy conversations. He actually said, if this passes, we should collaborate with Greenwich Hospital, with Stamford Hospital, and we should make this happen because not only will these centers save lives and help people who have a disease, just like we help people with cancer, and he actually suffered from cancer in the past, and I think that makes him especially empathetic to diseases. But he got, and cancer patients get chemotherapy to save their life, the same way that any person suffering from addiction should be given Narcan. And they should be able to go to a clinic to have this happen, just like a cancer patient goes to a clinic to have their therapy. So he said not only would it be a compassionate way to save lives and give people hope and give them the education that recovery is real give them community, which is so important for people who suffer from mental health and addiction services. But, he's pretty fiscally prudent. He said it would also help take the burden off of emergency rooms in these hospitals and save money. Because when people come in over and over again because of substance use disorder, it's a burden on the ERs and it costs millions and millions of dollars. So imagine all the dollars we would save if we just had a center where people could get the help that they need. So very much on board. Thank you for that question. Actually, Ari didn't mention that she's actually on the youth council of the First Selectman's office, and they do a lot of work on mental health and just being compassionate to people who suffer from mental health and addiction.
Thank you so much for your testimony, and thank you for clarifying that aspect. I don't have any more questions, so go ahead.
Thank you very much. Tita, thank you so much for your just constant advocacy and for all that you have done on this issue and so many others.
Thank you so much, McCarthy.
We're going to turn it over to your son, which I think just handing the phone over to him or the device. Welcome.
Thank you.
Please proceed.
All right. Honorable legislators, I'm Kalyan Pelletier, here to support Senator Bill 195. I'm a high school freshman at Brunswick School, living with type 1 diabetes. I manage my blood sugar with hourly monitoring, carb counting, and insulin. Though some days are difficult, supportive doctors, nurses, and my family give me guidance, a treatment plan, and a hope for a full life. No one shamed me for my disease. This was not so for my older brother, Alec. Alec struggled with substance use disorder, but that did not define him. To me, he was a hero, someone who played AAA hockey and inspired me to put on my own skates. Alex was strong, funny, and smart, and in his final years, he wanted nothing more than to get sober and build a proud life. But Alex's path to recovery was filled with gaps. He moved from one treatment center to another, often without follow-up or long-term support. When I was diagnosed with diabetes, my doctors checked on me constantly. When Alec left treatment, he was left to navigate the most vulnerable period of recovery on his own. On 2018, on his birthday, Alec died from fentanyl poisoning, just weeks after being discharged from a treatment center in Kent, Connecticut. The Surgeon General once said, "Addiction is not a moral failing, but a chronic disease of the brain that deserves compassion and care." If we truly believe that, we must treat it like every other disease. No one would ever deny me insulin because my pancreas does not produce it. No one would ever stigmatize a cancer patient because their illness may have been linked to smoking. So why do we allow people with substance use disorder to suffer in silence, afraid to ask for help? The night my brother died, he placed Narcan by his side, and his roommates were close. But shame stopped him from asking for help, costing his life. Overdose prevention centers offer compassionate, supervised spaces for overdose reversal and access to treatment. They allow individuals time to pursue recovery. This session, Governor Lamont and the legislator can pass Senate Bill 195 to create safe spaces that save lives like we do in the states surrounding Connecticut. This is not about politics, but about people. It's about our brothers and sisters. It's about birthdays that still should be celebrated. Both NHL star Max Domi living with type 1 diabetes and NBA legend Chris Herron living with addiction equally prove that their diseases are not barriers. Not everyone is so fortunate. My brother was awfully close, wanted to recover, but needed time, support, and a safe, life-saving place. Please pass Senate Bill 195. Treat addiction like the disease it is. Give families like mine a chance to hold on to our loved ones. Thank you.
Kalyan, that was beautiful. Thank you.
Thank you.
for being here, especially as the juggle of your night. And you said that your brother was your hero. I think you're a hero.
Thank you very much.
Thank you for sharing tonight.
Thanks for having me on.
Senator Anwar.
Kalyan, thank you so much for your testimony. This was very helpful, and I know you have homework and you have school and you're getting prepared for all this, but you made sure that you were able to speak. In a way, I'm glad you didn't have to drive all the way because it was going to make it more long night for you. So I'm glad you got to speak, and your impact is very clear on all of us. So thank you.
Well, thank you for having me on.
Thank you so much. Next, we will go to Kyle Fitzmaurice. Welcome. Please proceed.
Hello all. Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Kyle Fitzmaurice, and I thank you for the opportunity to testify today in support of Senate Bill 195. Besides being a lifelong resident of Connecticut, I have worked in Torrington at McCall Behavioral Health Network for the last 4 years. We also live with my wife and my 10-month-old son. It's important to me that you know, while I'm honored to represent my organization today, I come here first as a neighbor and a community member. I'd be delighted to hear that an OPC was in my hometown. As a father, I want my son growing up knowing that his state invests in the care of his community. I have served in a variety of capacities during my time at McCall, from responding to overdoses with our local police partners, outreaching to at-risk communities, and coordinating one of our outreach programs. Regardless of the role that I held, I worked very closely with people who use drugs. People who live in, work in, and use drugs in the same community that I have lived for the last 15 years. Before stepping into this line of work, I had a firm narrative in my mind that the way we help people who use drugs is by letting them struggle until they reach rock bottom, to arrest them, crack down on laws and drugs and the people who use them. And I share this for 2 reasons. One, because after experiencing our system from the front lines, I can tell you that not only is this frame of mind wrong, it's causing harm. And 2, because my mind was changed, and it certainly didn't happen in 3 minutes. Data helped, stories helped, and information helped, but my mind was changed, truthfully, with just experience. My favorite part about this work is not the change process or getting people into treatment, it's unconditional love. For the people we serve and for our community as a whole. My colleagues who spoke before and who will speak after me are truthfully experts in this field. People with lived experience, people who are data analysts, public health officials with decades on decades of work under their belts. Knowing that I'd be the 73rd person to speak, I have a feeling that data's been covered, the stories and the personal anecdotes have been covered. I have shared both in my written testimony and would love for you to read it, and I would be honored. In these 3 minutes, I want to stick to what I feel I know best, and that's creating a space for unconditional love. Many of the people I have the privilege of serving have a view of themselves that they are less than, underdeserving, unseen, unwanted. And while we have made great strides in naloxone saturation around our state, there's no amount of outreach in naloxone that can save someone who has not been found. People die from overdose because they are alone. We have to invest in our neighbors if we want them to have a better quality of life. Outside of it being simply what every human deserves, we preach unconditional love because the doors of conversation stay open when our minds do. So I'd like to close with an invite to all of you. Whether it is to myself or one of my many deeply educated and experienced colleagues, please reach out. Come visit an OPC or an outreach site with us, ask questions, let us give you the experience that we are privileged enough to lean on to share with you why these spaces are such a dire need in our communities. Thank you.
Thank you so much for your testimony today and for sticking with us. We appreciate you and the work that you do.
It's an honor to speak.
Next, we have Alexi Ditmore, who is not here in the room, I believe. Bright Johnson, welcome.
Thank you. Good evening. I'm Bright Johnson, Connecticut Government Relations Director for the American Cancer Society Cancer Action Network. We are in strong support of HB 5164 and have submitted written testimony which details the cost of tobacco use in Connecticut, the disappointing and uneven history of tobacco control funding over the decades, and indisputable evidence in support of the vital role tobacco control plays in helping people quit and preventing kids from ever starting. I'd like to use my time today to publicly thank the governor for maintaining $12 million in funding for the second year of the biennium in his budget revision proposal, which will provide continuity of tobacco control programs and services across the state. While the budget proposal is a strong place to start, we can't stop there. That's why we strongly support increasing tobacco control funding to $32 million annually as called for by the CDC, which HB 5164 would do. Increasing funding for statewide tobacco control programs that meet CDC best practices would better alleviate and reduce the tragic annual toll tobacco use costs Connecticut, both in lives lost and healthcare expenses. The number of annual deaths in Connecticut is staggering. 4,900 lives lost, 13 people a day. About 3 or 4 have died during the course of this hearing today. Unfortunately, after years of decline, we've seen increases in youth tobacco use nationwide in recent years, largely due to skyrocketing rates of e-cigarette use, as well as new, largely unregulated products that have come on market, such as nicotine pouches. At the same time, progress on previously declining youth use of other tobacco products, including cigarettes and cigars, has slowed. It should be noted that the damage tobacco inflicts upon our state is not limited to death and disease. Annual healthcare costs from tobacco use exceed $2.36 billion in Connecticut, including $560 million to Connecticut's Medicaid program. In 2022, the legislature supported the restoration of $12 million annually for tobacco control, the first new appropriation of funds for tobacco control in 7 years. Since then, the first disbursements of $12 million have been approved and allocated following 5 CDC best practice components. They include state and community interventions, mass reach health communication, cessation interventions, surveillance and evaluation, infrastructure administration, and management. ACSCAN applauds these efforts because despite much progress, the current rates of tobacco use remain unacceptable, and more than 2/3 of people who currently smoke indicate that they would still like to quit. Continuity of services and programs is essential, as not everyone reacts or benefits the same way from utilizing the various FDA-approved quit methods. Some take longer to be able to quit. Some react better to some therapies, for example, than others. We are not asking for a new funding source or to create new bureaucracy, only to utilize a portion of that which comes to the state every year for this very purpose. We applaud this committee for making a strong public health statement that not only should funding that follows CDC best practices continue, but be increased to $32 million annually, the minimum level recommended by the CDC. Funding tobacco use prevention and cessation programs that alleviate this burden on our citizens and economy, as well as preventing people from ever starting to use tobacco, is not only consistent with our shared goal of ensuring public health, it is also the only fiscally responsible approach we can take. Providing $32 million in annual continued long-term funding for proven and effective tobacco programs aimed at educating parents and kids, and that reduced tobacco use is critical so that our children can grow up not as the next generation addicted to tobacco, but as the first tobacco-free generation. Thank you for your time.
Thank you very much, Bright, for your advocacy and your very impactful testimony, which I will tell you, Claudio Gualtieri is here in the room to hear. I think you'll appreciate that. Thank you so much, and we look forward to continuing to work together. Before I turn it over to Senator Gordon, I just want to point out something to the members and to the rest of the people testifying. Today's been a day of technical difficulties. We have one more. We are going to have to end the hearing by 10 o'clock because there's a technical issue with YouTube. We usually pause and then reset. We're not going to be able to do that today. So, Senator Gordon, I'll turn it over to you, but I'm just letting everyone know that just mathematically we have a number of people left to testify, so I just want to point that out. Senator Gordon.
Thank you, and Bright, I just want to thank you for the work that you and others continue to do on this. Certainly, we know tobacco contributes to another diseases. Lung cancer remains the #1 killer of people from cancer, just not in Connecticut, but around the country. And before free cigarettes were given out to soldiers in World War I, lung cancer was really not a major cancer in the United States. So I just want to ask a very specific question, and I'll be very quick. You feel that getting this additional money for tobacco prevention and tobacco cessation will not only help people, but ultimately save lives from preventable diseases, just not cancer, but heart disease, lung disease, things like that?
Absolutely. This funding, I think, has proven to be effective in other states that have provided funding over the years. Got a list here: Washington State, Florida, California, Alaska, Maine, even North Dakota have seen tremendous results from long-term and continual funding. And there's no reason to think that something like that can't happen here in Connecticut. It's been a challenge. We have brought in over $2 billion in master settlement funds in 24 years and have spent about only, I think, 2% of that total on tobacco control. And it's an entirely preventable problem, which is what makes this such a frustrating issue, because the cost to the state, both in lives lost as well as healthcare costs, is staggering. And again, it's entirely preventable. And so investing funds like this to provide people with an avenue to be able to quit or to help prevent kids from ever even starting, I think is, as I said, not only a fiscally responsible move, but ethically and morally, it is something that we absolutely have to do.
Thank you, Madam Chair.
Thank you so much. You know, I'd love to talk about this all night, but especially this topic, I think those of you who know me know that. And Bright, thank you so much. We will be continuing this conversation for certain. Next, we are going to go to number 76, Tracy Wodach. Welcome, Tracy.
Good evening. Can everybody hear me?
Yes, we can. Please.
Great. Good evening, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Tracy Wodach. I'm the president and CEO of the Connecticut Association for Health Care at Home. I'm also a registered nurse with more than 40 years experience. Our association represents Connecticut's licensed home health and hospice agencies, along with several homemaker companion agencies. Collectively, our members provide the essential services that allow thousands of Connecticut residents to receive care safely in the setting they overwhelmingly prefer, their own homes. Before I begin my testimony, I apologize for my scratchy voice, hence why I'm not there in person today. But I applaud all of those who have testified tonight, especially regarding the harm reduction spaces. The political process is indeed alive and well. I only wish some of those lives lost, as mentioned tonight, were still alive and well. I'm here today to express strong support for House Bill 5169, which would establish an alert within Connecticut's statewide health information exchange to notify healthcare providers when a patient has a reported history of violence or combative behavior toward a healthcare worker. This bill is critically important because home health and hospice clinicians deliver care in the most unpredictable environment of all, the patient's home. Unlike hospitals or nursing facilities, healthcare workers are often entering homes alone, without immediate security or coworkers nearby. They do this work every day with compassion and professionalism, but they should not be expected to do it without the information necessary to protect themselves. HB 5169 builds on the important work that began with the Home Health Safety Work Group established in 2024. That group recognized the unique risks faced by home-based providers and recommended improvements such as better training, stronger reporting systems, and the use of technology to improve workforce safety. At the time, the idea of a centralized alert system was discussed, but acknowledged that our health information exchange may not be ready for it. A year later, our hope is that the system has advanced and that it's not only possible, but necessary. Right now, home health agencies are forced to screen for safety risks by searching multiple systems, relying on incomplete referral information, and asking direct questions that may not always be answered honestly or thoroughly. Too often, key information about a history of violence is missing, outdated, or simply not shared. That puts our frontline workers at risk. A centralized alert mechanism would allow agencies to make informed decisions and implement appropriate safety plans. This is not about denying care. It's about ensuring care can be delivered safely. One concern we must acknowledge is that the system will only work if incidents are consistently reported and not minimized or kept under the rug. We must build a culture where safety information is shared responsibly and consistently, because protecting patients and protecting healthcare workers must go hand in hand. I want to recognize and support Kim Sandor and Kathy Flaherty. Both of their comments tonight made much sense about making sure that it's timely information and that we're also very cautious about people with dementia or mental health diagnoses and not trying to deny them care, but finding ways to give them care. For all these reasons, the Association for Healthcare at Home strongly supports House Bill 5169. Thank you so much.
Tracy, thank you so much. We hope that you feel better, and we appreciate your advocacy on this issue both tonight and in the long run. You've been doing this for a while, and many people have benefited as a result, so thank you. Next, we have Greg Allard. Greg,
Chair, I have my hand up.
Oh, Senator Marks, thank you. I missed that. I was looking
That's okay.
at the side of the screen, so hang on, Greg. Go ahead, Senator Marks.
Okay, sorry, Greg. Thank you, through you, Chair. Hi, Tracy. I just want to, when you said, you know, we talk about the screenings that we do right now for our home care patients, which was part of the safety bill that we passed, and it is working beautifully. And it might be missing some people, as it missed a patient that I saw who a month later murdered his partner and cut her up and put her in a suitcase and took it to the cemetery. I was there for an hour and a half in his home, and I knew something was wrong. I knew that wasn't the house. I knew my intuition went up and I was nervous, but he had no past record because his past records were in New York City, in New York. So they didn't show up in ours. So yes, we are missing those, but we're also flagging so many that we missed 2 years ago when we didn't do this. So I just want to make sure that if we do this flag in Connie, that the Home Care Association isn't suggesting that then we stop doing the safety checks that we are doing before we go out and see our clients.
No, the safety checks, thank you, Senator Marks. The safety checks that we're doing now would not be answered by doing the red flag alert or the alert in HIE. These are additional checks that we're doing.
Yeah, I just wanted to make sure.
But I do agree with you. Our work group talked extensively about the limiting ability or the limiting information available through the judicial branch because it is just Connecticut and it's not other states. So the situation that you unfortunately faced would not have been picked up with our current processes in place. So it's not foolproof, but it certainly is identifying many more than what we had before.
Yeah. Chair, may I respond?
If you will, briefly, I don't know, Senator Marks, if you heard my remarks.
Oh, I've heard. Yeah, I've been listening all
Yes,
day. I haven't said a word all day. This is the only time I've
Go
talked.
ahead, and you know what? I'll also say thank you for your leadership on this issue as well.
Yeah.
Senator Marks, go ahead.
And I just want to say now we do have the device where when we're walking into that home, I could have said, will you just listen in on this talk? I feel a little anxious. Sometimes you're anxious just by the way the phone call, the initial telephone call goes. So I just want people to know, I'm thank you, Tracy. It really is working and our nurses feel so much safer. And I hope that our occupational therapists and our social workers and everybody else out there gets to have this level of safety. And we have never said no to a client. Believe me, we go to patients' houses that if people saw where we were and what we were doing and how we were treated, they would never believe it. But now we have a security guard with us, an escort with us. And it really, the patient gets much better care because of it. So thank you. That's all I'm going to say, Chair. Thank you for letting me speak.
Thank you. Thank you for that. I think those were important questions and comments. Thank you, Tracy, for being with us.
You're welcome. Have a good evening.
Have you too. Greg, we saw you were here earlier today. It's nice to see you here on Zoom. Please proceed.
All right, thank you. Thank you. Good evening, Senator Anwar and Representative McCarthy-Vahey and members of the Public Health Committee. My name is Greg Allard, and I'm the president of the Connecticut Ambulance Association, and I'm here to support Senate Bill 93 and Connecticut joining the EMS Licensure Interstate Compact. Connecticut's EMS system is under real pressure. Agencies are struggling with recruitment and retention. Volunteer numbers are down. Call volumes are up. EMS needs some practical tools to expand our workforce. The EMS Compact allows qualified EMTs and paramedics licensed in other member states to practice here through a privilege to practice without going through a second full licensure process. There are 25 states in the compact representing more than 450,000 EMS clinicians. That gives Connecticut access to a mobile workforce. It also streamlines recognition for military members, veterans, and their spouses, helping trained professionals integrate quickly into our workforce. This is not just about workforce mobility, it also strengthens Connecticut's position in the Rural Health Transformation Program. The compact requires FBI background checks and participation in the National EMS Coordinated Database that aligns us with national standards and demonstrates serious regulatory oversight. We strongly support the bill, and we hope to work with all parties involved on establishing a firm effective date, ideally a January 1 or July 1 of 2027. A clear date shows commitment to CMS, strengthens our position for competitive federal funding, and gives EMS organizations and providers the certainty needed to prepare. We also support the broader rural health transformation efforts, particularly mobile integrated healthcare programs. MIH allows EMS to deliver rural care in communities more effectively and meets patients where they are. Senate Bill 93 is practical, workforce-focused solution that supports both patient care and federal competitiveness. I respectfully urge you to support the bill and work with we plan to work with stakeholders on timing considerations. Thank you.
Thank you, Greg. And as you probably heard earlier, we do plan to bring those stakeholders together. And I know that we have folks from the governors from the OPM team here as well, listening in to who have heard this conversation, and I expect you will hear from us. Thank you for being here tonight.
Yeah, you're welcome.
Next, we have Tara Knapp. Welcome. Oh, you need to unmute first.
Yep.
There you go.
There we go. Testing. Thank you. All right. Good evening, Chairwoman McCarthy-Vahey, Chairman Anwar, ranking members Claridis, Ditria, and Summers, and members of the committee. My name is Tara Knapp, and I'm the Vice President of External Affairs at Gaylord Specialty Healthcare. Thank you tonight for the opportunity to speak in support of SB 193. The bill is really about something simple: clarity. Right now in Connecticut, long-term acute care hospitals, or LTACs, are classified under the same chronic disease hospital category as inpatient rehab facilities. But Gaylord is not an IRF. We're not a skilled nursing facility, and we're not a traditional acute care hospital. We care for medically complex patients who still require hospital-level treatment, often for weeks. That misclassification creates real challenges. It affects insurance coverage and reimbursement. Patients are sometimes forced to use rehab benefits instead of hospital benefits, which can limit recovery options. Medicare Advantage plans frequently deny authorization because our state classification doesn't align with the federal designation, leading to delays and unnecessary administrative burdens. It also impacts workforce recruitment. We function as a hospital-level provider, but our license doesn't clearly reflect that, which can create confusion for critical care nurses and other clinicians. And perhaps most importantly, it creates confusion for patients and families. Some assume chronic disease hospital means long-term residential care, when in fact, Gaylord is short-term, hospital-based setting focused on recovery from serious injuries or illness. We recognize there may be concerns about removing LTACs entirely from the chronic disease category. So we're proposing a practical solution. Establish a clear LTAC subcategory within the existing framework. This would modernize Connecticut's structure, align with federal recognition, and create needed clarity without adding administrative burden. This isn't about expanding regulation. It's about refining it to reflect the care that's actually being delivered. I thank you for your consideration and for your support of SB 193.
Thank you, Tara, for your testimony and explaining that so well to everyone. Were you able to hear the commissioner's testimony earlier today?
I didn't hear the commissioners. I've seen the written testimony.
And do you have any brief comments in response to that?
Well, I think to me, there was a little bit of confusion in that. She had mentioned that, hospitals were primarily engaged in providing inpatient services to Medicare beneficiaries. But while this designation federally is a CMS designation, Gaylord and LTACs are not primarily providing services to Medicare beneficiaries. We provide services to Medicaid, to individuals with private insurance, and even private pay. To us, it's about the level of care, that there is a higher medical necessity and oversight at the LTAC level that isn't present at the IRF level. And so that was a little bit, little unfamiliar to me as to that. And I realize that, there is concern about trying to manage any regulatory work, but I also know that that is why we are trying to suggest a subcategory, because it really comes down to patient acuity.
Thank you. Thank you for that, Senator Anwar.
Thank you so much, Ms. Knapp, for your testimony. I just wanted to share with you, I think we had a pretty focused conversation with the commissioner. And then I know we've had a meeting about a session ago as well. And the whole thought was that we'd be in a better place. But I think the DPH is exactly where we had left them last time. But we also recognize, because we have seen the patients and the severity of the healthcare issues with the patients that they have. There's ventilator patients. There are patients with traumatic brain injury who are not in a rehab facility condition. They are in a long-term acute care facility. And that's what was recognized at the federal level, and that's why this category is there. So I have a feeling we'll need to have a sit-down conversation again and perhaps see if there is a way to literally solve this issue, because every other state can do this. I'm just intrigued that why is it so tricky for Connecticut? So we'll be working with you to address this, because we need you healthy and well as an institution, because you're providing health to some of the most complex patients in our state. So just wanted to make that statement. Thank you.
Thank you, Senator, and we appreciate your comments, and we look forward to working with you.
Thank you so much. We look forward to working together, definitely. Next, I believe number 79, Kirsten Sherry. I do not believe she is here now. That means we are going to Rob Miller. Mr. Miller, thank you for your patience today. Welcome. Please proceed.
Can everybody hear me okay?
Yes, we can.
Good evening, Public Health Committee Co-Chairs Anwar and McCarthy Vahey, ranking members and distinguished members of the committee. My name is Rob Miller, Director of Health of the Eastern Highlands Health District, representing the Connecticut Associations of Directors of Health. On behalf of CADH, thank you for raising House Bill 5167 and for the opportunity to testify to support this important bill. CADH is grateful to the committee for recognizing the challenges local health departments have faced since statutory changes enacted in 2022. Those changes have created a barrier to the timely sharing of important public health information and significant uncertainty in the application of Connecticut's confidentiality statutes. This bill proposes two important changes. It removes the need to obtain commissioner approval prior to releasing certain well water data, and it establishes clear and direct access to that data for neighboring property owners. We believe 5167 represents a thoughtful and necessary step toward restoring transparency and workability in the statute. The removal of the commissioner's approval requirement is both practical and appropriate. Eliminating the step reduces unnecessary administrative red tape, improves timely release of critical information, and allows local officials to respond more efficiently to community concerns. In addition, the approval requirement is redundant. Local health departments already operate under established authority governing the collection and disclosure of public health information. Requiring an additional layer of approval creates delay without adding meaningful oversight. 5167 appropriately restores decision-making at the local level, where directors are already charged with protecting their communities. Groundwater is a shared resource. Contamination does not stop at the property lines. When pollutants enter an aquifer, they can impact neighboring wells. This bill proposes establishing unfettered access to relevant groundwater data for neighbors. This ensures those neighbors can make informed decisions about testing their own wells and take reasonable steps to protect their families. CADH strongly supports this transparency. Property owners should not be permitted to keep their contamination a secret when it poses a risk to surrounding homes and families. At this time, local health departments must continue to operate within a clear legal framework. Both the current and proposed statutes established local health departments as the gatekeeper of this data at the local level. Some uncertainty remains regarding how the statutory language applies, which continues to place directors in the difficult position of balancing transparency and privacy without consistent statewide guidance. Additional clarifying language would further reduce legal exposure, promote uniform statewide implementation, and strengthen public trust. CADH stands ready to work with the committee and the State Health Department to determine what appropriate clarifications may be needed. In closing, CADH respectfully urges the committee to support 5167. Thank you very much for this opportunity. I know it's late, but I'd be glad to answer any questions.
Mr. Miller, thank you so much. I appreciate you hanging in here because this is an issue we haven't really discussed today, although some of us have discussed this quite a bit. You'll hear from Senator Gordon in just a moment. Just to clarify what you said, that you're supportive of the bill, but you do have some suggestions, some clarifying language that you'd like to see. Is that correct?
There are still some uncertainties in the interpretation and the application of the statute, even with this updated language. Exactly what that language would look like, I think we need to discuss it because there are various areas of uncertainty related to the disposition of historic data, potential conflicts with freedom of information, what to do with data that's reported to us by third parties, because the difference between this data and, say, healthcare data is that many parties get access to this data, only local public health and the State Health Department are bound by the confidentiality statutes, despite all this data being available to many other entities. And so how do we deal with those particular pieces of data in our routine workflows as a local health department?
Thank you. That was an excellent answer to help us understand just how complex this issue is. Senator Gordon.
Thank you, Madam Chair. And I just want to make two quick statements. One is I want to thank the committee chairs for working with me and others on this issue. I think the wording changes that are in this bill aren't many, but they're extremely important. For example, a town I represent, Tallinn, that has a very bad salt contamination in the public water supply or water supply for people's wells in parts of town. This will make a big help in how to deal with neighborhoods affected and other potential neighborhoods. So I appreciate the work on this. And I just want to thank you, Mr. Miller, for I know you've been working with me and others for a while to see what we could do to address this. And I think this bill does get to the crux of the issue. And I look forward to seeing what we can do moving forward. Thank you.
Thank you, Senator Gordon. And there have you and a number of your colleagues, our colleagues on both sides of the aisle, have really advocated for this. And we know that there will be more conversation on this moving forward. Thank you so much. Thank you. Next, we have John Brady. Welcome.
Good evening, Representative McCarthy-Vahey, Senator Anwar, Senator Summers, Representative Clarence Dietra, and members of the Public Health Committee. My name is John Brady. I am a registered nurse, and I am the Executive Vice President of AFT Connecticut, a union of more than 30,000 members in healthcare, public service, and education. I've submitted testimony on 3 bills today, and I will summarize. We support HB 5165, which would possibly lead to the appointment of a receiver for financially distressed hospitals. This seems to be a prudent step that could prevent that hospital from undergoing further decline and entering bankruptcy. We also support HB 5169, which promotes a statewide exchange of information about violent behavior. Healthcare workers face 5 times the risk of assault as compared to other industries. We must protect our workforce, both because it is the right thing to do and because we already face a crisis of nurses and others who are leaving their professions due to workplace violence and short staffing. As far as SB 196, we support the goal of preventing another crisis that Prospect has caused in Connecticut and other states, and Stewart has caused in Massachusetts. However, we must oppose 196 in its current form. We feel that the sale leaseback transactions in healthcare only exacerbate a problem. One could argue that this bill in its current form makes it easier to enter into a sale leaseback agreement. Section 2 of the bill attempts to limit the influence of private equity over the operation of the hospital and providers. While this is an important and worthy goal, it lacks any enforcement mechanism and does not go far enough. Now is the time for a strong law to prevent the repeat of Prospect and Stewart crisis that has hit Connecticut, Massachusetts, and other states. While I myself am not a financial expert, we can provide such experts through our national union, AFT, and I would be happy to do so, to make this bill something that can truly make a difference. Thank you all for listening to me and giving me the time to speak.
Mr. Brady, thank you so much for your advocacy on so many issues that have come before this committee and your partnership, and look forward to ongoing conversation with you. Senator Anwar to be followed by Senator Gordon.
And Representative Hoffman too. Thank you, John, for your testimony, and thank you for being with us for quite some time and waiting. I did not have a chance to talk to you before about Senate Bill 195. I know you've spoken about this. Are you able to comment on this?
195?
Overdose prevention, and then.
Yes, speaking personally, because we have not discussed this at AFT, as you know, and as many of you know, I lost my son to an overdose in 2019. He was 42 years old. He had spent 20 years fighting heroin addiction. He died in his living room, and he was found by his family. So I've listened to this debate for 3 sessions now, I think, and I just think it sounds like a good idea that we should try this. They've tried it in other states, and it seems to have saved lives. That the statistics show that. So, you know, personally, I would encourage that we pass this bill.
Thank you, John. Sorry, didn't mean to put you on a spot, but I actually ended up doing that. So sorry. Thank you for your.
That's okay. That's okay, Senator.
Thank you. Madam Co-Chair.
Thank you, Senator Anwar, and thank you, Mr. Brady. Senator Gordon.
Thank you, Madam Chair. I just want to thank you, Mr. Brady, and your colleagues at AFT Connecticut. I agree with your positions relative to the hospitals, and that we do need to do something strong given what's gone on, and that we can't at all have another situation with hospitals in jeopardy, patients in jeopardy, getting care when they need it, where they need it, and also potentially losing thousands and thousands of good healthcare jobs, which would be devastating not just to the people who lose the jobs, to their families. So I'm proud to work with you and others on this issue and continue to. And I agree with the testimony you've said and the testimony that's been provided in writing relative to the support of 5165 and the opposition to some of the concerning issues right now with 196. So just one quick question is, I believe you said that the positions of AFT Connecticut you feel are strong positions in order to protect these things, and I just want to make certain that I'm understanding as well that you're speaking for patient care, but also for the healthcare employees in their jobs?
On 196, we're speaking mostly for the people of Connecticut. As you know, doctor, when we leave the hospital or the office or wherever, we don't stop being providers. It's our duty to speak out for others. You know, and the same thing on so on 196, it's more along that line. On the other ones, it's also that. On the exchange of information, of course, there's a safety issue there, which is, of course, it also affects our members greatly.
Thank you, and I appreciate that and look forward to the continued advocacy that you and your colleagues are doing and will do. Thank you, Madam Chair.
Thank you, Senator Gordon. Representative Dauphiné.
Thank you, Madam Chair. And I just wanted to thank John. He's my constituent in Sterling, and he's always very faithful about being here and advocating for those things he thinks are very important in healthcare. And I wanted to just reiterate my sympathies to you with regard to your son. Thank you for being here today, John.
Thank you, Representative.
Thank you, Representative. John, we will see you soon, hopefully after some good rest. On your part, not ours. No.
Oh, both. Thank you.
Oh, thank you. And our last, I always just want to say witness. Forgive me, everyone. Lauren Baker, are you here? I see that you are a panelist. There you are. Welcome.
Hi, can you see me?
Yes, we can see and hear you. Please.
Okay, perfect. Good evening, everyone. I was also present at the hearing today, but needed to leave due to some work obligations. I want to thank co-chairs Senator Anwar and Representative McCarthy Vahey, along with the distinguished members of the Public Health Committee, for the opportunity to speak today on Senate Bill 195. My name's Lauren Baker. I am a licensed professional counselor specializing in addiction and trauma, and I have been in recovery for over 7 years now myself. I've worked with individuals and families affected by addiction and overdose across multiple levels of care. And after listening to the testimonies today, I want to speak both from my clinical experience, but more importantly, from my own lived experience. I think one of the most common misconceptions I hear about addiction is that it's a pleasure-seeking decision when it's actually an attempt to solve a problem, to soothe pain, suffering, trauma, disconnection, and mitigate underlying mental health conditions. When we respond only with punishment, we deepen the very conditions that drive the behavior. Consequences did not stop my substance use. They only intensified it. Shame, fear, and isolation made me use more, not less. Each punishment increased the urge to escape and to find relief, which is exactly what addiction does. I did not enter recovery until I was ready, and that readiness could not have happened without the encouragement, hope, and support provided by others who got sober before me. Most overdose deaths happen alone. We've heard a lot about that. And it's not because people want isolation, but because of shame and fear. People hide their drug use in bathrooms and cars, anywhere out of sight. And when overdose happens alone, survival depends entirely on chance. I'm a clinician, not a researcher. Debating individual statistics is beyond my scope of practice. However, we've listened to more qualified professionals cite real-world evidence from both outside and inside the U.S. demonstrating reductions in overdose deaths, STI transmission, incarceration, and public drug use as a direct result of harm reduction efforts. Harm reduction does not remove recovery. It makes recovery possible by reducing shame, increasing trust, and offering real human connection. I have lost countless people to overdose. I've spent 3 days at my best friend's bedside in the ICU before doctors confirmed he had no brain activity. I've held his hand as life support was removed. I am tired of attending funerals. I'm tired of having to tell stories so people understand addiction is not a moral failure or a choice. No child grows up wanting to become addicted. These are human beings trying to survive pain. And right now, their survival depends on luck. Overdose prevention centers replace luck with care. This bill asks a very simple question. Should survival depend on chance or on a system designed to save lives? Overdose prevention centers do not ask whether someone is ready to recover today. They keep the person alive today so recovery can still exist tomorrow. Thank you for your time and your patience in listening to all of our testimonies today. And with that, I think that's the end of the night. So.
Thank you very much. I'll turn it over to Senator Anwar before I end things.
Lauren, thank you so much for your testimony, and thank you for bringing the human part and the suffering of everybody involved back to the forefront of what we are trying to do is to prevent this, and how relatively easy it is to be able to prevent this because others have shown it. So I just want to thank you. You waited the entire day to be witness of and then bear witness for the people that you've cared for, and I just can't thank you enough for that. I hope we do the right thing this year. Thank you.
Thank you, Lauren. I'll echo Senator Anwar's thanks and also share condolences as well for all that you've been through. I'm glad that you're walking with others through this journey. Have a good rest of your night. So with that, I am just, before we close this public hearing, logistically, it's going to take a few minutes before we transition back to our committee meeting. I think we're probably going to need at least 15 minutes to just make the transition and the team behind the scenes to make sure everything is set up. So it's, let's see, we'll say 9:50, and Beverly, does that work? Are you able to come on screen or just indicate if that works? I think we're going to go ahead and we'll say 9:50, and what I'm going to ask committee members to do is to use the link from the earlier committee meeting. That's where we will be meeting. Okay, with that, we are closing our public hearing. Do you think we have to remind them about coming back? Committee Kai has been reminding people on text, but it's probably, if you have an email that we can send out to everybody, the whole committee, does that work? Just to let people, yeah. Let me see. Even just to reply all to something else that you have said, that way it just goes out.
Okay, you don't think they're coming back?
No, they've been
I
gone
can count
forever.
on you. Oh, they have, great. That's a reasonable thought. Yeah, I took those off. Okay, I'll go and get the offset.
I already did that.
Oh,
I did it in